beneficial effect. And then a symbiotic is just a physical combination of a pre and a probiotic. Sometimes they're just put together randomly, but sometimes they're put together as a targeted approach to potentially yield a beneficial metabolite. So doing therapeutic targeting for alcoholic-associated liver disease, my lab, we've been studying this for almost 12 years now, looking at butyrate. So targeting butyrate that I already showed you is depleted during alcohol consumption. And is there a way to restore these butyrate levels to help mitigate the alcoholic gut-liver injury? And we've studied this in a number of animal models of alcohol-associated liver disease, where we provide mice with acute or chronic alcohol, or a combination of chronic binge alcohol, which really that model replicates alcoholic hepatitis. In all of these models, we've actually been shown, and these are just images of several papers that we've published, that the butyrate supplementation has been able to protect against gut barrier disruption, and as a consequence of that, been able to mitigate alcohol-induced liver injuries, particularly the hepatic steatosis that occurs in this model, and liver inflammation. Now, looking at human studies and trying to see, or just looking at probiotics as a means to mitigate. So previously, those slides we were targeting and providing the beneficial metabolite of the gut microbiota. Here is targeting the microbiota itself. And so there's been other mouse models where they've looked at Lactobacillus rhamnosus GG or Akkermansia muciniphila, or we've been studying Faecalibacteria praslitzi. And in these mouse models, again, they've shown benefit protecting the gut barrier, liver and systemic inflammation, and the hepatic steatosis. There are not, unfortunately, there aren't to date many human studies that have been conducted. And listed here, I know this is a busy slide, but here's just a few studies that have been studied in humans looking at intervention of different types of probiotics that have been provided. And again, I want to point out the different probiotics that were utilized. So in this paper, they used Bifidobacterium bifidum and Lactobacillus plantarum, and this is the strain specificity. And here they were able to show reduction in liver enzymes and also beneficial increase in lactobacillus and bifidobacteria in patients that received the probiotic. Here's another study that looked at Lactobacillus casei shirota. And again, they were able to show improvement in neutrophil phagocytic capacity in individuals compared to baseline. And then here's another one with a spore-forming Bacillus subtilis, and again, here they were able to show improvement in liver function, systemic inflammation, and endotoxemia in the individuals that had the probiotic. Now, fecal microbiota transplant has also been studied in alcohol-associated liver disease. For individuals who were not candidates for steroid therapy, which is the main therapy, there aren't very good therapies for alcohol-associated liver disease. So they did fecal microbiota transplant in these individuals. And what they found is that those that did receive the FMT did have improved survival compared with historical controls in this study. And they also followed in this study survival at 3 months, and the follow-up was best in the patients that received the FMT. And what they also found is that there were not an increase in infections. And this was it has always been a concern, particularly with alcohol-associated liver disease and FMT, that it would induce infection. Now, looking at targeting for NAFLD, again, there's more studies that have been done with probiotics for NAFLD. So instead of looking at individual studies, this is a nice meta-analysis that I found that was published in 2019. This included randomized controlled trials up until 2018, about 780 patients that were had NAFLD. And the intervention for these individuals were prebiotics, probiotics, symbiotics, or particularly lactobacillus, bifidobacterium, streptococcus, or combinations. And the controlled groups were either placebo or they didn't receive any treatment at all. The primary outcome that they were looking for in these studies was a change in hepatic steatosis that was graded by ultrasound. And these are the list of all the secondary outcomes that were analyzed. They did perform subgroup analysis based on the intervention type to further assess overall effects. What they found, this is the forest plot, that 4 studies were reported changes on hepatic steatosis based on the ultrasound studies. And here you can see in these 4 different trials that the individuals that received the probiotic had a beneficial effect on normalization rate of the fatty liver compared to the control. And what's interesting and beneficial, which is unlike in most probiotic studies, is that these 4 studies were very homogeneous. Most of the probiotic studies are very heterogeneous. Just to summarize the secondary outcomes that they looked at, overall looking at them, for improvement were found for the liver enzymes. You can see the number of studies that showed this. Overall, serum triglyceride levels were found to be improved. TNF-alpha levels, the HOMA-IR was improved, and liver stiffness was also shown in 3 studies. What's interesting is they didn't find in any of the studies any differences between probiotic versus control in individuals for their BMI, waist circumference, fasting blood glucose, or blood HDL levels. So what this is really showing is that the probiotic or other intervention improved indices that were associated with NAFLD, but not necessarily indices that are associated with other aspects of metabolic syndrome. So just to summarize, there's a lot of unanswered questions. So this is just a field that's in the beginning, looking at ways to target the microbiota as a means to mitigate these 2 liver injuries. And so I think future direction should look at the role of the gut microbiota to help determine why some individuals develop certain phenotypes of these liver failures and others are not affected. And also to determine the point of the liver failure where some intervention may be beneficial. My hypothesis is that it's early. So if you can catch the individuals when it's just steatosis, but it may be too late at the stages of cirrhosis and further. And to look at functional changes in the microbiota that could be a future target of the gut microbiota-directed therapies. So the probiotics that were provided before were non-targeted. They were just whatever was available on the shelf to be able to provide to the patients. But as technology is advancing, can we come up with bioengineered, perhaps, probiotics that can target particular microbes that are disrupted, or to target these beneficial metabolites that we know are depleted, and to help mitigate some of this pathology? And definitely, larger and long-term clinical trials are needed to focus on how this microbial intervention may be able to be translated into clinical practice. So I just want to end by acknowledging people in my lab that have really contributed to this work that I've presented from my lab, and my collaborators, and of course my funding source. And here we're wearing our team uniform, which is a t-shirt that you can buy, another commercial. You can buy this t-shirt from Aspen, and it says that nutrition is a science, not an opinion. Thank you so much.
Thank you, Dr. Casey, for that wonderful, comprehensive lecture. I think we'll take the questions at the end of the 4 talks, and therefore I'd like to call upon Dr. Robert Martindale for the next lecture. He's from the Oregon Health and Science University, and his area of interest is primarily in surgical and critical care nutrition.
Wrong. 820. That looks like it. This is on, sir.
Great. Perfect. Okay. Thank you. I don't know if I need this step, but it's okay. Well, thank you very much again for the invitation to come back to Hyderabad. I've been here a couple of times, and every time it seems like the city is growing rapidly. There's more tall buildings and more people and more traffic. Reminds me of Los Angeles. So I think that it's been a wonderful conference so far, seeing old friends and meeting new ones. So today I'm going to follow up on Gail's talk and really hit a few of the topics she already did, and then talk about it on a global perspective in the ICU. Not necessarily specific liver disease, but so take the whole picture in the ICU. So if we look at that, we have to say to ourselves, does modulating then the microbiome in the ICU setting, can we make a difference? Do we see the outcome difference, as Gail showed us nicely with acute alcoholic liver disease? So, the microbiome she talked about really was coined by Dr. Lederberg, a PhD winner, a PhD recipient, Nobel Prize recipient in 2005 for his work in microbiome, similar studies on macrophage function, transferred DNA. So, but he coined that where he said all of that DNA should be counted in the human DNA when we start talking about the system, because it's in us and on us, all over us at all times. It changes. The question we have to ask ourselves is, why has nutrition community neglected the microbiome? And this paper was written by McClave and I in 2019, so it means we wrote it in 2018 probably, by the time it got published 2019. So 4 years ago. Well, in the last 3 or 4 years, we've seen that the nutrition community is now accepting it. In 2015, 2016, you would have thought I was talking about going to Mars when they started talking about how we have to manipulate the microbiome, and the future of nutrition is going to be manipulating it. And they didn't want to listen about it, because I get a couple things from this last line here. The amount of interaction and crosstalk between the microbiome, similar to what Gail has just shown us, is very confusing. You've got, a trillion bacteria, and which ones, and how do you manipulate them, and the names are hard to pronounce. You've got all those problems, and you say, what am I going to do with this? This is too confusing. Let me go back to how much protein, how much carbohydrate, and those sort of issues. That's much simpler to look at 3 or 4 macronutrients, or maybe 20 micronutrients, than it is a billion bacteria. So I think that's partly why, and it's difficult, there's no question. If we look at the microbiome concept, we started seeing about 2010, 2011, people start talking more and more about it. And then now it is part of the mainstream. But we have to say we still don't understand it. But we need to think of the microbiome as another organ. If you think about that, what do organs do for us? Like the liver, cleans the metabolic products, protects what goes up and down glucose. But what is the GI? What is the function of the microbiome? This is the gut bacteria in total. Metabolizes drugs, produces metabolites, vitamin K, short-chain fatty acids, as Gail talked about, butyrate. It produces amino acids. Up to 7 to 10% of your total leucine, the most anabolic amino acid we have, comes from the gut bacteria. It stimulates hormone secretion. It maintains mucosal barrier. It modifies and modulates immune function. It is an organ, and we need to think of it like we would the kidney or the liver or the brain even. And it is so powerful, we have to start thinking about it. Because if we don't, what happens? Diversity starts dropping, and the number of the variety of bacteria drops. We lose immune function. We lose the integrity of the brush border. And then we start seeing bacteria becoming invasive. We know that an ICU admission is an assault on this microbiome. What do? This is iatrogenic torture to these bacteria, right? Broad spectrum antibiotics. We kill them off. We know that broad spectrum antibiotics given to somebody within 24 hours, their species in their colon goes from about 800 to 900 species in a Western diet. If you go to somewhere deep in the Amazon jungle, those people have about 4,000. We have about 1,000 species. They have about 4,000 species. What happens with 24 hours of antibiotics? We go down to about 300 species. So we dramatically drop the diversity. Oral antiseptics, we all use them on ventilators, right? We give them a HibaCleanse mouthwash twice a day. It's part of the routine to prevent ventilator-associated pneumonia. PPI, proton pump inhibitors, lower the acid. As Gail already mentioned, we lose the acidic barrier that protects us in many cases. Vasopressors alter the CO2 and the PO2 in the GI tract, altering the pH along the mucosa border, affects the microbiome. Opioids decreases motility, affects the microbiome. Decrease in luminal nutrient delivery Giving TPN significantly alters it. Great work done out of Detroit has shown us that the microbiome for diversity drops within 24 hours of starting parenteral nutrition. So we do this to our patients. So the question is, what can we do to reverse this? Well, this was a nice study by Miriam Collins group showing that if you received an antibiotic in the last 6 months and then were admitted to the ICU, look at the difference in the mortality. Let me see. You can see the black here is the mortality, and the white is without antibiotics. The black is with antibiotics in the last 6 months. So if you were on antibiotics and get admitted to the ICU, you almost double your risk of mortality because you've altered the microbiome with that antibiotic you may have received up to 6 months ago. Makes you much more susceptible, and there's a lot of cofactors involved there, but it makes you much more susceptible to the problem. Well, John Alverdi's group out of Chicago, Illinois, has shown us that we may, in fact, change the individual bacteria. Not that we give different bacteria, but we alter the bacteria that are there. So-called changing of a microbiome to a pathobiome. The bacteria, which were at one time not pathogenic, have now become pathogenic. And that shift generally happens. What happens in the ICU? Someone comes in, they get readmitted, take to the operating room, come back, hypotension, go back to the operating room, go to radiology, get intervention, get more antibiotics. All these things change that microbiome. As you know, the commensal microbiome, as Gail talked about, start to decrease. The opportunistic infective bacteria, proteobacteria, go up. The Firmicutes and Bacteroides go down, as Gail mentioned. Same thing happens in the ICU. Look at this slide here. On the left side, you'll see this is serum from a patient who just had surgery on opioids given to the Pseudomonas bacteria. On the right side, same bacteria growing at the same time, just given saline, basically placebo. As you can see, the red comes in. That red is an invasive receptor on the Pseudomonas membrane, which allows it to penetrate the mucosa. Remember, for a bacteria to become invasive, it has to be able to attach to the mucosa and then penetrate. And that's exactly what happens. Just exposing it to the serum from a patient who just had surgery, as opposed to a patient who doesn't have surgery. Very interesting data. So a good example here too is this is a mouse model, and granted we don't operate on mice, but it gives us proof of concept. What they did here was took mice fed a Western diet, typical hamburger type diet, okay? They give them antibiotics and then undergo a splenectomy. Animals getting rat chow versus this Western diet, doing everything the same, doing a splenectomy, and what happens? The animals who got the Western diet show more drug-resistant pathobiomes. So just a week. So then they had to say to ourselves, what happened here? What should we do here? What can we do? What happened? Well, we know we need to maintain homeostasis. We need to maintain gut perfusion. And we try to luminal feed at least a small subset. You don't have to give all the calories, just enough to maintain the microbiome. Well, for a long time, there was European data and Western US data saying maybe we should sterilize the gut. I was part of that era. 20 years ago, we gave broad spectrum antibiotics, antifungal agents, thinking, okay, we saw sepsis, we can sterilize the gut. You can't sterilize the gut. We learned that doesn't work. So now, as Gail mentioned, we got to ask the question. Prebiotics, probiotics, synbiotics. Gail showed us those definitions. We won't go into that. But she didn't mention postbiotics. You say, wait a minute. I've heard about synbiotics. What are postbiotics? Postbiotics maybe can answer this question, as Gail mentioned, by giving live bacteria. I get a lot of resistance in my hospital about giving live bacteria. To the sickest patients in the hospital, they argue we shouldn't be giving them bacteria. Although there's no data to say we shouldn't, but they say we shouldn't be giving. So we can say maybe if we can take metabolites, just some sort of metabolites from the exudate or the lysate or some way to extract them from live bacteria and give that to them, it may work. And that data is beginning to look very good. Maybe we can just give a product, a metabolite of those bacteria, and not have to give the live bacteria. Well, do we have any data? Do we have any data that says modulating the microbiome works? Well, we do. We know that enhancing the immune response. How does it work? Well, in elderly population, they gave half the group probiotics before their vaccine for the virus or for a flu virus every year, and the other group got a placebo. Half got probiotics, half got placebo, and they showed that the people who got probiotic had a better immune response to the vaccine when it was given. Very good data. Outpatient, not ICU, but good data. We know short-chain fatty acid production for the myriad of beneficial, enhances function of white cells, anti-inflammatory, decreases neoplasia, and many other factors. We have decreased sick days from work. In a factory in Lund, Sweden, they gave half the people a straw with probiotics on the inside the straw. So if they use that straw, they got 300,000 bacteria. Versus people who got a placebo straw. They didn't know which was which. In a nice controlled study, they showed that the people in that factory working and once a day during their break used a straw with bacteria coating the inside, decreased their work absent days by 40% over a 6-month period. Just taking daily probiotics. Again, not ICU. We also have decreased symptoms of upper respiratory tract infections. We have, what about gestational diabetes? This is one that was very hard for me to understand the mechanism. We now have 36 papers in gestational diabetes showing that women who take probiotics during their pregnancy decrease their risk of gestational diabetes. Again, a systemic inflammatory state. Now, when you get down to necrotizing enterocolitis in children, we can show the data. It's a little gray in some areas, but most data is positive. C. diff. It looks like prevention is better than treatment. And where we get confused is when we see the headlines of papers saying probiotics make no difference in C. diff. Because we didn't give it prevention, we gave it as treatment. Treatment doesn't work so well once you've already got the disease. Ventilator-associated pneumonia, about 85% of the data shows it's beneficial, 15% show no difference. The good news here, no harm, but most of the papers showing beneficial. Post-op infections dramatically decreased. Well, here's probably the most dramatic paper I'll show you today. Published in Nature, probably the best. I've never had a paper in Nature. Probably the best paper I've seen ever in this. This is from rural India. This is the NIH-funded National Institute of Health, U.S. National Institute of Health, with very strict criteria for sepsis. They took healthy children, 4,500 infants, greater than 2,000 grams, 35-week gestation, so healthy birth, normal births, and gave them, using WHO criteria for sepsis, this is funded by NIH, the Fogarty Fund, 42% reduction in sepsis, 1 week of treatment costs $1. 42% decrease in septic risk, 1 week for $1, becomes possible to give globally. Amazing difference. Been repeated now, showing similar data. What about, we're all dealing with the pandemic? What about that? This is a prospective, randomized, quadruple-blinded, placebo-controlled trial. 300 patients. What they show, probiotics in this COVID situation, ICASE, IgM, IgG, and reduced nasopharyngeal lung viral loads and reduced symptoms. Probiotics and COVID-19. And there's a myriad of other ongoing trials, C. diff, ventilator-associated pneumonia, et cetera, et cetera. Well, here's one just recently published. It showed no benefit. So I find it hard to understand because I see so many positive. And then we see a big paper by a very good group, Dr. Cook's group in Canada. Look at the numbers. In Canada, USA, and Saudi Arabia, 2,600 randomized people with the lactobacillus rhamnosus, one of our best probiotics we know, giving 1 billion twice a day, probably not enough. Most people would say 10 to 20 billion is somewhere you need. And they looked at ventilator-associated pneumonia, no difference in any outcome parameter. So what do we do with this? I'm not sure, but I think maybe the bacteria content, maybe the timing, maybe they had antibiotics before they got to the ICU. I don't know, but we have to look into that to ask the question, what happened here? When we look at this randomized, a meta-analysis of the randomized clinical trial, Paul Wishmeyer, who will be here later today, shows 30 trials, 3,000 patients, decreased infections, decreased ventilator-associated pneumonia. So the data is mixed. I'll tell you, it's a little bit confusing out there. So maybe it's the timing. Maybe we didn't give it at the right time. So what should we do there? Well, look at this. When you give it pre-op, this is, I'm a surgeon. I routinely, in all of my patients, give pre-op probiotics. Look what they showed here. Pre and perioperative probiotics, patients under major abdominal surgery. Look at that number. 34 randomized clinical trials, 2,700 patients, and look at the P0, P-values of those. Significant decrease in infections, significant, you can see that unbelievable P-value. Huge numbers there. So Synbiotics is better than probiotics alone when you get both the pre and probiotic. What about C. diff? You can see the first big randomized double-blind trial for C. diff, published in British Medical Journal 2007, showed a very good response. Followed by in the Annals of Internal Medicine, the best internal medicine journals, what they tell me anyway. I don't read those journals too much. Meta-analysis of 28 studies, 3,800 patients, 2012, benefit. Again, gastroenterology, very well done paper. 6,000 patients benefit in C. diff. Again, in the 2018, 60% decrease in C. diff in that paper in the big journal there. And again, C. diff bundles, do they work? This is our work, actually, where we started a C. diff bundle for every trauma ICU admission, and we showed we could decrease the incidence of C. diff from 11 per 1,000 admissions to 4.8. We cut our C. diff in our hospital down by 50% by giving prophylactic whenever that antibiotics getting in the ICU, number of receiving, you can see, went from 2.2 to 0.7. Significant change. The timing may be the key. Well, Gail mentioned prebiotics. Remember butyrate, milk sugars. We wonder, why would breast milk have 15% of the sugar in breast milk not available to the baby for absorption? That's 15% of the total energy in breast milk is not available to the child. It's because it's available for the microbiome to make the perfect microbiome population to prevent infectious diarrhea. Still, globally, the number one killer of children under 6 months old, globally, is infectious diarrhea. So if the breast milk is made and producing milk sugars, which produce an ideal microbiome population to prevent that, that's the key to that. So it's worth the 15% of the energy the child loses because it protects it from infectious diarrhea. Again, that's what we see. Very nice. Fermented products, basically. Remember, that paper out of Nature gave fructooligosaccharides, a fermentable oligosaccharide in that case. But even the non-fermentable ones have been shown in animal models to make a difference. Non-fermentable fibers also tend to benefit. So-called the unprocessed diet, we see the difference there. Increased survival. So basically what's happening here? We're eating processed foods, like 80% of the calories in most people in the Western United States, 70 to 80% of the calories come from processed food. We're wiping out our normal flora by eating huge amounts of processed food. And then we see changes in the Tregs, increased the whole cascade of events giving us more inflammatory process. And we know that. Here's another one. A low-fat, high-fiber diet actually improves anastomotic strength when they operate and sew the bowel back together. And you say, well, that's a mouse model. So a short course of high-fiber diet before surgery in these mice could protect their anastomosis, decrease the leaks and breaking down. You go, I don't operate on mice. I don't really care what happens to mice. Give me a break. Look at this. Now we've shown it in colorectal cancer in humans. The same thing. All of my patients now undergo, and all of my colorectal surgeons, we have a protocol, they all get a high-fiber diet for 2 weeks prior to surgery to try to get away from this concept of this decreasing this processed food. We want to get away from that processed food. Give them a high-fiber diet prior to surgery. It protects their anastomosis. Now there are problems. Problems with the probiotics. We know that depending on the species, some will survive, some won't. Right? Lactobacillus acidophilus only about 1 to 3% makes it to the ileocecal valve to get to the colon, if we're looking for the action in the colon. Lactobacillus plantarum, about 90% makes it to the ileocecal valve. So we really need, as Gail mentioned, maybe we should focus and try to figure out which ones give us the benefit we want. Lactobacillus GG is a subspecies of rhamnosus. We can't even populate that. We can give it to the people that generally increase their numbers acutely, but when they quit taking it, it drops right back down. So we know that processing alters it. So what about the risk? Like this little mouse here, he's prepared to go for that cheese, but is he really safe? Okay, so we think about that. There's 400 clinical trials in the last 15 years that they looked at risk and basically showed they're safe. Probiotics are safe. There's no big risk. There's a lot of hype about it. Like, for example, just published 2 months ago at the American College of Chest Physicians, headline news: probiotics increase bacteremia in ICU population. I thought, oh, great. Now what do we got? I got to figure this out. So you pull that paper, you pull the data, and you look at it, and basically it went from 0.03 to 0.02 out of 25,000 patients from administrative database. Remember, they didn't look at risk, they just looked at administrative database. And when you dig through that data, what do you find? The only people at risk are those who've got powdered probiotics. We know that powdered probiotics, if they're spore-forming bacteria, allow fungus, like Saccharomyces boulardii, which the CDC actually said should not be used in ICUs or in a hospital setting because it's a spore former and you aerosolize it when you open the sachet. Should not be. It goes up to 30 feet, 10 yards. So again, we know that. So it's really, this paper got a lot of headlines, but really meant nothing for us because we don't use probiotics that are powdered. Also, we know that a lot of trials don't report their data, don't report their negative data. So we have to be careful. Adverse events are not well reported. This is a nice paper in Annals of Internal Medicine about that. Well, where do we see the benefit in the last couple of minutes here? These are the bacteria we've shown huge doses, huge benefits. The ones that have the most data: rhamnosus, Bifidobacterium B12, KCI, Acidophilus, Salivarius, etc. Those are the bacteria which we have good, solid data for safety and functional ability. So what do we remember? Efficacy, we've got to look at. Most studies report positive results, don't talk much about the adverse events. So we've got to be better there. Safety looks good. I can tell you, I've been following this for 25 years now. Mechanisms, animal models, we can show proof of concept. We can't do that very well in the human models. There's too much variation in the severity of illness, in the bacteria, in the strain. Too much variation, it's hard to prove. Dosing, who knows what we need. In the study with the days off work, only 300,000 bacteria made a difference. It looks like in the ICU setting, it may be up to 10 billion. One of the probiotic yogurts we just use a yogurt or a kefir in our ICU, and we get 100 billion in 3 ounces of bacteria given twice a day to every one of our ICU population on antibiotics. So I think we've got some issues, but they're overcoming them. We've got to overcome them with big studies and big data. Now, to throw something else in the mix here in the last slide or two, what about the respiratory microbiome? We used to think the lung was sterile. Now we know the lung has a whole series of microbiome just like the gut. And guess what? It does the same thing. We see more pathogens going up after being on a ventilator, and we see antibiotics, and we see the good, healthy communal bacteria in the lung dropping, which protect us from pneumonia. So significant alterations. So basically right now, where are we? What should we be doing? I think you need to think this through and pick your probiotic if you're going to use it in the ICU, because we don't understand for all populations. You got to do focused approaches now. We need to attempt, to minimize the cues that let the bacteria know this is a sick patient. Many people argue if we keep the phosphate high in the colon, the bacteria don't sense the negative effects of the trauma and stress and ICU stay. So that may be an answer. We've yet to define the ideal community. We can define what the metabolic functions are, the beneficial metabolic functions, as Gail was saying. We can define that, but we don't know yet what bacteria are going to do that in a human setting. We can't extrapolate one bacteria to the other because of strain drift. And remember, these are so widely variable, makes it very confusing. So I think if we're going to use them as prevention, it's much better than treatment, like in C. diff. I think the study you see that no benefit in C. diff is probably because they basically gave it too late. If you give it before, you're going to see a benefit. So I think, where's the future holding it here? I think postbiotics has some future here. We don't have to give probiotic of live bacteria. Gail already mentioned tributrin, a way to deliver butyrate to the colon. It cleaves it off the glycerol backbone, releasing 3 butyrates. That butyrate then is anti-inflammatory, anti-infective, stimulating mucosal maintenance, decreasing loss of the brush-border barrier, very nice data. IV butyrate, and now approved in Europe as IV butyrate, not necessarily for this, but for other sources. And then maintaining luminal phosphate. John Naverdi has shown by giving a pegylated product, goes to the colon, cleaved by the bacteria in the colon, releasing butyrate. So very interesting data. Releasing phosphate, phosphate stays high. The bacteria go, look, there's no worry here. We got plenty of phosphate to make ATP on. They don't turn aggressive. And fecal transplant, Gail mentioned already. Blenderized food, natural food with fibers, pre and probiotic, may be the answer. We've got a big ongoing trial, which was held up because of pandemic, but now is back up and running, looking just at that, comparing our most aggressive interval formula for the ICU currently used versus a blenderized food, which in Asia is a common way to do it. You guys probably been doing it right the whole time, Okay, so where are we then? Right now, we're back up in here. We've got this heterogeneous population and a heterogeneous number of bacteria. We're starting to understand with our animal studies. I think we're going to be soon implementing it using big data to say we can now focus the next generation of probiotics, as Gail mentioned, as a target, targeting the probiotics based on the pathology. Thank you very much for your attention.
Thank you very much, Dr. Martindale, for another excellent presentation. I'd now like to welcome another Aspen colleague, Dr. A.J. Kumar Jain, who is a professor of pediatrics, pharmacology, and physiology at St. Louis University in the USA. Dr. A.J. is going to talk to us about his interests in pediatric nutrition, gastroenterology, hepatology, and liver transplantation. And his talk will focus on the gut microbiome in short bowel syndrome and long-term parenteral nutrition. So welcome, Dr. A.J.
Okay. Well, thank you, everyone. It's hard to follow a lecture after Bob, but I'll do my best. So firstly, a big thank you to Aspen and everyone here. This is truly an honor for us to be able to present this. Thank you, all the organizers, colleagues, friends, for this invitation to present. The title for my talk today is Gut Microbiome in Short Bowel Syndrome and Long-Term Parenteral Nutrition. Put this off a little bit here. These are my disclosures. I do not have any relevant financial conflict with respect to this presentation. So I thought what we'll do is we'll divide this talk into several parts. We will first understand some of the injury mechanisms with SPS as well as competing etiologies. We'll understand the role of gut microbes in driving disease in patients on TPN with short bowel syndrome. We'll overview some of the relevant clinical data, and then I thought it would be nice to stop every couple of slides to sort of present a key message. As Bob said and Gail said, this data can become a little messy. And then we'll have a little discussion about some of the novel basic science research that's going on in this area. So let's get started. As many people know, short bowel syndrome is a devastating condition where there is significant portion of the bowel is removed, as you can see on the images on the right. In addition to affecting babies, it affects children, adults, and is truly a global problem. Patients with SPS require long-term parenteral nutrition for survival, and this is, as a lot of you may know, is a modality for providing nutritional support through the intravenous route. SPS patients on TPN are also known to develop significant complications. One of the major ones is liver disease, also called intestinal failure associated liver disease, or IFL, and gut atrophy. So let's briefly discuss some of the factors driving TPN-associated complications in SPS. As people have mentioned, several etiologies have been attributed. Prematurity is certainly one of them, and it is hypothesized that the premature neonate has an immature hepatic transport and metabolism of bile acids. We'll discuss some of the role of the bile acids in subsequent slides, and that's a major driver for direct hepatotoxicity. Toxicity of the parenteral nutrition itself, I mean, this is discussed at multiple lectures, whether there is something to do with the various lipids which drives injury mechanisms. And this is also thought partly from direct hepatotoxic effect as well as some nutrient imbalances. Additionally, there is data on the role of sepsis as a driving factor. The theory here is, if you focus on the right, is that patients with short bowel syndrome are predisposed to bacterial overgrowth and changes in gut integrity. And intraluminal bacteria then produce endotoxins, which then permeate the bowel wall and go into the bloodstream. And these endotoxins are directly cause liver cell damage. They modulate the bile acid signaling pathway within the liver, and then they cause systemic injury. So, the gut microbes basically are causing systemic injury through this mechanism. Now, if you sit back, none of these pathways can fully explain sort of the breadth of pathology that you see in short bowel syndrome, including liver disease, gut mucosal atrophy, and some of the other things that are well known. So is there something else going? So our lab has worked on this, but the big idea here is, it's clinically known that TPN-associated injury in short bowel is minimal if enteral support can be given. In fact, data from clinical studies, both pediatric and adult, strongly support early feeding and intestinal rehabilitation, as also noted by Bob in his in the past presentation. So the big idea here is that it is the state that TPN induces, a state of a lack of luminal nutrients, thus a lack of signaling that occurs from the GI tract, which then drives the injury mechanism. Using the same schematic, it is sort of we're emphasizing this because that's sort of the crux. It is the state of TPN that occurs in patients with short bowel syndrome that causes key signaling molecules not to work as they should, which then drives the SPS complications. So an important question arises, so what is so special about the gut to serve as a conduit for systemic signaling? And I think Gail had very nicely mentioned some of the things, so I can skip some of the slides here. Mechanistically, we know there is a robust portal system driving all blood flow from the gut to the liver. In fact, the portal vein is now increasingly believed to carry key luminal signaling molecules as well as bacterial end products, which then modulate hepatic disease through uptake and systemic disease modulation. A very important link is also the intrahepatic circulation of bile acids. We'll not go through each of these steps here, but we know that intrahepatic circulation is the process that involves the recycling of bile salts between the gut and the liver. So if you sit back for a second and, think about it, an important question arises: why are there so many connections between the gut and the body? Is there a link between the gut and the body which then regulates normal health? So what controls this gut-derived signaling? And it's not rocket science to believe what is the major component of the intraluminal part. What is in the GI tract? So no discussion about SBS TPNUs or intraluminal content can be complete without thinking about the major component intraluminally, which is the gut microbes. And if you take a minute here, and both Gail and Bob have talked about it, the gut microbiota are a formidable player in health and disease. And they are known to regulate gut inflammation as well as proliferation. In a lot of ways, I wanted to set the stage here, what we are dealing with. The gut microbiome, as we now know, is individually adapted, intimately involved with the processing of nutrients, production of essential vitamins, other metabolites and toxins. There is data that a lot of our caloric intake, almost 10 to 15%, comes from the metabolic processes of the gut microbiota on the food we eat. In terms of numbers, there are about 100 trillion microbes on every human being. There are more than 10,000 species of microbes, and this has varied based on, as Bob said, whether you're in the Amazon jungle or sitting in New York or New Delhi or Hyderabad. We know that they weigh about 2 kilograms. In fact, they're housed in the GI tract, and if you span it out, it has a surface area of about 2 tennis courts. I like this analogy. The body has more microbes than there are stars in the Milky Way. It's a huge number that we are dealing with. And the gut microbiome is so huge that there are the 100 trillion cells and greater than 3 million genes. If you look at from a genomic standpoint, we are 99% bacteria and 1% human. So you've invited a genomically 99% bacteria to give this presentation. But it's a cool idea that these bugs, with so much genomic load, we know that they can impact health and disease. And now there is data that they impact short bowel syndrome significantly. I think Gail had mentioned, while there is significant variability in the gut microbes between the species and actually even individuals, about 80% belong to this Firmicutes and the Bacteroidetes phylum. It's also important that the gut microbiota is not stagnant. Early colonizers of the guts in the humans include aerobes, which are generally Staphylococcus, Streptococci, and later strict anaerobes like Clostridia dominant. But this is a transition that happens over the several years of life for every human being. In fact, babies tend to have more Proteobacter and Actinobacter. And one element that has been mentioned, and which I think is important, is bacterial diversity. There is this idea that more diversity is advantageous. Many patients with SBS undergo their initial resections of the bowel quite early in their lives. And this is a time when the microbiota is, has significant transition and vulnerability. They also undergo anatomic rearrangements. They have variable nutrition intakes and receive antibiotics. And we have some data on antibiotics, which is not good. Let's look at another idea called intestinal dysbiosis. Dysbiosis in SBS, or derangement of the gut microbiota, is associated with many chronic diseases. In fact, intestinal inflammation is associated with an increase in the gram-negative Enterobacteriaceae, which broadly belong to the phylum Proteobacter, which has again been discussed with my past presenters. And we also know that there is a decrease in the anti-inflammatory Clostridium phyla, which generally belong to the Firmicutes phylum, the Clostridium bacteria. Now, what we also now know is that the Clostridia are important for induction of colonic regulatory T cells. They're called Tregs. And then they decrease inflammation in the gut and promote intestinal motility. Intestinal bacteria are also thought to be critically in the development of necrotizing enterocolitis, which, as we know, is one of the key causes for short bowel syndrome. And additionally, something called toll-like receptor 4, or TLR4's expression has been seen in intestines resected from babies with necrotizing enterocolitis. The next question arises if intestinal dysbiosis is persistent. So you do a surgery, does it persist beyond a certain time, or does it revert back? And that's important because that tells us whether the disease is a one-time event, or the change in the microbiota, or this is in perpetuity. Emerging data now suggests that it's actually the latter. that once the microbiota changes in SBS, it's very hard to bring it back to what it is in normal humans or someone who's not had a resection. In a piglet model of dysbiosis, dysbiosis was seen after SBS both at about 2 weeks and 6 weeks post bowel resection, and this was particularly prominent for firmicutes. A subsequent study in children with intestinal inflammation found that there was an increase in the abundance of Proteobacter, which we just discussed is pro-inflammatory. And in another adult study, they found a reduction of Clostridium post SBS. We mentioned this, but we also now know that the microbiota tends to be more simpler and less diverse after intestinal resection, which likely also has a role in overall diminished gut health. In general, there is a trend towards an increase in abundance of pro-inflammatory bacteria and deficiency in the anti-inflammatory bacteria in the setting of TPN use with short bowel syndrome. I'm going to pause here. This is an interesting study which evaluated if the length of the remaining bowel was associated with bacterial diversity. And this looked at 25 patients with SBS. They used what is called 16S ribosomal sequencing of the jejunal aspirates. And if we look at the image on the left, right there, on the vertical axis is the diversity, on the horizontal axis is the remaining small bowel. If you focus on the blue line here, which shows patients who had stopped TPN, we note that the diversity increased with the longer bowel length. However, this was paradoxical. In those who were still on TPN, there was actually a reduction in the diversity as shown by the red line. So this actually poses an interesting idea that it's both the bowel resection and TPN which can then modulate the gut microbiota. Several other clinical studies have reported significant alteration in the gut microbiota in patients with SBS on TPN compared to controls. In this study shown here, the composition of the intestinal microbiota was noted in 23 patients with short bowel syndrome, and they compared it against controls. This study had patients of a variety of ages. And what you see is while there was variability, the most dramatic difference between short bowel and healthy controls of all ages was the massive, almost an 18-fold overabundance of the lactobacillus shown here. They also lacked bacteria containing, relating to the Clostridia clusters, as well as less abundant firmicutes. So we'll stop here for a second because, and we'll do this for a couple of other slides. A key message here is that bacterial diversity is advantageous. SBS patients undergo resection, rearrangements, they go on antibiotics, and this drives significant microbial changes. Intestinal inflammation increases with gram-negative Enterobacteriaceae and decreases with the anti-inflammatory Clostridia bacteria. Clostridia are now known to regulate inflammation through Tregs or regulatory T cells. And there is persistent dysbiosis in SBS. Microbiota tends to be simpler and less diverse in SBS, and both bowel resection and TPN can independently modulate the gut bacteria. Another problem worthwhile noting as we talked about SBS and gut microbiota is this entity called small intestinal bacterial overgrowth, or SIBO. There is lack of consensus in how do you define SIBO. Traditionally, it has been defined as the presence of greater than 10 to the power 5 colony-forming units of bacteria in the small bowel, or a greater than 10 to the power 3 colony-forming bacteria species that are normally found in the colon. Usually, the bacterial counts in the small bowel are roughly around 10 to the power 4, as Gail had also mentioned. But once they cross the ileocolonic valve, they increase significantly and are dominated by the Bacteroidetes and some of the bifidobacteria. However, in order to make the diagnosis, a small bowel or jejunal aspirates are required, which can be difficult, practically. An alternative methodology is the hydrogen breath test, and here the patient ingests a carbohydrate and then the exhaled hydrogen is then measured. And interestingly, some tests now look both at the hydrogen and the methane to capture, because the gut archaea can actually convert the hydrogen into methane and cause some false negatives. So I thought we'll talk a little bit about what the methodology looks like. But shown here is the hydrogen breath test from a patient with SIBO. This test is considered positive for SIBO if the hydrogen concentration is increased by more than 10 to 20 parts per million compared to baseline. If you look at figure A, which is on the extreme left, on the vertical axis is the hydrogen and the methane concentrations, and on the horizontal is the time. Figure A shows no SIBO. If we now see figure B, we note a peak indicating small intestinal bacterial overgrowth. And the idea is that as these organisms uptake sugar, which is glucose here, they release hydrogen, which is then picked up. People can also do this test through lactose, where actually you see a double peak, because the lactose hits the small bowel, you get a peak, and then as they transition to the, you'll get another peak as the colonic bacteria come into play. The downside with breath tests are they can be difficult to interpret in the setting of SPS, and depending on the amount of bowel resection, this can be a little less predictable. Now, practically, which is important as we talk about microbiota with SPS, how do you define, how do you say what SIBO is? And the general thought is based on clinical symptoms. Symptoms of poor weight gain, abdominal pain, foul-smelling stools, bloating, high stool output. And the goals of treatment for SIBO are not to achieve intestinal sterilization. You would automatically think that there are a huge number of bugs, let's kill all of them, and things will be better. But that's not the idea. We'll show some data supporting this in the subsequent slides. But the idea is actually to restore the good commensal bacteria back to where they were. There are several strategies. Usually people use 7 to 10 day course of antibiotics with an improvement expected in about 1 to 2 weeks. Metronidazole is considered a standard line of therapy. Other options include amoxicillin, which is bactericidal, rifaximin. I'm sure a lot of people use that. It's a non-absorbable analog for rifampin, and this is also considered bacteriostatic. The efficacy of antibiotics is largely unknown, and there are some unpredictable long-term side effects. But again, this is sort of what we have in the armamentarium. There's also this idea of using a food map diet, which is sort of low in carbohydrates. And the idea is because it minimizes the short chain carbohydrates, it results in less gas production. But there is need for more research in that area. So again, stopping here, our key message here is that small intestinal bacterial overgrowth is a major problem in SPS. SIBO traditionally is defined on bacterial counts. Diagnostic modalities include jejunal aspirates as well as hydrogen breath test. And practically, SIBO is diagnosed based on clinical symptoms, and the goals are sort of to reduce the pathogenic bacteria, not gut sterilization, and then restore the good bacteria. So we'll pivot here a little bit. Patients with SPS are known to develop hepatic cholestasis, and we mentioned that briefly in the earlier part of the discussion. And while the etiology can be multifactorial, as discussed before, alterations in the intestinal microbiota in SPS can result in increased inflammation, which causes the gut and the liver injury. So I found this as an interesting clinical study. They looked at the composition of the intestinal microbiota in patients with SPS, and they found that a lot of those cohorts who had liver steatosis and liver injury, they then divided into two groups and found those patients who had prolonged TPN support had an increased abundance of Proteobacter, reduced microbial richness, and tended to have the most severe liver disease. Those with abundance of Clostridium had the least injury. I think Gail and Bob both had mentioned that SPS patients are known to have growth failure, which can be due to malabsorption, which we now know because of hepatic cholestasis. In fact, in our practice, we recommend weekly TPN labs, monitoring for fat-soluble vitamins, and regular anthropometric measurements for patients with hepatic cholestasis. There is data on ursodeoxycholic acid, which is not as robust, but a lot of people use that if there is more than 2 grams per deciliter of conjugated hypobilirubin. Um, so there is some recent data that also shows that a lack of short chain fatty acids in patients with SBS is also a driver for growth failure. And SCFA, or short chain fatty acids, can be measured through metabolomic assessments, though this is not routinely done, but it certainly is a major target for therapeutic interventions, as tributarin was mentioned by Gail. And this is a target for both, in this cohort of patients, but also with some of the other liver diseases and systemic illnesses. Another problem with gut microbial dysbiosis in SPS is alteration in bile acid metabolism and signaling, which is a risk factor for cholestasis. So let's see how bile acids are altered by gut microbiota in SPS and during TPN delivery. We know that the intestinal microbes play a major role in bile salt metabolism, and their main transformation occurs as follows. Deconjugation, which results in the hydrolysis of the amide bond, and this makes the bile salts available as substrates for modification by the intestinal bacteria. And this is a very important idea here. Deconjugation is catalyzed by bacterial enzymes called bile salt hydrolases, which are sort of widespread in the bacterial community. 7-alpha hydroxylation or beta hydroxylation converts the primary bile acids like quinodeoxycholic acid into secondary bile acids. For example, such converts cholate and quinodeoxycholate into the secondary bile acids deoxycholate and lithocholate. And why this is important is we now know that the primary bile acids, quinodeoxycholic acid, cholic acid, are activators of FXR. FXR, or farnesoid X receptor, we didn't have time to talk about that, is a major receptor which we now know is involved in liver health through the FXR FGF19 CYP7A1 signaling pathway. And the gut microbiota-driven secondary bile acids, for instance, lithocholic acid and deoxylithocholic acid, are preferential ligands for another interesting major G-coupled protein receptor called TGR5, which regulates gut growth through the TGR5 to the TGR5 GLP axis. An extremely interesting idea emerges if sort of gut microbiota then can change the bile acid signaling properties and then modulate liver health as well as gut injury in SPS disease. And why this is important is because then it opens up the potential for therapeutic targeting for this group of drugs that will be developed. I don't know why there is overlap here on the red line, but I think some of the formatting has changed. But our lab has created a SPS model system using piglets who undergo resection in the OR, and we place bowel resect. We place jugular catheters, duodenal catheters, and on the extreme right is our untethered animal model that we're going to talk about some of the results in the subsequent slides. And we also have a nice novel platform which is now patented. It's called Protect, where we can get discarded human livers which are not applicable for transplant, and we can split them for therapeutic testing where one lobe acts as a control. And our lab has also developed organoids, which are organ cells for the gut, which can be grown in the Petri dish for therapeutic testing. So interestingly, we have found from our studies that TGR5 also modulates intestinal immunity to the NF-kappa B inflammatory cascade. And as we know, it is also involved with gut proliferative responses through GLP-2. This is additional data from our lab, and in order to characterize the gut microbiota, we performed 16S ribosomal sequencing on the fecal samples from control enteral-fed groups against those receiving TPN. And what you see in this graph are, it's a simplified version, but percentages of each of the phylum. On the top left, in figure A, is the phylum level distribution in controls, and we see a dominance of the firmicutes. However, with TPN, there is a major shift with the Bacteroidetes dominance as shown in image B. We also noted in subsequent studies that the bile acid receptor agonists, like those regulating TGR5, could prevent the changes with TPN, as shown in figure C, and such treatments could also preserve gut atrophy as indicated by what is called the villus to crib ratio, or the VC ratio, as shown in figure D. So if you focus on image D, there is significant reduction in the villus to crib ratio in those who had TPN, as shown by the black bars, and this is dramatically preserved with TGR5 ligand treatment. So I know we are running out of time, but what are the options for restoring the gut microbiota? And some of those have been discussed. They include antibiotics, supplementing with probiotics, prebiotics, symbiotics, also repopulating the gut microbes with fecal microbiota transplant. Commonly available probiotics used in SPS empirically have been lactobacillus, bifidobacterium, Saccharomyces. In animal SPS model, lactobacillus has been shown to stimulate intestinal growth and decrease bacterial translocation. And lactobacillus and bifidobacterium have also been used in very low birth weight infants to prevent necrotizing enterocolitis and sort of shorten the duration of TPN. Another treatment to consider is prebiotics. As people have mentioned, these are non-digestible food ingredients which help in the growth of the beneficial bacteria. And examples include oligosaccharides, fructooligosaccharides. Again, using a piglet model of SPS with bowel resection, prebiotic or a combined probiotic and prebiotic resulted in a significant increase in jejunal as well as the ileal mass in this cohort. And while these are promising approaches, robust control studies are lacking, which limits their widespread usage. Another exciting approach is fecal microbiota transplant, where sort of healthy gut microbiota are transfused into the diseased gut. And this has been very successfully done with Clostridium difficile. And as Bob had mentioned, you can now actually take the breakdown products of the bacteria and transfer them into patients with C. diff, and that has some response rates, which is important that you don't have to have the whole intact bacteria or the prebiotic. The problem with SPS is, again, there is limited studies looking at fecal microbiota transfer for SPS. I thought I'll end this talk by a study from our lab which looked at fecal microbiota transplant in our model, and we'll show the results in the subsequent slides. So if you look here, as done in the prior studies, we measured the gut mass for the proximal small bowel and the distal small bowel. So what you do is you take a 20 centimeter segment of the bowel and weigh it. For the next several slides, the black bars will represent regular enteral nutrition. The blue represents TPN, the yellow, the TPN with antibiotics, and this was a broad spectrum antibiotic. Our goal was to sterilize the GI tract. And then the last, the green bars show the FMT group. On the vertical axis here is the weight in grams per centimeter, and what we can see is that both in the proximal and distal small bowel, there was significant reduction in the gut mass with TPN, and surprisingly, the attenuation in the gut mass was much higher in the antibiotic group. So look at the antibiotic group. We now think that gut sterilization actually is bad, and we can actually determine that through some of these studies. And what we did see was that fecal microbiota transplant was able to prevent the gut reduction that would have otherwise occurred. We next look at serum bilirubin. Again, on the vertical axis is the bilirubin, on the horizontal the groups. As expected, serum bilirubin was significantly elevated in TPN. The FMT group showed serum bilirubin elevation, but it was statistically much lower than the TPN group. But again, if you look at the antibiotic group, we see a massive increase in serum bilirubin. In fact, it was the highest among the groups. Serum TNF alpha, which is an inflammatory cytokine, was also lowest in the FMT group. This next slide is a little busy, but it denotes what is called the operational taxonomic unit, or OTUs. The pre-samples indicate stools at the study commencement and the post at the end of the study. If you focus here, of note, the major shifts in the post samples of SPS animals on TPN can be seen, and those of the antibiotic groups, and there was sort of similarity between the enteral and the FMT groups. And this is the last slide. We sought to objectively quantify the similarity between samples, and this slide shows what is called the principal coordinate analysis, which is a method to explore and sort of visualize similarity or dissimilarity of data. And here we determined what's called the Jacquard's index. Broadly, this determines how closely samples agree with each other. The closed circles represent study initiation or the pre-samples, and the open circles represent the end of the study or the post-samples. And what we note is a striking clustering in both the pre and the post-samples for enteral and also in the FMT groups, as shown by the blue and the green respectively. The antibiotic group, shown in red, if you actually see, is the furthest from here, had the least similarity with, and the TPN group was next to it.
AJ, you have summarized?
In summary, and as a take-home message, gut microbiota plays a formidable role in SPS and TPN. Intestinal inflammation is associated with increase in the gram-negative Enterobacteriaceae and a decrease in anti-inflammatory Clostridium. Importantly, evidence shows persistent dysbiosis in SPS, and the microbiota tend to be simpler, and less diverse after SPS. SIBO is a major problem with SPS. Traditionally, is defined on bacterial counts, but diagnostic modalities include jejunal aspirate and hydrogen breath test. Practically, it is diagnosed as a surrogate of clinical symptoms. Antibiotics and a food map diet remain promising. We also know liver disease occurs in SPS and is modulated by gut microbes. And importantly, gut microbes can transform bile acid signaling in SPS. Our future studies look at probiotics, antibiotics, and FMT are promising. Stool metagenomics, which was whole genomic sequencing of the gut microbiota, our lab does that, is an area of research. And we are specifically looking at the bile salt hydrolases within those cohorts to see if we can do targeted therapeutics. The role of bacterial components, as Bob has mentioned, may have a role and needs further exploration. And I'll end by saying that we know that major alterations occur in the gut microbiome with SPS. And sort of targeting their signaling could sort of provide really a paradigm change in how we develop our future diagnostics as well as therapeutics. And the good part is we think this may prove a way so that we can significantly help our patients do better. With that, I apologize for taking more time. We thank our funding agencies. We thank Pensa for hosting us here. We are funded through the NIH, through Aspen, through some of the foundation and industry. And this is our lab group. We thank each of them for the work that has been presented. Thank you very much.
Thank you, Dr. Jain, for that comprehensive lecture. We can have questions later and maybe you can join us. So now may I request the last speaker, Dr. Ravinder Reddy, gastrointestinal surgeon from CARE Hospital, to come on the dais. So his area of interest is in surgery in critically ill patients, nutrition in gastrointestinal failure and sarcopenia and wound healing. He is currently the president of the ISPAN, the Indian Society of Parenteral Enteral Nutrition. He is a panel member of the WHO Nutrition Recommendation in Hospitalized Patients in Southeast Asia, and he has several peer-reviewed international and national publications to his credit. So now the dice is yours, Dr. Reddy.
Pointer options. Good morning. Good morning, ladies and gentlemen. In front of Dr. Gail Qureshi, Dr. Martin Dale, Dr. Ajay Jain, and Dr. Paul Wishmaya, I feel like a small infant trying to masquerade as an adult. And I'd like to thank the Aspen board for actually putting me on to the same platform, such as your distinguished swells. And I'm going to talk about the gut microbiome as a surgeon, what happens to the gut microbiome in the post-operative period. Before that, we are the new entrants onto this world. The bacteria which came about 3.5 billion years ago, I mean, they were the first ones. And since then, they have evolved and evolved and evolved. Even though we have the audacity to call ourselves sapiens, the word sapiens, I'm sure some of you all know, means the wise one. We call ourselves the wise ones, but we ain't wise. If you look at the most wise beings, it's actually the microbes, especially the gut bacteria. They say there are about 30 million different kinds of species on this planet Earth, and out of which we are only one of them. Right? And they took about 3.5 billion years to actually evolve. So it's been quite a while. And so they have right from they have a bit of an advantage over us as far as the evolution is concerned. And we have, there are many factors, I'm not going to that. But one of the most important factors is how the initial feeding practices of a child, the first 1,000 days of a child. As Dr. Bob Martindale mentioned, it is the human milk oligosaccharides, which is very rich in Bifidobacterium longus. Bifidobacterium. The word longum means it's got one of the biggest DNAs, and that is required to actually break down the human milk and other things. No pharmaceutical company could actually emulate the human milk oligosaccharides so far as we know. I'd like to pause here and tell you a story about a few years ago. There were a group of Swedish students who came to India to spend 2 weeks, and then they went back. So Uppsala University from Sweden, one of the leading universities, they did their biopsies, not biopsies, but the rectal swabs, and these students stayed in hostels, not in fancy hotels such as this, but they ate street food and all, and then they went back, and what they found was, compared to the previous one, their gut microbiome changed drastically different. Most of them were pathogenic. Despite that, these students were very healthy. I'm actually alluding to the fact that what is a healthy gut microbiome? We do not know. What is a healthy gut microbiome? Till today, there are no definitions. No one seems to agree of what is a healthy gut microbiome. As Dr. Martindale and Dr. Gail Pesci have shown that the simple commensals is the one who shares the table, simple commensals can become pathogenic if the events actually encourage them to become pathogenic. So we do not know what is a good bug and what is a bad bug. And one of the most important things I'm going to talk about is what happens to the gut microbiome in surgery. And as all the speakers have mentioned, humongous number of species in patients, in people, especially those who are living in the Hasda community in Tanzania, people living in Amazon, huge numbers. We think that they have more than 1,200, 2,000, 1,500 species. We do not know, because right till today, we do not know how many bacteria and how many viruses are there, for the simple reason that we do not have the wherewithal to actually culture them, identify them. So we do not know. And also the numbers, we say that we are overwhelmed by about 1:10. The jury is still out. Recently there was a paper in Nature that says that maybe we are 1:1. We are about 30 or 37 trillion cells, and maybe the bugs are about 39 trillion cells. This particular paper in Nature Outlook also said that once a person has empties his bowels, in fact, the authors presume that the human cells are actually more than the gut bacteria. We do not know. So there's a lot of things. There are many lot of things. But what is important is the constant temperature of 37 degrees, the pH, and the anaerobic and relative anaerobic environment that is so very essential to actually keep some sense of homeostasis as far as the intestinal bugs are concerned. Different types, as we all know, the commonest ones, 90% are the Firmicutes. Examples of Firmicutes are the Lactobacillus and the Clostridia and the bacteroids. The remaining are Actinobacter and Proteobacter. Very small amounts of Proteobacter are there. Proteo means water. In fact, we all see them whenever we see an infection in the gut. E. coli is a Proteobacter. Pseudomonas is a Proteobacter. They are the ones that actually depend on the anaerobic environment and also the nitrogen. The other rare phyla as well, I'll not go into that. The phyla between the small intestine is different from the large intestine, mainly because A, the transit time, it's relatively faster. Huge amount of digestive secretions, nearly amounting to about 6 liters or so. Low diversity of the bugs, that explains, and the density is also low, and different kinds of available foods that results in a different phyla and different species such as Lactobacillus, Clostridia, E. coli, staph, and strepto and bacteroids. Whereas in the large intestine, it's a slow transit time compared to the small intestine. There are no digestive secretions. In fact, there are only two main functions of the large intestine: absorb some sodium, and water. More important than that, it's one of the biggest fermentation factories in the body. And the biggest masters of fermentation are actually the fungus, which we all have. And that's the reason why, and there is a relative anaerobiosis in that. One of the reasons why there's anaerobiosis, I'll come to that soon, is because of the redox reactions are different in the large intestine. And this is important to know because when we bypass a large intestine, the total number actually changes, the scene changes. And given the nutrient poor environment, as I said, the bugs are more wiser. They evolve to actually survive in a different environment, resulting in again bacteroids, Floricella, Echinacea. Some of them are very mouthful to actually pronounce. Ruminococci, Lacanospidae. I don't know if I'm pronouncing them correctly or not. So there are many factors that actually in which the gut bugs depend on. We think we know one of them is the pH, right? The pH increases as we go down from the stomach. The mucus, the total mucus area of the human body is about 200 square meters, and it is divided into two, mainly in the gastrointestinal tract, and the other one is in the respiratory tract. Right? And also the oxygen availability in the lumen as well as in the epithelial cells of the gastrointestinal tract. And I'll not go into the short chain fatty acids in a very deep way, but we all have heard this in all the three preceding lectures: acetate, butyrate, propionate. I'm very glad to know that there is intravenous butyrate available. I'm sure it is very costly, which in India we cannot afford, but there are the means to actually increase the butyrate in our body. But the short chain fatty acids, because they reduce the pH, they have antioxidant, anti-inflammatory effects, antimicrobial, anti-tumorigenic. They help in proliferation of the cells, especially even in the short gut syndrome as well. And what we know, we are beginning to understand the role, what the scientists call it as the psychobiotics. Some of them through the vagus nerve, they act directly, and these small chain fatty acids, they are 2 to 4 carbon atoms. They percolate everywhere into the blood, and they cross the blood-brain barrier easier. And they are one of the most important molecules as far as our mood is concerned, and development of Alzheimer's disease, Parkinson's disease, the autism spectrum disorders, various. We are still beginning to scratch. Maybe there's a lot we do not know. And of course, it also helps in increasing the incretins. One of them is the glucose-like peptide 1 and the peptide YY1. And the mucus, it has single layer in the small intestine, but in the large intestine, they're divided into about 2 layers. The lower one actually is very tense, is very closely packed. Not many antimicrobial substances. There are a lot of antimicrobial substances, but the upper layer actually is full of these bugs, or the good bugs, basically. And antibiotic prophylaxis, feeding prophylaxis, many of them, bowel washes, all of them actually alter this particular mucus, thus resulting in a different kind of microbiome in the post-operative status. We heard of this very mouthful organism called, mouthful to pronounce organism called Faecalibacterium praunitzii, and Akkermansia mucinophilia. As we all know, the name itself suggests that it thrives on mucin. It actually not only eats the mucus, but also it stimulates the goblet cells. I have a picture of goblet cells I'll show you, to stimulate more and more mucus. And it is one of the biggest beneficials, or one of the biggest protections which we have in our guts, is actually the mucus layer. So one way to increase that is actually to increase yes, we can take probiotics, but they may be costly, and intravenous butyrate may or may not be available in this part of the world, in Asia. So high fiber diet, fructose oligosaccharides, and pectin, inulin for rich foods, so on and so forth. This is an important slide because this is one of the redox. This particular slide shows the redox reactions which actually dictate what kind of bugs stay in which part of the intestine. As we all know that most of the aerobic bacteria are in the small intestine, and as we go lower and lower down, the oxygen is utilized by the colonocytes, the epithelium, so much so that the redox reactions, ATP, it depends on the ATP. The ATP need oxygen and it is utilized. So the relative anaerobiosis, the amount of oxygen present in this large intestinal lumen is about just 0.6% as opposed to about 6% in the proximal intestine. And this is one of the reasons why entirely there are different sets of microbiome. And when we bypass, when we reset, we are drastically changing the post-operative gut microbiome in these. So the major functions of this gut microbiome, apart from immunity, infections, metabolism, antioxidants, and gut inflammation, is that produce short-chain fatty acids, drug metabolism, insulin sensitivity, which is so very important soon after surgery. And of course, it reduces the toxins, plays a major role in obesity, cancer, sleep health, and other issues. This is the slide I was telling about. So, one of the most complex systems in our is the small intestinal mucosa are very, very different cells. Each of them work in a very different way, in a very comprehensive, cohesive way to actually maintain what is called as a good health. Having said that, this is completely changed. This is completely distorted soon after surgery. And resulting in various interactions. So, what exactly happens to the gut microbiome in the post-operative period is we think we know something, and that's what I'm going to share a few things about it. The various practices and factors, still many of, I'm a surgeon, I do not prepare bowel, but many of my peers in India, they do prepare bowel, even for surgeries which do not require surgery on the large intestine. It's a very rampant procedure. And most of them actually are starved, which is very unfortunate, but still from midnight onwards. So no food or drink for 12 hours, bowel of preoperative bowel preparations, rampant use of preoperative antibiotics. And quite a few of them actually spend some time in the hospital before their actual surgery, so much so that we all know that once the person is in the hospital, he or she will acquire the resistant bugs from the others, from various formats, even from us as medical health professionals. And of course, if somebody has got various comorbidities or various organs and a pre-existing infective disease, many factors that affect the perioperative one. And I'll not go into this slide, but a ton of things are happening and very soon after surgery. And what is more important here is the takeaway message from this particular slide is there's increased inflammation, there's increased insulin resistance, there's increased metabolism, so much so that the resting energy is increased. At the same time, we are not feeding the patient. At the same time, we are killing the bugs by giving unnecessary antibiotics. So, what happens in the post-operative period is there are alterations, as I said, in the mucus, alterations in the pH, and more importantly, alterations in the aerobic as well as the anaerobic environment, which is so very important to maintain what we think is a healthy gut microbiome. Right. So, what we poorly understand is there is a reduction in the bifidobacterium across most of the surgical patients in Clostridium species and also in the lactobacillus species. The important thing about lactobacillus is it actually prevents the adhesions, as Dr. Martindale said, prevents not only the adhesions of this pathogenic bacteria to the gut wall, at the same time, it reduces the pathogenic bacteria. So it has many functions. Similarly, the Clostridium species. At the same time, there's an increase in the phyla proteobacteria, that is E. coli, some other phyla like staph and strepto and enterobacteriaceae as well. Now, all surgeries are not the same. There are different surgeries. These are all some of the surgeries I have done. So, a simple, straightforward laparotomy, going home in 2 or 3 days, but that microbiome is different. A person who is admitted for an intestinal obstruction, such as shown here, he's already come with a distorted microbiome. Somebody who's got an ulcerative colitis and we do a total colectomy, we did that a few weeks ago. He or she has a different microbiome to start with, and he or she will have a different microbiome in the post-operative period. The last one is actually the colonic replacement. So for a young girl who actually consumed corrosive, so we had to replace the entire colon with that. And massive resections, laparoscopy, and anastomotic leaks, and of course, necrotizing pancreatitis, all of them differ. All of them, the gut microbiome, it is actually the gut bacteria which dictate which patient actually improves, which patient actually doesn't improve in these things. So monitoring certain bacteria is very important, especially if the person has inflammatory bowel disease. Faeculobacterium, if somebody is got, if we have the wherewithal to actually see which bacteria increases, and if we know how to diagnose Faeculobacterium brownidgei, then we know that there's an increase in remission rates. Patient is disease-free. Increase in Enterobacteriaceae and Septobacteria, there's an increase in recurrence rate. This particular patient may develop recurrent episodes of the initial disease. And reduction in Enterobacteriaceae and staph, increase or increase in Bifidobacterium 2 weeks post-surgery, they actually reduce the incidence of surgical site infections. So not only clinical assessment, but by just looking at the bacteria, the type of bacteria, we can actually predict which patient actually will do properly or improperly in the post-operative period. Now, we take a lot, as a surgeon, we take an extra precaution to actually see that we do not develop, our patients do not develop an anastomotic leak. If you look at the conventional textbooks, they say tissue handling, nutrition, early feeding. There are many standard things to actually increase the success rate and so that we do not have an anastomotic leak. But then we are beginning to understand why there is an anastomotic leak, because there are certain bacteria which actually produce collagenase, such as Pseudomonas and E. coli. And as seen in the picture, they are collagenolytic enzymes. And as seen in one of my patients who developed an anastomotic leak, I hasten to add that this patient survived. We had to immediately recognize and go in. But then, apart from the surgical technique, apart from the anesthesia technique, we are beginning to understand the role of these bugs in causing various complications, not just anastomotic leak, but surgical site infections, infections in the remote place, recurrence for colorectal cancer, recurrence for various ailments. So we are just beginning to understand that. And but having said that, the good thing about one of the bariatric surgeries, if the person actually improves, is there is an increasing. We completely change the anatomy and the physiology of the gastrointestinal tract in bariatric surgeries. There is an increasing pH. There is a shrinkage of stomach. There is alteration in bile acid metabolism. Has been said by Dr. Ajay. And alterations in incretins, that incretins are the ones that increase the insulin sensitivity, the glucose-like peptide, and in addition to that, the cholecystokinin, the alterations in ghrelin, all of them actually reduce. They increase the bugs, which actually cause changes in these incretin molecules. So how does bariatric surgery help? It actually helps with changing the gut microbiome, and that's how it helps. So increasing Firmicutes, Actinobacter, and Akkermansia, Mucinophilia, etc., they are the ones that actually help. In colorectal cancer, there's a decrease in Firmicutes, bacteroids, Bifidobacterium, Clostridium, Actinobacter, Prevotella. We do not know what is the outcome of these. We still do not know. Maybe by next Pensa we'll know. Increase in Clostridium species, Proteobacter, Fusobacter, again we do not know. They are contrasting outcomes. Some of them say yes, there's an increased incidence of surgical site infections, and some there's not much of a difference. So again, we do not know. However, if there's a decrease in Proteobacter, like E. coli, right, there are potentially benefit. Some studies actually show that there's some element of benefit. So the post-operative changes of the gut microbiome. I've just taken 2 studies, not many. I'm not a big fan of showing data. So this was one of the first systemic studies where they have taken about 337 publications. And they found that in all of them, in all the patients, for over 650 patients, there was a change in the gut microbiome in every patient. There was an increase in the pathogenic bacteria. Uniformly, there was a decrease in the beneficial bacteria. Now, symbiotics reduce the post-operative infections, as we know, and I'm waiting for Dr. Martindale's ongoing results of ongoing study. And abdominal cramping and diarrhea definitely reduced. I put an asterisk there because this is not uniform. There are various limitations. One of the reasons in this particular study is they use different kinds of kits to actually measure the kinds of bacteria. So it's not uniform. Again, so in other words, we do not know. This is another study published in the European Journal of Clinical Nutrition. Over 2,500 records were analyzed, and again, there were change in gut microbiome in almost all the studies. This is an amazing paper by Suzy Ferry. But in 9 studies, they found that there was a significant change in specific bacteria, and there were better outcomes in those with an increase in beneficial bacteria and diversity. Again, asterisk is there because it is not uniform in all of them. Different methodologies were utilized, and some of them had bowel preparation, some of them have the decontamination of the gut. So we cannot say that it is uniform in everyone. Different methodologies. So the jury is still out there. So this is a very nice slide actually, which tells us what happens exactly. It gives us the synopsis of what exactly happens to the gut microbiome. To start with, if these are the ones, I don't know if you can see the pointer. No, you can't see the pointer. The one on the left side that actually shows, oh, let's see that. I think this is a pointer. Yeah. No, I don't know. Is a gut microbiome. And soon after the antibiotics, there's a drastic reduction in the beneficial bacteria. But very soon, the pathogenic bacteria increase, and which increases the inflammation, which increases the dysbiosis. And recovery takes a while. I'll talk about recovery in the next slide. So how do we reprogram the gut microbiome after surgery? Right, we need to reprogram. We need to make attempts to see that the person give back the good bugs back to the patient. Yes, ERAS protocol. We have Dr. Oli Lindquist, one of the leaders of ERAS protocols. There are a few studies not specific to the gut microbiome, but we know that early feeding, early ambulation, limiting antibiotics, using minimally invasive surgery as much as possible, all of them on paper, we know that they actually benefit the patient. Perhaps we think that it is due to the alterations or limited alterations in the gut microbiome. But this particular study actually shows, it's a very good study, it's called the Food and Resulting Microbiome Metabolic Studies. This was done in healthy individuals. There were 3 groups, those who are omnivores, who eat everything, those who were vegans, a vegan diet, and those who were exclusively on a fiber-free artificial diet. And in all of them, there was an attempt to cleanse the intestine. We know that we can't clean the whole intestine of bugs, but there was some attempt. And they found that after the antibiotic course, the recovery phase of the original ones were very quick with the omnivore and the vegan diet, whereas those who were on fiber-free diet, they are the ones who take a very, very long time to get back their bacteria. So in other words, soon after surgery, it's better to start normal diet, especially the high-fiber diet. Now, this is an amazing study by Justin Sonnenberg, who's from Stanford University. They have done, it's one of the biggest studies. I think this was a study which was over 17 weeks. They have divided that into 2 groups. One is high fiber diet, and the other one is the high fermented diet. And initially, the first 3 weeks, they checked the stool and the blood sample. After that, gradually in 2 periods, there were 18 in each group. They took over a 4-week period. It's called a ramp period, where they increase the fiber diet or the fermented diet, maintain this particular thing for the next 6 weeks or so, and then for the remaining 4 weeks, they said choice. That means they can eat whatever they want. And what did they find? They found that those who were on high fiber diet, the microbiome function increased. There was a definite increase. At the same time, they looked at the stool and they did various kinds of studies. I'll not go into that. But they found that the carbohydrate active enzymes increased drastically in the high fiber diet. The short chain fatty acids increased. But surprisingly, those who had a low diversity of the gut microbiome to start with, when they were put on a high fiber diet, they found that their inflammatory markers actually increased. Perhaps telling us that they do not have the wherewithal or the kind of bugs to actually assimilate and extract the short chain fatty acids or the reduced inflammatory markers from these, as opposed to the people who were taking the high fermented diet. That is, they are the bacteria already, instead of prebiotics in a capsule form, They're taking the fermented diets, and they found that there was an increase in microbial density. In all of them, they found that there was a reduced inflammation activity as well as the markers. So we can utilize this particular study in our patients in the post-operative period. I'm just finishing the last two. So apart from the prebiotics, we can actually encourage our patients in the post-operative period to not only have a high fiber diet, but to also encourage the intake of a fermented diet. And one of the good fermented, which is commonly available in this part of the world, is actually the yogurt. Probiotics, symbiotics, enough has been said, contrasting results, but I use prebiotics, I use symbiotics and postbiotics, and I use a high fiber diet. I encourage them to have a high fermented diet mainly because they increase their postbiotics, so that there's a positive clinical outcome. So to summarize, it's an important system. It's a well-being, very, very essential for our well-being. There is a definite relationship between the gut microbiome and the outcome. We know that the diet, the epithelial functions of the epithelial cells, the redox reactions, the integrity of mucus or the absence of mucus, fasting, bowel wash, antibiotics, inflammation, infections, intestinal resections, bypasses, reconstructions, diversions, all of them do have an effect on the gut microbiome. And we are just beginning to understand some aspects of this very complex system. So we know very little, and here I'd like to pause and give you a statement made by Donald Rumsfeld, the famous or the infamous Defense Secretary of the United States, and he said, we know that there are known knowns, we know what we know, and there are known unknowns, we know what we do not know. But he also said that there are unknown unknowns, in the sense that we do not know what we do not know. And that particular thing, his particular statement, very, very aptly applies to the gut microbiome. We do not know what we do not know. So with that, I'd like to end. The true knowledge is to be aware of one's ignorance. Thank you very much.
Thank you, Dr. Reddy. And it's now my duty to close this session. I apologize that we don't have time for questions because we started late and we're running over. But I think you'll agree this has been a very exciting Aspen Pensa session with lots of food for thought. And so I'd like you to join me in thanking my co-chair, Dr. Talukta, and all our speakers for their excellent presentations, and thank you for your attendance. Thank you, everyone. If you do have questions, please feel free to talk to the speakers individually over coffee.
Delegates, please stay back. We'll be continuing with the symposium. The symposium on critical nutrition will continue now.
And I need to plug it in. I may have to sit down. You guys can plug it in. And I have the connector with it. How's it going to sit with this computer? Can I shut this computer and move it when I'm up here? So how's my computer going to sit here? This is giant. I'm sorry? No, I don't have my work. No. Only Mac. Yeah. So I warned them 2 weeks ago about this. They knew it's coming. I told them I would move it. Okay. Okay. Can you show me? I don't hear the sound. No. I'm sorry, is there what? Yes, there's videos. Multiple. Okay, you can plug that in here. I need to unmute. The plugs are here. Can you turn the volume up a little bit? Can you turn the volume up a little bit? Louder, louder. It's playing right now. Yeah, I was just playing music. I just wanted to hear it. Yeah. Beautiful. Perfect. That's good. Okay. I'll put down. I'll be on the way. I know it. Yeah, I'm gonna try to.
Hello, check.
Good morning, one and all. My name is Anvita Paruchuri. Before we start the next session on critical care nutrition, kindly note the change in the schedule that Professor Martin Robert will speak on perioperative use of parenteral nutrition after Professor Matt Berger's talk, and Professor Pierre Singer will be doing the session in the evening. And I would also like to request all the speakers to kindly adhere to the time. Now, coming to our speakers of the current symposium, I would like to now invite Dr. Srinivas Samavedam, Medical Director and Head of the Department of Critical Care, Virinchi Hospitals, Hyderabad. Dr. Srinivas Samavedam is a nationally recognized practitioner who has had major interest in the areas of quality in ICU, AI, and ML in ICU. We welcome you, sir. I would also like to invite Dr. Bhuvaneshwari Shankar, Senior Consultant Dietitian at Apollo Hospitals, Chennai. Having more than 3 decades of experience in the field of clinical nutrition and dietetics and areas of interest in critical care nutrition, She has achieved plethora awards like the Lifetime Professional Achievement Award by Apollo Hospitals Group. We welcome you both onto the dais. Thank you.
हाँ हाँ इधर से क्या होना
Good morning, one and all.
इधर नेट क्या बोलते हो
Thank you, organizers, for inviting us to be the chairpersons. May I introduce Dr. Varsha Asrani. I need to tell you, I met Varsha in the Australian Society conference a couple of years back and heard about her work in the ICU and the gut. She's an advanced ICU dietitian in the critical care medicine department, and she's got quite a few achievements. One in 9 New Zealanders to secure a prestigious Carey Research Training Fellowship, followed by 2 Allied Health Trust Awards in 2019 and 18, followed by recent funding in 2021 and 2022 for work and outcomes in her PhD with other prospects. Named investigator on over $2.5 million of research funding with STAR Center collaborators of University of Auckland. Her area of interest is nutrition and IV fluid therapy in critical gut dysfunction, failure in critical illness, nutrition leadership in the ICU. Welcome, Varsha. Please take over.
Thank you, Dr. Shankar. Thank you for the lovely introduction. Right, just put my presentation. Great. Is it not? It's showing you.
This is the back. No.
So just press. Oh, great. Thank you. And slider.
This is the slide change. This is the point.
This is the point. Okay. And this is
This is the slide changer. This is backward. Forward is back.
Great. I'm going to be talking today about gut and critical illness. Before I start, I would like to give my thanks to the Pensa organizers, ISPIN, Dr. Reddy and his amazing team who have put this together and having me here today to speak on this interesting topic. I'm an ICU dietitian, so this has really intrigued me for a while now. We see patients at the bedside day in, day out, and we come across the problems associated with gut dysfunction pretty much in every patient I see. And therefore, that kind of revived my interest in this area where I just thought I should take it a bit forward. So this is a bit of an overview of what I'm going to be talking. A bit about organ failure, a case that I came across which also kind of triggered my interest around gut failure. Feeding enterally in these patients, which can be a challenge. And something about my project that I am working on about a novel gut scoring tool. So this is our ICU. This is a typical scenario that we see every day. As you can see, this is an ICU patient who's been there and has got organ support, intensive care support. He's on a dialysis machine. He is on a ventilator. He's also on a TPN bag that's running on the side, a gray bag. And this is what we see. This is a patient who is fighting for his life. And many of our patients that we see in intensive care are attached to a number of devices. He's also having an infusion running at the side. And this patient is obviously probably having multiple organ failure, which is one of the leading causes of mortality in the ICU, despite intensive organ support. And organ failure is a life-threatening condition. Almost 50 to 80% of mortality is associated with organ failure. And unfortunately, we can't prevent it even despite intensive organ support. So with organ failure, obviously, historically we know that we have 6 organs that have one or more parameters that define its function or failure, and usually clinicians in the ICU would use these variables to identify organ failure. As you can see, they have 6 organs here, and historically also we have had many tools to assess organ dysfunction. Out of the ones which we use widely in our ICUs as Apache and SOFA, there are a number of others that have been developed over years. But the most interesting thing is that none of these include the gut. And talking about gut failure, I'll take you to my life-threatening case of gut failure where some time ago we had a lady who came into our ICU, a 51-year-old female who had a posterior fossa tumor resection in her brain, which was an extensive neurosurgical procedure. As you know, these patients usually come in post-operatively to the ICU just for a few weeks or days, depending on how they recover. Because she had an increased intracranial pressure, some brain swelling, she had an extraventricular drain. Obviously, she was very drowsy, so she was intubated, and she was doing fine. She was just following just having the usual recovery phase after any neurosurgical patient has. She was enterally fed to target at that point. And she was very stable. On day 5, suddenly we saw that she suddenly had deterioration. She had a surge response suggesting some sort of an inflammation trigger, positive blood culture. Her blood sugar started to go up, so she started to require insulin to manage that. And she started having decompensated renal failure and respiratory failure as well, because of which she had the organ support, as you can imagine. And she also had some abdominal signs like abdominal distension, abdominal hypertension, and increased gastric residual volumes, which is the only surrogate marker that most ICUs would be still using. And our threshold is about 500. So her gastric residual volumes were way beyond 500. If we do a CT scan of a patient with abdominal distension, sometimes you can see distended bowel loops like this. Obviously, with an X-ray. With a CT scan, you'll probably see some gas in the peritoneum, which is called pneumatosis. And sometimes these patients can have a more worst diagnosis like non-occlusive mesenteric ischemia called NOMI, which is a necrotic bowel. And even on an histology specimen, you might see loss of mucosal layer, inflammation, and gas in the wall, which suggests that gut dysfunction and injury is a feature of critical illness. Or maybe do I say it's the other way around? Does critical illness drive gut failure? And there might be a number of factors which could be driving gut failure, like fluid therapy. So inadequate fluid therapy can cause a hyperperfusion to the gut, but excess can cause bowel edema. When patients are null by mouth for a long periods of time, that can cause mucosal atrophy in the gut. Aggressive enteral feeding can trigger gut ischemia as well. High-dose inotropes can trigger ischemia. Narcotics or sedatives given to patients in the ICU can lead to slow gut transit and ileus as well. And antibiotics, which are either given prophylactically or postoperatively, can disrupt the normal gut microbiome, as you have seen, and cause dysbiosis. So it could be any of these factors. So coming back to a patient, when she started to deteriorate, she suddenly had a high vasopressor dose, which escalated to almost 4.5 mg per hour. That's the unit we use in our ICU. But if you convert it to a micrograms per kg per hour, which was more than 2.38, which is a significant dose, at that point she was enterally fed to target. Her serum lactate started to rise more than 2 millimoles per liter, which is quite high in a critically ill patient. She did have signs, as discussed, abdominal distension, gastric residual volumes, suggesting something was going on in the gut. And she had an episode of GI bleed suggesting the stress to the mucosa as well. And this was in a span of anywhere between 12 to 24 hours. At some point, we had to stop her enterally feed, but that happened much later after all this had occurred. The damage was too quick, and by then it was quite late. So luckily, she did come out of it. She had gone for a surgical procedure. She went for a laparotomy. She had 7 segments resected. She had a necrotic bowel. And she actually ended up in a lot of fluid and electrolyte derangement during that time. I think she was discharged from the ICU, but she was in the ward for several weeks. Luckily, she survived. Many don't. So what really happened, just understanding gut dysfunction and critical illness is an important thing for clinicians who work in an ICU. So I'll just briefly touch upon that. So gut dysfunction is common and complex, but it's a wide spectrum. You may have patients anywhere between mild gut dysfunction, which is nausea, vomiting, reflux, which is a very post-operative kind of a scenario, and almost 2/3 of the patients will suffer from that. You really don't have to treat that too much. It might be treated conservatively or will resolve on its own. This is moderate gut dysfunction is a very typical ICU picture, which you might see in many of your patients, as you can see there, slow gut motility, feeding intolerance, and about 1/3 of the patients do suffer from this. But a very small fraction of patients will suffer gut failure or non-occlusive mesenteric ischemia called NOMI, which can lead to perforation, peritonitis, or even sepsis. And this has a very fatal outcome. So in 2020, one of the authors, Riantham Blasser, who's a very well-known author around this area, who we've briefly collaborated with as well, she published this scoping review and agenda and had a framework in her article which was talked about an underlying mechanism that leads to a clinical effect or manifestation in the ICU can lead to a life-threatening condition. So for example, the underlying mechanism like impaired gut motility, as you can see here, can lead to gastroparesis or lower GI paralysis or feeding intolerance, which is manifested. If it's not treated or addressed early on or at the right time, then it can lead to Ogilvie syndrome or GI tract perforation, which obviously leads to worsening clinical outcomes. So we do understand that gut dysfunction impacts clinical outcome from a range of mechanisms. But do we know if we can assess gut dysfunction? Yes, there are methods that have assessed gut dysfunction. Clinically, we use signs and symptoms at the bedside as we would normally do in any ICU. Radiological assessment, which is your CT scans, which are done, which are great. They are very definite. But just remember that they do happen only at the end of a spectrum when the damage has occurred. So you would normally do a CT scan if you want to take a patient for a laparotomy, but not necessarily from a diagnostic perspective. They are expensive, they are time consuming, and also exposing the patient to a lot of radiation. Laboratory test, yes, we have serum lactate. Again, serum lactate just defines global perfusion. So perfusion in your body, but not necessarily at the gut level. And if you give a bit of fluid, your serum lactate can reverse easily. So maybe not the most reliable marker. From a research perspective, there are a number of tests that are listed here, but these are cumbersome. They have inter-rater variability and can be exposed to methodological errors. So we are not very sure whether there can be an ICU bedside technique to assess gut dysfunction. The second one, which is tonometry, I'll just talk to you about that, was a very useful tool used in the 1980s, where you have a balloon catheter like this, which was inserted at the end of a nasogastric tube and down into the lumen. And at that time, you would just use a fancy equation to convert, to understand the oxygen levels at the gut, in the gut. But this was it was a potentially useful tool, but it was very cumbersome and there was a lot of interpretation errors that happened. So in the 90s, it was completely abandoned. So going back to the research methods, we have some upcoming attention with biomarkers. So there's a lot of emerging work that has been done with biomarkers, whether these are more gut specific, and I think there's more work to be done, but definitely these are the ones that might be more reliable. But in general, none of these are useful at the bedside. So overall, we have no agreed established method to score gut dysfunction and critical illness. Last year, we published a paper, in 2020, we published a paper on gut dysfunction and critical illness, and we reviewed all the scoring tools which were available, not just in the ICU. And we found 14 scoring tools which were not useful in the ICU setting, poor quality, poor to moderate quality, and did not have adequate validation. So we did not feel any of these tools were useful at the bedside. So how do we feed our patients? If we don't know how to assess them, we don't know how to feed them. We need to be careful about how we enterally feed our patients. So most of the times enteral feeding is good, and any of these patients or any of these conditions listed here these patients should get enteral feeding. Anyone with an intact GI tract, You just got to use it and feed enterally. So a lot of the guidelines, which is from the ESICM guidelines, PS Singer's ICU guidelines, also suggest feeding enterally early on, trying to reach target within the first few days is very, very important. So we need to try and keep doing that. Again, Rientam's paper on a scoping review and research agenda suggested that enteral feeding does preserve gut immunity, keeps the gut viable, and prevents bacterial overgrowth, which we all know it's not new knowledge. But also there have been certain areas that have not been covered in terms of patient-centered outcomes, so more work is needed on that. In our meta-analysis that we published last year, where we looked at the impact of enteral and fluid individually on the severity of gut dysfunction, we found that vomiting was much higher in enteral feeding patients, which is a mild form of gut dysfunction. But that when we looked at the timing of feeding, and when patients were fed earlier, vomiting was much lower in patients who were fed earlier compared to delayed feeding. And you can see that was also a significant result. So any of these conditions, if your patients suffer in the ICU, you just need to use enteral feeding as the first line of intervention. So there's no kind of second thoughts to that. But there are conditions when enteral feeding can be slightly bad, or you just need to be a bit more cautious of how you're doing it. So these are the conditions where enteral feeding might be a bit tricky, and you have to use your clinical judgment. In saying that, there was a review paper that was published that you still want to enterally feed when the gut's not feeling good, particularly when there are no contraindications. And that is the best way to meet your protein and energy requirements. And in our meta-analysis, we looked at some other complications where enteral feeding did significantly reduce anastomotic leak and peritonitis. And that was quite a good significant result over here, as you can see. And again, when we looked at enteral feeding versus nose by mouth, also the events of anastomotic leak was almost half to that of nose by mouth regimes. So it does suggest that enteral feeding is definitely beneficial in complex problems as well, like leaks and things, where it can get the gut mucosa enterocyte. It can prevent gut mucosa enterocyte loss. So in these patients where there's moderate gut dysfunction, you need to try and trophic feed early with gradual increase to goal weight. And you may want to consider supplemental PN if you're worried about nutrition, especially if the patient is at risk or malnourished. But you need to keep regularly assessing for enteral nutrition eligibility. So in our ICU, our protocols do suggest that even if a patient is on PN, we need to assess enteral feeding on a daily basis. So we talk to the surgeons, we ask when can we trophic feed, when can we start trickling some feed down, even if it's 10 mils an hour, it doesn't matter. So from a historical point of view, gut rest strategy is no more relevant. Gut protective strategies is relevant, which suggests that trophic feeding is definitely beneficial, even with those with moderate gut dysfunction. And so is supplemental PN, which is no more a problem if you want to try and meet your patient's protein and energy requirements. Like historically, it used to be expensive and the risk of line infections, which is not an issue as much now because we do manage it better. So in the long term, it can be a cost-saving strategy, particularly when you are not able to feed your patients enterally up to goal weight. But there are times when enteral feeding can be really bad and ugly, and this is when your patient is unstable. He's bleeding, is in shock, the lactate's up the roof, or is a risk of bowel ischemia, or has high catecholamine use, which I'll talk about shortly. In these patients, you have to be really careful. And I'll address to the very classic study called the Nuturia trial, which was they had about 4,000 patients, fed patients on target feeding to day 1, high dose of vasopressors, and these patients developed severe complications like NOMI. Even though there were only a small fraction of patients on enteral, the mortality was almost 74%. And this is because with a number of factors like aggressive enteral feeding early in a patient who's unstable on high-dose vasopressors, there is a whole cascade of that gets triggered, which can actually impact and cause more severe gut ischemia or gut failure. And there is a bit of debate in the literature, and I refer to Paul's paper as well on enteral nutrition can be given to vasopressors versus Arabi's paper on it should not be given. So that's very interesting. So I think we need to, it's not a black and white answer. So we need to be very, very mindful about how we're assessing these patients. And Paul's paper addresses a very interesting chart which talks about a checklist kind of a thing where you want to keep an eye on the vasopressor dose, the resuscitation. Has the patient been resuscitated well? What's the lactate like? What are the signs of intolerance? And once you assess that, you might be able to make a better decision about when you want to start enteral feeding, even if it's trophic. And this problem associated with what happens at the gut level is just because there's an oxygen battle at the gut, and the tips of the villi who get the least oxygen level just die off. And then you might see that this disbalance leads to a necrotic bowel, which can be easily seen on CT or in an open laparotomy. We published a paper in the ANZ Journal of Surgery about this interesting combination of conservative fluid resuscitation and aggressive enteral feeding. So in patients who are not adequately resuscitated and a high vasopressor dose, aggressive feeding can be more damaging or more harmful than beneficial. So what do we do in these patients who have got severe gut dysfunction or life-threatening gut dysfunction? We need to hold off enteral feeding till the time we are confident to start trickling and their hemodynamic parameters have settled. You may want to start PN because these patients should not be left without nutrition for a long period of time. And in saying that, there is a position paper by Stanislaw Klek in the clinical nutrition about how you manage acute intestinal failure. Just being able to sort of start TPN for these patients is a lot of like a care framework that has been addressed in this paper. So a little bit about gut dysfunction, assessment, which I'm very passionate about. It is an area that we are trying to look into. It's an ambitious goal, and I know our colleagues in Estonia, Rient and Blasser, have had multiple attempts at that. They had published two scoring tools. They had developed two scoring tools. One was in 2012, which was a subjective scoring tool. Very recently, they published the gut dysfunction score, which is mainly based on subjective parameters. So I think even in daily practice, we assess patients subjectively at bedside. In our ICU, we do bedside assessments twice a day, which is done by nurses or a junior ICU team. And in last year, when we published a paper on the intensivist assessment of gut dysfunction, we were trying to understand what is the perceptions, attitudes, and approaches of intensivists across Australia and New Zealand on gut dysfunction. And what we found is that most intensivists don't use a scoring tool, don't assess the gut in a very structured manner, and would like to have a new scoring tool, which encouraged us a little bit. So at the moment, we don't have a validated score to assess the gut. We don't have a standardized protocol. And again, the scoping agenda suggests that current evidence on gut dysfunction is scarce, and we need to, this is because there are not adequate definitions to define it, and we need to use core sets of monitoring and outcomes which are required to improve in further studies. So what my study is looking at developing and validating a novel scoring tool, we're looking at a framework where we're looking at intraluminal pressure, which defines gut motility. We are looking at a panel of biomarkers which will look at mucosal cell injury, and we're looking at gastric electrophysiology, which is like a stomach ECG, which is called body surface gastric mapping, and clinical variables, which is signs and symptoms. And we will be looking at a correlation of all these in comparison to standard care, which is signs and symptoms. What we'll be doing is, this is something that we have done actually. We've done it in a few patients. We have screened them on admission, done all those three parameters, including signs and symptoms, at 3 time points. Early, within the first 72 hours, day 5 to 7, and day 7 to 10. And we're currently analyzing the data. In the second pilot, we'll be looking at more symptom-specific. So rather than doing it at time points that we have defined, we will do it based on the patient's symptoms. So maybe at the time when the patient has no symptoms. Oops, sorry. Okay, sorry. At the time when the patient has no symptoms, when they have an increase in symptoms, and then when the symptoms are resolving or go back to no symptoms. So we're still modifying the protocol to get to that point, sorry. So future steps, we'll be looking at hopefully validating the scoring tool in a prospective large study, maybe a multi-center study. And then at some point, if we do find a simple metric, we might be able to incorporate it into an organ severity tool, so that the seventh organ, the gut, can be included in an organ systems tool. So in conclusion, gut dysfunction is common in the ICU patient, but yet is a neglected organ. Feeding early but with caution is priority in the very sick and vulnerable patients, especially at the high risk of life-threatening gut failure. as ICU dietitians, we need to be very proactive in how we assess the patient and watch the gut. If your gut's working, you can feed them well. So I'll talk a little bit about the role of ICU dietitians tomorrow. Early trophic and supplemental PN may be the answer for severe cases of gut failure, not for all of them, not for all of your ICU patients. But gut dysfunction assessment and early diagnosis has become a priority at the moment, and we should address that. So it's an important task to get the gut a seat at the table. And just like historically how you assess the heart function through an ECG, troponin, blood pressure and heart rate, you might at some point have something very similar for the gut. And we have an amazing team of experts who work on this, not just scientists, but surgeons, intensivists, engineers, technicians, who work through this together, who have their heart, brain, and their guts into it. Thank you.
Thank you, Varsha. The floor is open for questions. I think there are no questions. Varsha, I would like to ask you one thing.
Sure.
You had been telling enteral nutrition with parenteral support. Have you ever tried the concentrated 1 ml 2 calorie solutions, and what is your experience with regard to the gut and the concentrated nutrition source?
Yes, we do use double strength feed for many of our patients, especially the head injury ones where they have they need fluid restriction and enough 4 molar salt to keep their intracranial pressure low and serum sodium high. So we do use concentrated feed, and it's kind of fine if your gut's working. But I think what happens is if these patients are having very sensitive gut, they're not even tolerating the 2 cal feed, even at like 20 mils an hour, which would probably give them about 50% of their calories. We would have to sort of look into, we might just stop it and restart and try and assess it again. But I think the combination of EN and supplemental PN is more for the ones where they've had a very severe abdominal event where the gut's just not accessible, and we can't feed these patients. Or if it's been contraindicated by the surgeon where we shouldn't be feeding these patients. It's mainly in those patients. But most of the times if the gut's working and we're trying to do that, we would use prokinetics, we would try and push for that, we'd use nasojejunal tubes. That's all imbibed in our protocol. So we would push for that, yeah. So definitely that intro feeding would be that first line of this. And sometimes we do switch to a moderate or a double strength feed to try and get the calories up. Yeah. But it's only in the severe cases where we might not be able to do that.
Okay. In our experience, previously we used to give 1 ml 1 calorie only initially. But if we have to reach more calorie in a shorter time, we always tried this and it has worked. Some patients, yes, even the 1 ml 1 calorie, they may not. We will try that, and then we may have to switch to a peptide formula. So, in your opinion, what about peptide formula?
Yeah, we used to use peptide formulas a lot, especially for pancreatitis patients and stuff. But of late we don't use that as much because I think collaboratively the evidence has sort of been a little that you can use a normal formula, except for the ones which are complex, like, if you have pancreatitis, we have malabsorption, long stay patients, very complex, we might use MCT or try to push for that. Yeah.
So your protocol doesn't have initiating everybody on a peptide formula?
No.
So you use the standard formula?
Standard formula, yeah.
And then switch to peptide formula
as needed, yeah.
And in peptide formula, again, you use only 1 ml 1 calorie, or have you stepped up?
We have the 1.5, which is which is vital, which is a 1.5 calorie MCT formula with peptides, and that works well for some of our patients with severe malabsorption or pancreatitis, where they're needing creon and things like that. With those patients, it does wonders. So we use for those patients. Yeah.
Thank you.
I would like to ask one question.
Sure.
Congratulations, Varsha, on your excellent presentation, and I really like your idea of getting the gut as one of the organs in SOFA score. You are using various biomarkers, you said. But I just hope that it shouldn't become too complicated for, commonplace ICUs to get the parameters to actually calculate the score. Like IL-6 in Nutrix score was actually one of the hampering biomarker. So what biomarkers you are using, just out of curiosity? That is one question. And secondly, you mentioned about intraluminal pressures. But what about intra-abdominal pressures, whether they are of any use at all?
Great question. Yes, intra-abdominal pressure is an area that, it's a numerical, value, but it is intravesical, so it goes through the bladder, right? What we're looking at intraluminal pressure is in the lumen of the gut. And one of the things, I've done a review on intra-abdominal pressure as well, which I am still working on. I haven't published it yet. And I think in that, it just kind of suggests that it may or may not be an indicator of gut dysfunction because it's so influenced by fluid. And because it goes through the bladder, many of our ICU patients may be having kidney impairment. In those patients, the risk of infection can be a problem. So it's slightly invasive as well. Whereas the intraluminal pressure, all these devices, which I should have mentioned, are non-invasive. So what we're trying to look at is get a bedside easy monitor, which may be non-invasive and can be easily interpreted at the bedside. And it may not be all of it. It may just be a simple blood parameter to assess that. But just like how you have, for the brain, you might use a intracranial pressure monitor, but you still use an EEG if you need to look at a more intense, complex assessment. Just trying to get a similar version for the gut as well.
And what biomarkers?
It could be, we are looking at a panel, citrulline, IFAB, and D-lactate, and some microRNA as well. So just to see which ones are more specific. And, it could be one or it could be a panel. So still looking into that. Yeah. Okay. Thank you.
Thank you, because we are running out of time.
Yeah, sure.
I was told to keep the question sessions at the end. Yeah. Thank you very much, Varsha.
Thank you. Thank you.
Can we give a round of applause for Varsha?
Professor Matt Berger will be doing a virtual presentation. Thank you.
Good morning, dear Pensa colleagues. It's a honor and a pleasure for me, Dr. Bender, to be able to share with you the state of the art as I perceive it in critical care and metabolic support. I'm an intensive care physician, and retired from clinics, but having been doing that job for close to 40 years. My conflicts of interest, it's mainly actually that I've been member of guidelines groups, and of course, this will impact what I'm going to tell you. Well, what is medical nutrition therapy? It includes clinical examination, edema, skin integrity, assessment of nutritional risk. We're using an investigator because it's really metabolically related. It's managing fluid and electrolytes, detecting leafy syndrome, measuring phosphate, glucose control, delivering continuous insulin when required, and feeding. It's one of the issues, choosing the optimal composition also of the products, and monitoring. So medical nutrition therapy, it's about adapting to the individual by combining all these tools. Our patients are not the same, all of them. We know from Nutrition Day that only half of them have been eating normally when they come to us. All the others have eaten very low amounts of food. And this is associated with a worse outcome. In our own ICU, we were using NIS2 in the long-stay critical ill patients to detect those where we might do something. And out of 150 patients who stayed more than 10 days, we realized that close to half of them were actually with NRS scores 5, 6, and 7, meaning what the ESPN guidelines say would be the risk in the critical ICU. Well, in red, you see the mortality of those patients. Clearly, 90 days, those who enter with a nutrition risk. There was no difference in the Apache and so on, so the trick score wouldn't have captured this. And we know, and this is very important with our guidelines, that there are different stages of disease. The early phase where a patient comes in unstable, etc., the patients are catabolic, they are less an endocrine turmoil, and they do not respond well to extrinsic feeding. And then they turn into a stabilized period, hopefully responding to our treatments, and eventually go into anabolic phase for rehab, into a chronic phase, which is still catabolic. But you need to appreciate the stages before this, age, comorbidities, acute or chronic disease, and functional recovery. So mortality is not sufficient. And we have different routes where we can go on. We now have assessed the patient. What are we going to do? Does it matter? Well, no, that it's not as important anymore. Our patients, when they are real sick, they have a messy gastrointestinal tract, to put it simple. All the intestine is affected by severe disease due to our drugs, but due to the shock, due to the disease itself. So, not so easy to use it. Nevertheless, this recommendation we wrote already from years back at the SICM group, and we suggested, based on analysis of literature, to use early enteral nutrition in critically adult patients in general, rather than early parental nutrition or delaying enteral nutrition. And we even suggesting is a word which requires appreciation, using early enteral nutrition in patients in shock receiving vasopressors or inotropes when shock is controlled. Meaning not when you're ramping up sulfurides and norepinephrine. No way you should feed that patient and leave him alone. You wait 24, 48 hours until you have sorted it and worse on it. But we also stated, and this thing is very important, that when we start enteral nutrition, do not increase enteral nutrition in case of intolerance or new symptoms. And as to the target, do not aim to cover full energy target with all enteral nutrition. The optimal energy and protein target in the early phase is not known, and we're measuring with endocalorimetry only by day 3 or 4. So, this is what we stated then and which had been taken up in the ESPN guidelines. This study was published this year is a multicentric study coming from Spain, one more of their good studies, and it aimed prospectively to assess the tolerability and safety of enteral nutrition in patients on vasoactive drugs. They enrolled 200 patients, 15 of them required mechanic circulatory support, which means they were sick, and 73% had multi-organ dysfunction criteria. Mortality was 24%, good doctors and nurses. Look at what they did. Actually, this figure is very interesting. It shows the efficacy of enteral nutrition, the energy balance in the brain, and the dose of norepinephrine. So you can observe actually that, yes, the patients were not fed to 100% of their goal. 0 is here. But this is typically candidate for supplemental parental nutrition after a few days, from day 4 or 3 on, when you see that the gut is still not coping well, then you can consider topping up. But they showed this was safe. Yes, they had quite some trouble with this in the study, but the real complex and serious complications were in 0.5% of our patients. So you can do it. Our guidelines are quite okay. And it's important to know that the advantage of enteral nutrition is to have an impact on blood flow. If you look at patients here, at the start of enteral nutrition, and you measure splenic blood flow, you see it increases with enteral nutrition. It's not really changed with PM. There is specific impact, a good impact. This is the main nutritional effect of enteral nutrition, and the reason why we say, try, but only try, don't push it. And the Aspen guidelines say that, well, early, within 48 hours, is to be started, rather than early PM. The patient doesn't need really us giving much energy during this period. But, of course, you may go for PM if it doesn't work. After 3 to 7 days, when we're not covering, we say, go for it. And no nutrition isn't a good idea. So clearly, we can do that. Equipoise has been shown by 2 large-size trials. The first is a pragmatic British trial, calories. They were considering that PM would be better. They included 240 patients on mechanical ventilation and went for a full target of 25 kilocalories per kilo already by day 1-2. No difference in mortality. PM had modest advantages, but significant, less hypoglycemia, less vomiting. Nutri-reactive. No severe patients. Septic shock, 2,100 also. Also for early feeding, by PM or EM infections, the same mortality, the same. Eventually, the number is a little bit smaller in PM, but look at this, much more, significantly more gastrointestinal complications. Pushing the gut early is not a good idea. So, continuous feeding we encourage, especially in the early phase, what the patient is best for after 1 week when he's stable is not the same. We're here talking about the critically ill patient who in the first week. And we use gastric excess. There's no real advantage to the other one. Sometimes you need it. And then you go past caloric, but okay, it's there to be used as a tool. And again, if a gut is not happy to tolerate and accommodate all this food, you can go for supplemental parental nutrition. This is a study which includes 317 patients after abdominal surgery. These patients are special. They have a complicated intra-abdominal infection, and 111 were qualified as at risk. Only SPM was delivered within 2 days. And they looked at what happened, late being after 1 week. Look here, the early patients with high risk of underfeeding had significantly lower mortality. Again, if you let a patient who is at risk or is admitted go without sufficient energy, it will not work. Here, it's not critically ill patients, all of them. It's complicated surgical patients. And they do have no results. How much? Well, this is an important question. And what we recommend is that if we have injury calorimetry, isocaloric should be provided. If you don't have injury calorimetry, which is the majority of you, go for 70% of your goal during the first week. Hey, equation is problematic as the old fever inadapted goes. After day 3, we all increase, meaning that even when we have a direct care, we don't use it before day 3, 4, but as we are ramping up our feeding delivery, both fluids, we do not risk overfeeding, but then it becomes important. And underfeeding is important, so you should consider alternative strategies. This is the aggregation of the results of 2 studies, one conducted in New Zealand and one conducted in Israel by Pensa. And when we aggregated this, we could see that when the cumulative energy deficit was minus 4,000, it was not a problem. Absolutely not a problem. If we have a flu, we can wait 2 or 3 days without having full feeding. No problem. But as soon as you increase the deficit, something starts happening in these sick patients. They accumulate a second disease, which is underfeeding, and by minus 10,000, which is roughly minus 130 kilocalories per kilo weight, all have complications which can be attributed to acute underfeeding, such as ventilator-associated pneumonia, infection, or surgical complications. Look here at this number. Between 4 and 8,000, we have minus 4,000. This number is important because you will not be able to do catch-up feeding. So you have to intervene before you get further. Now this was done in an American trial in surgical patients again, where they categorized their patients according to a low energy deficit, below minus 6,000, or high. They also calculated protein deficit with a goal of 1.2 gram kilo. And what you can observe is that there is a lower hospital mortality, lower 30-day mortality, and you triple the number of patients discharged to home if you have fed them reasonably. Not only fed, reasonably. And this is why we actually say the goal is very important to have, and there are now 3 meta-analyses out there regarding trials which have been conducted with goals directed by direct calorimetry with adaptations over time. And we now at P.03 for reduction of mortality. This is not a joke anymore. People say there is no evidence, they're lying. And this was another one. Yes, clearly, it's evidence. Mortality is reduced. We are telling that you should not progress too fast. Very important. This study comes from New Zealand. Our physiologist designed it, looked up here. And when we published this over 20 years back, we were really bad at enteral feeding. Here we have a group of 40-year-old trauma patients. On day 3, we were totally starved. Sorry to say that was the case at that time. Energy expenditure, 1800, a little bit over prediction. Endogenous glucose production, because we use traces, 3.1 million kilo a minute. If you calculate per hour per day and translate, it's 310 grams of sugar produced endogenously per day, which is 1,200 calories. 2/3 of the needs are covered. It has a price, it's protein contamination. We repeated this in other patients. Here we have a column almost all trauma patients. These are the partially fed SPM2 study patients, and totally fed, all of them, by day 9. If you look at what happens, you observe that you have a curve of endogenous glucose production. There are no critical data for the first 2 days, but here we clearly have evidence that this happens. And we know this for 30 years. So, if you integrate this, now, let's say we measure total energy expenditure. There is an endogenous energy production which covers, well, variable amounts. If you attempt to full feed all from day 1, as was done in calories, as was done in nutrition, as was done in independent, you overfeed. And that's bad. The organism is not able to populate. What should you be using? Well, for sake of time, I'm not going to say very much about it. we stay with the 1.3 gram protein per kilo per day. There are evidences for that. There are yet no evidences for higher amounts. So we maintain this. We maintain that glutamine is important in nutritional doses for the patient depending on PM130. And we also maintain that omega-3 should be given. And then micronutrients away from. To avoid all essential micronutrients and treat deficiency. They are part of the puzzle, and without them, it's not working. So clearly, you need to address it, and you need to do determinations. And there are two micronutrients which are special in critical illness. All our patients end up with anemia. Now, for multiple reasons. And actually, we remind in the 2022 guidelines that all patients should receive daily iron. It's easy, but also painful. You probably know that in the United States and Canada, they have multi-traceable products without iron. It's a shame. But it's ancient beliefs. And we insist that if you have anemia, if you have a determination of a true deficiency with low hepcidin levels, which has now become a marker of deficit, you should go for, this time, supplements of iron. And it's going to be a very strong consensus among us. Of course, we have to do a full look at it. There are risks with overload, but these patients are there. This study is actually supporting our guidelines. It's a very well conducted French randomized trial, 400 critically ill patients who are anemic, who have a low hepcidin, and they are not in the acute phase of disease. Their discharge is planned, meaning that they are on the descent of inflammation and infection, and they get 1 gram ferric carbon screening tools. Well, the primary endpoint is not significant. No statistics is needed to show that 33 days of stay are identical. But we had significant secondary endpoints, such as, beg your pardon, the day 90 mortality. And this is highly significant. These patients are doing much better as to recovery after the ICU. The other one on which we insist is thriving. And we insist on the liberal delivery of thyroid in the defense of acute disease. It is well absorbed, so you may deliver it entirely, but in critical care, you should go for 10 to 300 mg per day or admission. Look at this, it's a COVID study, it comes from Riyadh. It's not a randomized study. It's the patients were in two groups by judgment of the clinicians in charge. Some of them considered that the patient had not been eating properly the days before, and they delivered them 100 milligram as a mean of 5 meals per day, and others were not assessed as such, and look at the difference in mortality. It's tremendous, important. So, another of this not micronutrient is phosphate. It's not sufficiently often measured in many ICUs. And actually, if you go below 65 millimole per liter and have a significant drop, you should deliver the electrons, but you should reduce the progression of your feeding. And this was very nicely shown by the Australian study, where the patients were selected exactly on this criteria of decrease upon initiation of enteral or feeding of any type. And actually, if you look in the paper at how much phosphate they received, both groups received the same amount, but look at the mortality. It's not only about delivering sufficient phosphate, it is about managing the nutritional and metabolic state of the patients. So clearly, important to do. And this is what we did with the SPM study we did Geneva and Lausanne. We took the patients who had difficult feeding on day 3 and randomized them, meaning they hadn't been force-fed here. And believe me, delivered full feeding to measured value in SPM. And by that, doing that, we improved immunity. It's a separate paper, and we reduced infectious communication. This is in-label management. To summarize the strategy, now we know about, we've become aware about the immunogenesis production. If you compare it to the total image expenditure, of course there is a difference. But if you start progressively, softly, 10, 20 milliliters in a row, look at what happens. You can actually also, when it doesn't work, consider supplemental plant nutrition. You never exceed that. We now know that this overfeeding is real bad, but we have to monitor not to slip into the opposite, which is underfeeding. So with that, conclusions are examine the patient, consider history, consider enteral nutrition first. Shock and other conditions may require delaying or being very cautious or not making it work. Avoid early full feeding. Nutrient 3, which has been prevented in Paris, is shown because they continue doing full feeding early on. Water available. Risk of breathing syndrome and gastrointestinal complications are the result of it. If you have more calorie, calculate very simply 20 calories per kilo per day, then adapt, but to be reached over several days. We stay with 1.2, 1.3, with an individualized prescription and base medical nutrition therapy on objective data. And we monitor what the patient really has received, because there are such differences between what we prescribe and what they receive. So with that, best wishes from Switzerland, where we now have received some in the meetings. Wish you a great progress and I'd like to be with you. Thank you so much.
So we'll have the questions at the end of the symposium. We'll move ahead with the next part of this symposium. It's my pleasure to invite Dr. Robert Martindale from the Oregon Health and Science University with a special interest in surgical and critical care nutrition. So.
Okay, well, thank you. I know I'm taking the place of Pierre Singer in this time, though Pierre will be presented later on this afternoon. So thank you for the opportunity to deliver this speech today. It's on perioperative. Good. Glasses. And thank you. This is it? Okay, great. So mine will be on perioperative use of TPN. I've spent my entire life as a surgeon until the last 4 or 5 years really discussing how to use enteral feeding and not parenteral. I have to say, as we've gotten better on our selection of parenteral nutrition, we've got better substrates now in the use of parenteral nutrition, and I think that's what's nice, is we're starting to get more physiologic solutions. So we can go from there, again saying, okay? So we first have to ask the question, who do we need to feed? We clearly have shown in this paper, earlier work from Dr. Asrani showed us very nicely who not to feed. And again, excellent paper she presented, very nice. But then what route to feed? And again, our first choice should always be enteral. But then we have to ask the question, when we have to go to parenteral, what should we be doing and where and when? So if we look at that in the preoperative period, remember, prehabilitation is mainstream now. I think Dr. Wishmeyer will talk about that later today, is that it is no question that preoperative preparation, whether it be enteral or parenteral, really should be done, because that's the key. That's a time we've got them before their catabolic stress, which we can make a difference. So in the pre-op setting, really in the parenteral needed, we need 7 to 14 days to make a difference. If it's 24 hours and you got a semi-urgent case, you're wasting your time and you're setting yourself up for more problems. So if you can't give 7 to 14 days preoperative parenteral, and those who cannot take enteral, that's the key, only in those that not take enteral. And again, if we do give it less than 7 days, actually we end up with more complications associated with no benefit and probably some increased morbidity using it less than 7 days. Parenteral again, enteral is a whole different story. Today we're only talking about parenteral. Now the question then becomes, what about the immediate perioperative period? Remember, we're going to see patients urgently. Maybe we're going to see patients who've been in the ICU or been on the ward and now come to the operating room. And the question is, what do you do with a patient who shows up to your operating room or is on TPN when you make a decision for an urgent operation? You have two choices, right? One, you can stop the TPN during the surgery, knowing they're going to be stressed even worse than they're stressed now by the surgery itself. And in my goal, in my opera as a surgeon, as used to doing trauma and things, I stop the TPN when they come down for TET, and I stop it, and for 2 hours we measure glucose every 30 minutes. I think that's based because it's a problem, especially if we're using a soy-based intravenous lipid emulsion, because it's a pro-inflammatory state. So we're dealing with hyperglycemia during the case. Endogenous production, as Meta just talked to us about. And now we're adding more glucose on top of that. The following glucose is very difficult. So I like to shut it off. If you want to let it stay on, we have to deal with the intraoperative hyperglycemia. And then we also deal with the big volume shifts we get from that. Now, there is some animal studies giving small amounts of glucose actually protects lean body tissue during a catabolic stress. Again, early work, animal data only. No good human study showing we protect lean body mass by giving intraoperative TPN. So basically, we should shut it off, as the 2016 guidelines talked about. Now, what about in the first 24 to 48 hours? The patient is now post-op. Should we be doing it, as Matt very nicely showed, those first couple of days? Most of our requirements for energy are delivered to us by endogenous production. And really, that stems from this very nice graph done by Dr. Franco Carli early on, and I've changed that a bit. But as you can see from this, we've got 4 things that happen in perioperative period. Let me see if I can figure out where this is. Oh, here's the point. Okay. As you can see here, we got tissue trauma, mobilization of endogenous fuels. That's the big catch here. The mobilization of endogenous fuels really provides us with so much glucose, we don't want to add to that and make trouble, because we see most patients have significant insulin resistance, 50% of reduction in insulin sensitivity. So our insulin sensitivity drops significantly in that perioperative period with significant stress. There's the key, why we don't need to worry in that first 24 to 48 hours. That's the time we should stabilize those patients and not worry about it. So wrong way. So if we then go on from there, and the other big issue with parenteral nutrition is we have little idea of how parenteral nutrition affects the hypothalamus pituitary axis. We know that during stress, we have a significant release of neurochemicals from the brain that control energy and stress response and feeding and stress response. And we have no idea what parenteral has to do with this yet. This is early in the days knowing this response from the hypothalamic pituitary axis, and we're just beginning to learn what happens with enteral feeding, let alone parenteral, haven't been touched. I think we've got to be careful until we understand that role. Well, the guidelines, the ESPN guidelines, which I was lucky to be an American and involved in that because it's a great group who put together these guidelines. And what do we say in the post-op setting? What do we do? If the energy and nutrient requirements cannot be met enterally, that's the key, enteral first, okay? By the 3rd or 4th day, 3rd to 7th day, then we should add supplemental parenteral nutrition. Again, now, early versus late. And Meta mentioned this. This paper actually was published just a couple of weeks ago. A nice paper out of China. As you can see, what they did here was they measured it. They used delivering at 3 days versus 8 days. So they had early supplemental and late supplemental. This is a fairly large study, as you can see, 230 patients, 11 tertiary hospitals in China. And they showed actually in this patient, post-operative randomized trial, again about 115 in a group, they showed that early supplemental parenteral nutrition decreased nosocomial infections. But you look at that in routine GI surgery, this was pretty routine GI surgery, 18% nosocomial infection is pretty high. So we got to be a little careful there. That may be higher than what we normally see. We normally run in our place about 11%, and our severe GI upset, a big pancreas esophageal surgery, runs about 7 to 11%. So this is almost double that rate. So I think we need to wait and see more papers along the same line that early makes a difference. But I have to say, things are confusing now. The recent literature has really put things in a disarray, you might say, because we've got major changes. If we look at this, what do we see here? You see early versus late, Wheat-Vandenberg. We should say autophagy is shut off if we feed early. We shut off the normal endogenous utilization of non-functional proteins and lipids in our cell. Okay, the trophic feed showing us that 25% of the calories versus full feeds for the first week are equivalent. Okay, and then the redox trial with glutamine, and then supplemental height basically showed total infections, but again, most of those were not the infections we think about, not urinary tract, not pulmonary infections, not wound infections. Okay, then we see intro versus parenteral that Matt talked about, Renier will talk about that, and now the effort trial by Darren Halen is out, showing no benefit to added protein. So now what do? The things we thought we were going to win from, giving more protein, giving earlier feeding, have shown us no big benefit. So should we just give up? Or should we start going, let's look at this, let's break these down. This was presented by Renier. This is the Nutria 3 trial, just presented by Renier in Paris in October. As you can see, very nice, just presented. They did 1,500 patients fed low calories, low protein, and 1,500 patients fed a standard group. Look at this. They had faster recovery and fewer complications in the low-calorie, low-protein group. This is, again, what are we doing here? We're saying give fewer calories. Again, this is part of that whole early response to trauma and stress. I think we're starting to learn that the endogenous fuels provide us with early response, and we probably don't need to push our calories early. Very nice paper. You can see during this catabolic phase, we've got to be very careful and not overfeed, not give too many calories, and be very cautious. Well, what surgical populations benefit then the post-op period? We've talked about them already. Dr. Ashrani showed us, Dr. Perry showed very nice papers, very nice list of those. There's obstruction, enteral intolerance, bowel ischemia, intestinal hemorrhage, continued intestinal hemorrhage. And so it's pretty easy to see what benefits. But remember, we've got lots of benefits from enteral, and we don't want to fool ourselves that parenteral is going to make up the difference. We should try enteral, and as she mentioned, every day we should reassess if they're on parenteral and say, is today the day we can start enteral? When can we start enteral? Continuous question should be asked, as she mentioned. You know, the swing went from historic. I spent the early parts of my career, 35 years ago, I spent trying to convince surgeons and my colleagues to use the GI tract because parenteral was so common. And this paper here shows it very nicely. That in 2000, 26% of patients with the same injury severity scar were on TPN. By 2005, the data was out, the big studies were out, we only had 3%, and that's the same severity of illness. So we really changed that pretty dramatically just in 10 years, in 5 years in this case for the study. So we started using the GI tract. And then we started seeing this paper. We had 48 prospective randomized trials showing enteral is better than parenteral. And then Sheila Harvey comes with this study and shows us equal. I looked for every reason in the book to not believe this study. I started saying, come on, that can't be true. We've got all these studies, all this studies showing multiple benefits of enteral, but then Nutria 2 study came out, 2,400 patients, and Matt showed you this. And in fact, they tried hard within the first 24 hours and actually showed increased complication with enteral. But these were septic patients by very strict criteria for sepsis. So it shows us we can do safely with parenteral nutrition. So what's changed in parenteral that allows us to say it's probably equivalent? Is it equivalent? I'm not sure. Remember, enteral should still be first. Okay, but you can do safely parenteral. It's probably the variety of the solutions available to us. We now have mixed intravenous lipid emulsions. Instead of having pure soy base in America only in 2016, did we get a mixed lipid solution. But as you can see very nicely, now we also can get glutamine dipeptide, we can rearrange taurine, carnitine, etc. So I think we've got better solutions. We better understand hyperdynamic feeding. We better understand trace minerals. So we better understand antibiotics and antioxidants. So we're getting better at it. So now the question is carbohydrate, protein, or lipid. Well, with carbohydrates, again, we don't need to do much because of endogenous production. That first 3 to 7 days, endogenous production gives us our carbohydrates. Gluconeogenesis from liver production and from muscle breakdown is going to give us that carbohydrate. So we don't really need that. Okay, so now what about protein? That's the big key, right? Saving protein. The question is, should we be getting more protein? Well, the new Nutria study says maybe not. The Darren Halen's recent study on protein, maybe not. Doesn't make a big difference. But let's look at some of that. We saw this paper by Zudin Bhattacharya in 2013. Classic paper. He looked at protein loss in the ICU and those people in the ICU for a week and showed dramatic losses. As you can see, if you use rectus femoris ultrasound, 10%, all the way down to protein DNA ratios at 29% by a biopsy. 29% in 7 days of your lean body tissue, your actual is lost. If you measure DNA protein ratio, very good way to measure it. And you see significant inflammation. Inflammation is the key here, okay? So we started saying we got to push the protein. That was 2013. So we had all these papers starting 2014 using tracer technology, showing that maybe, except for this last one here, showing maybe we should push the protein. These are not all in the ICU, but we said, okay, we've got trials showing protein is accepted, protein is metabolized, let's give more protein. The American guidelines, which clearly I was a co-director of in 2016, not the new one, 2016, we said give more protein, give up to 2 grams a kilo per kilo if you can. We knew because we were trying to overcome anabolic resistance. Remember, the older folks and traumatized folks, it takes almost twice as much protein to turn on anabolism in the muscle. So, now what can we do to decrease muscle breakdown? Resistance exercise, if you have one take-home message today, is get your patients out of bed and walking. Literally, get them out of bed doing anything you can. If they can't get out of bed, use stretch bands in the ICU. Somehow, you've got to get muscle function. Decrease systemic intramuscular inflammation. Well, I'll show you some tricks on that. Specific fuels, and then method of delivery. But the key is, this is patients on ECMO. When they first told me in my ICU we're going to walk people on ECMO when they got cannulas in their carotid artery and vein, I thought, this is nuts. If somebody steps on that cannula, they're going to be dead in about 3 heartbeats. But we do it. And we do it now because we realize the benefit. Remember, in the hospital, 83% of the time the patient sits in bed. 83% of the time. Look at this. When you're sitting in bed, what happens? 76% reduction in insulin sensitivity. Post-absorptive muscle protein synthesis is decreased by 26%. Dramatic benefits to walking, exercising, using stretch bands, whatever you've got to do. You lose 2 to 3% of your protein per day when you don't walk. So you've got to walk. If you want to get that parenteral nutrition or intra-nutrition protein, you got to use it. What about lipids? We've got to think about lipids today as not just long-chain fats. We got to think of lipids as short chain, medium chain, and long chain. If we look at that, we now know that delivering of omega-3 fats preserves lean body tissue by multiple mechanisms: decreased inflammation, increased transporter, increased activation of the mTOR mechanism. We can increase muscle integrity and increase rate of recovery from injury with omega-3 fats. So we have single soy, so we're old soy-based, now we have a mixed lipid, and that's what we should be using, something with omega-3 fats, whether it be intra or parenteral. Because we look at the shift from pro-inflammatory to less inflammatory, the fish oil is clearly on the less inflammatory, but the only true anti-inflammatory lipid is butyrate and short-chain fatty acid. But remember, fish oils produce now SPMs. Many of you haven't heard about SPMs or resolvins, but that seems to be the new hot topic. The key, remember, as you show in Zuden Pupitari's paper, was inflammation. Inflammation was the key. And pretty much every organ is altered by inflammation, and every organ in the ICU is set up by inflammation. This beautiful study by the Swiss hospitals here, nice study by Merker, 2020, they took 1,900 patients and looked at inflammation and ability to accept nutrition. What did they show here? The ability to utilize nutrition. If you look at this graph here, the first one here shows nicely that there's a big benefit with intervention. Nutrition is favorable. This is unsurvivable. Okay? You can see here, this is overall for the study. This is low inflammation. Look at moderate inflammation. Dramatic benefit here of intervention with nutrition. This is focused in nutrition versus standard of care. Look at the difference. But here's the catch to this study. Look what happens in the severely inflamed population. You reverse it, and now giving nutrition may be in fact detrimental. So we've got to control inflammation. How do we do that nutritionally? We do it with one good way is with omega-3 fats. We know they decrease the inflammatory response as well as a myriad of other benefits. The key to that is we now know, based on work by Charlie Serhan, that fish oils are the on signal for resolution. They turn on resolution of inflammation. And it comes through multiple cascades. You can see if you've got fish oils on board, EPA, DHA, you make these resolvins, you make them in virtually every cell type there is, and you enhance tissue healing and repair and inflammation resolution. Knowing that resolution of inflammation is an active process, we know we can do that whether it's enteral or parenteral by giving fish oil. Okay? And you can see this is made in every tissue. This is not new data now. We've got 10 years of data on fish oils and resolution and short gain resolutions by EPA and DHA. You can see serum profiles, enhanced bacterial killing, enhanced conversion to an M2, which is a resolution macrophage, accelerates removal of inflammatory debris, and a myriad of effects of these resolvins or SPMs. This is new data, been out about 10 years now. Now the clinical data is coming out in the last couple of years. Don't worry about the anticoagulation. There's essentially no effect of anticoagulation in your surgical patients. So what should we say then? What's in as we finalize things here? Basically, in the perioperative period, we got to think about the GI function, the baseline nutritional status, and the expected duration of need. Enteral is always your first option, but parenteral clearly is beneficial now. We know it's good nutrition early on, but not really in the first 2 to 3 days. We don't need to worry about adding extra parenteral. Day 5, day 7, clearly if you're not getting to goal, then you add, but not a lot of it. I think if anything, getting to goal should not be a goal in the first 3 to 4 days. It should be delivering a little bit for the gut mucosa if possible, and then you can back slowly move it up the gut, as Matt Berger also talked to us about. Select your vascular device based on expected duration, monitor response to the therapy, and again, how do we monitor? As Dr. Vishwanath already showed us, there's no good data on what to do except monitor the patient to the bedside. Use every parameter we've got, oxygenation, hyperdynamics, etc., but there's no good biomarker for that. Transition to enteral as soon as you can. Every day you should be assessing for that. Resistance exercise is the biggest thing I'd like to say today. Everyone in the ICU should be doing some sort of resistance exercise. If they're ventilated and paralyzed, they can't do it themselves. Get the family members or the nurses will do physical therapy, or the physical therapist will come. Passive range of motion will even protect some of that lean body tissue loss. There's growing data to support that high protein early is not the answer. We don't need these high protein fuels early on. We need to give it in day 5 to day 6, day 7. During that rehab period, that's when you're going to show benefit. We know that prehabilitation works, whether it's enteral or parenteral. We know that the concept of early feeding is really for nutritional and non-nutritional benefit. The gut mucosa and the microbiome we talked about, resistance exercise already, but I think we're using more selective PN now. My own ICU, we've got 105 ICU beds at my hospital, and in our surgical ICU and trauma ICU, we used to run about 15%, 10 to 15%. We're now running about 20%. Back up. It's either sicker patients, but we're using much more parenteral than we used to, but it's almost always supplemental parenteral. We have better nutrients delivery now. We have mixed fuels. We have better protein mix. We have what we're using, how much we're using, and why. We know a better understanding of insulin resistance. And I think the key is that inflammation we go after, aggressively go after. And I think I'll leave you with this quote from Darwin. It's not the strongest or the most intelligent species that survive. It's the most adaptable to change. Thank you very much for your attention.
Thank you, Dr. Bob. It was a wonderful lecture by Dr. Dr. Paul Weischmeyer. I don't think he needs much of an introduction. You would have seen a lot of his publications and posts regarding the rehabilitation. So he's the professor of anesthesia and surgery, Duke University. And he has got a lot of achievements. I don't know whether I should read all the achievements. And the minute we think of perioperative nutrition, we always think of Dr. Paul Weischmeyer. Doctor, please take over.
Thank you. It's turn this way. It's wonderful. Can you hear me? Is my mic on? Just want to be sure. It's working. Thank you. I feel like I can hear myself. So it's wonderful to be with all of you here today, and it's really a joy to be back in person at Pensa. And I'm going to try to cover some of the things that the other experts, and we had a lot of great talks in this session, some of the things the other experts didn't cover, and maybe cover a touch of what Pierre Singer was going to talk about as well, because I think it's really critical. And so I'm going to try to talk about how we can overcome challenges and really improve outcomes for our patients with some of the new innovations and new developments and new studies in critical care nutrition. This is my alignments of interest. I'd like to believe that I'm not in conflict with the NIH or with the industry sponsors I work with or my mentor and mentee grants, but that we're in alignment to try to improve care for all of our patients. So as I always start my talks, I think it's critical that every day on rounds when we're in the ICU or on the surgical floors, that we always be thinking about not only what we're going to do for the patient that will help them get through today, but what are we going to do for the patient that's going to help them get through the rest of their lives? What's going to happen after they leave the ICU that's going to give them the opportunity to go back to a life that's meaningful, a life worth living? How are we going to create survivors of our patients as opposed to victims? Patients who perhaps never go home because they're too weak, too debilitated, or have other complications that lead them to be stuck in a nursing home or rehab center, never going back to their families. Because what our patients really want, of course, we know, is to be able to go home and walk down the street with the people they love again, holding their hand, or hold their grandchildren again. And so nutrition is clearly critical to that. We know that. We know nutrition and physical therapy are critical to patients' recovery, not just in the short term, but in the long term. But our patients are sicker than ever, and COVID-19, I think, has really emphasized that. And so it's gotten much harder to deliver nutrition. And as I think Bob said really well, it's more confusing. There's so many different studies you can look at. And so I'm going to try to look at what we're actually doing now and how we can perhaps do it better by personalizing it. And so what do we actually feed our patients now? Again, this goes back to data that hopefully most of you have seen. The International ICU Nutrition Survey is something that Darren Hyland does, and the Canadian group does about every other year. Dietitians collect this data, and it's always the same. It shows that we feed about 50%, of our patients' needs, not just for the first few days. We probably should be reducing our calories, but for the first 2 weeks, we're giving half of what our patients need, which is terrifying if you think about it. And when it comes to protein delivery, we give about half to a third of what our patients need, not for the first few days, but for the first 2 weeks. And so this poor feeding, and I'm going to show you in COVID, it's even worse. In fact, it's going to scare you that any patients ever get better from COVID in the ICU when you see what we feed them. and why long COVID may be a bigger issue than we thought it would be. But again, we're underfeeding for long periods of time, and so we need to be better. We really need to improve, but how can we do that? Well, I think the first thing we need to realize is one-size nutrition does not fit all. We have to step into the next generation of critical care nutrition and personalize our ICU nutrition strategy, right? We wouldn't give vasopressors without measuring a blood pressure, or we wouldn't give patients on ventilators changes in their ventilator without measuring a blood gas or a saturation. So why would we give nutrition without actually measuring what our patients needs and the effect it's having on them? And so I think we need to be measuring. If we want people to take nutrition seriously in the hospital and the ICU, we need to do the things and have objective data like our cardiologists and our pulmonologists and our other physicians and other organ systems in our ICU have. And this was a paper that John Louis Vincent asked me to edit a whole issue on critical care nutrition personalization in the Current Opinion in Critical Care Journal. And this was the editorial I wrote on this. I'm happy to send you this paper if you would like it. I'll show you my email at the end. But we have to be able to measure things. And how can we put this into practice? What do our new guidelines say? And what can new data show us? Well, I think to talk about this, I want to tell you about one of the very first COVID patients that I cared for at Duke in the U.S. This was in 2020. It was in March, end of March, beginning of April. And the patient's name was Elijah. And he was a 49-year-old African-American science professor. We have a lot of universities near where I live. And both his other family members were also positive for COVID. And he came in on minimal amounts of oxygen, but unfortunately he progressed very quickly to rapid respiratory decompensation. He was tachypnic, he was hypoxic, and ultimately he got intubated and was very hypoxic on the ventilator. It was desynchronous, and ultimately we had to paralyze him, and we had to neuromuscularly block him in order to ventilate him. And of course we did what many of you are probably doing, is we had to turn him prone as well. And so this creates a lot of challenges to feeding and a lot of challenges to care in general. And so this is what his vital signs looked like after this. His blood pressure was adequate. He's on a little bit of Levophed, likely due to the sedation we were giving him more than the COVID or the sepsis. But his mixed venous was adequate and his lactate was normal. And so what do our recommendations say? And this is, I think, true for all ICU patients who are critically ill, not just in COVID. I think Bob and others, I think you guys did a great job with these guidelines coming out so quickly. And so I think this is brilliant. We want to start enteral nutrition just like we always have. Within 24 to 36 hours, I think it's great that we encourage people to use NG. They found 95% of the world feeds the stomach as opposed to post-pyloric feeding. And so I think this encouraged people they could start simple. And so what about this pressor issue? And you've heard other speakers touch on this. What about feeding on vasopressors? Is patients on vasopressors? And is it safe? And is it perhaps beneficial even? As you saw from the first lecture, I was right before the pandemic asked to write this pro-con on the benefits of or the risks of enteral nutrition in vasopressor receiving patients. And so I reviewed the literature. I hadn't done this in years. I reviewed the whole literature and I found some pretty striking things that not only is feeding on vasopressors likely safe if done in resuscitated patients, but it saves lives. It saves lives. And I'll show you the data for why I'm saying that. So this is the data. There's a lot of small trials that have been done that show benefits, but this is a large trial. 52,000 patients in a Japanese database. We actually recruited one of these statisticians away from this group that works with our group now. And they looked at patients who got enteral nutrition within 2 days on vasopressors like norepinephrine, or that waited beyond 2 days to get fed in some fashion, not to goal or anything, but just some enteral feeding. And what they found was that 28-day mortality was significantly lower in the early enteral nutrition group at low doses of norepinephrine, 0.1 mics per kilo per minute or less. At medium dose norepinephrine, 0.1 to 0.3 mics per kilo. This is higher than a lot of us would feed, although this data would be compelling to say maybe in resuscitated patients we should. And even at the high dose norepinephrine, there was no difference in outcomes. Again, this was a very small group though, so it's hard to make conclusions. But the results show that early enteral nutrition seemed to reduce mortality. It saved lives when we fed people. And I think one of the key takeaways from this is that if you look at some of the smaller trials, there's trials that compare full feeding on pressors to trophic feeding on pressors, and the patients in the trophic feeding typically do much better if they're trophically fed while they're on pressors. And this is likely the non-nutritional value of nutrition. You've heard other people say it. It does a lot of things. It's good for dysbiosis. It reduces intestinal permeability. It reduces the translocation of toxins into the lymph that injure our lungs. And just the fact of having protein or fat in your stomach causes vagus signaling, which is anti-inflammatory to the rest of the periphery and to the rest of the body. And so again, how to do this safely, I won't spend much time. You saw this chart before. Again, you want the patient to be resuscitated. That's critical. Lactate should be normal. The mixed venous should be normal. I think 0.1 to 0.3 is a safe dose to feed on. That's what I'm using now. And different pressors I found have different effects on the gut, with norepinephrine being the safest and vasopressin and dopamine being the worst. Bob and I remember we used to use vasopressin as students and residents to stop GI bleeds. It's great at cutting the blood flow to the gut. So different pressors have different risks. Start slow. I follow gastric residuals in these patients. I'm not saying you need to follow gastric residuals all the time, but I do follow them. I think it's critical if you're going to feed someone on pressors to do that. And feed the stomach. Don't feed patients on pressors postpylorically. You have no way to monitor for gut ischemia. So again, I just want to reiterate that. Feed the stomach, not the small bowel. Follow intolerance signs. Follow gastric residuals. This is the best monitor for perfusion. What about in the paralyzed patient? Well, this same group in Japan looked at this as well and found, again, patients paralyzed with neurovascular blockers should also receive early enteral nutrition, and it reduces mortality, reduces length of stay. So again, this is the same Japanese group using their database, showing that patients who were fed early when they were on a paralytic had significant reductions in mortality and significant reductions in length of stay without any adverse effects or pneumonias. And so again, patients who are paralyzed, I occasionally still get the question, wait, they're paralyzed, the gut's not going to work, right? And I always say, oh, no, again, the heart would stop if that was the case. The paralytics don't affect the gut. And so what about the prone patient, right? This is a question I got innumerable times at the beginning of the pandemic. It was the first time many people had ever proned or turned over a patient. And of course, we had great guidance from Aspen saying you can feed prone patients. And we did at Duke, and I know people did around the world. I got a lot of feedback that people very successfully fed prone patients. We tipped them up a little bit so that they're less likely to regurgitate, but we were successful in feeding a good number of our prone patients. Now, how to personalize all of this, how to make this really count as it does in other areas of critical care like pulmonary and in our pressor doses. So how much to feed, right? That's always the question. And this was our recommendation, start slow, and I think this is very true, and then advance to goal. But I think the reality is we need objective measurements to guide us. We need to be making measurements like, again, we do for pressors or we do with blood gases. And this is, I'm going to show you, especially true in COVID-19. We can't guess, which is what we're doing now. Our equations are inaccurate, I should say, more than 50% of the time. A third of the time you're underfeeding, a third of the time you're overfeeding. McClave drilled this into me when I was young, and maybe you get lucky and flip a coin and get close some of the times. I'll show you it's actually almost none of the times in a minute. And our equations performance are abysmal, 12, 25, 30%. Even the Penn State, which many think is the best, is maybe 40%, which is worse than flipping a coin to guide your delivery of calories. We can't guess, and we are right now. So what do our guidelines say about this? Well, they say we should be using metabolic cart. All our guidelines have said this. I won't reiterate it. Other people have said it. And in COVID-19, we realized at Duke that we needed data, that we needed to understand this new disease we'd never seen before. And so even the guidelines from Espen said you could do metabolic carts in COVID patients, and I'm going to show you we did that. And again, as you heard Meta say, there's numerous now meta-analyses showing that metabolic cart use reduces death. This is a better way to feed people, the data continues to say. And it just makes more sense. But the problem is, aren't they inaccurate or hard to calibrate? They take forever to use. They're very expensive. You have to have a respiratory therapist there. There's a lot of patients you can't measure. Well, a lot of us around the world realized this about 4 years ago. And we said we need to build a better metabolic cart. As Galileo said, measure what is measurable, and if it's not measurable, make it so. And so Claude Prichard and Meta Broder and others led a charge that I was honored to be a part of to get funding from Espen to build the better metabolic cart that we always needed. And so that's now been done. We validated it right before COVID. There's a new device that measures in 15 minutes. It calibrates itself in 5 minutes. It's about this big. We actually are doing a study for the Army. They're going to put it in forward Army units soon because they're so small and easy to use, and they're so reliable. It's accurate within 3%, calibrated by mass spec, so it's highly accurate. It's easy to use. You can use it in ventilated and non-ventilated patients. This is what it looks like. This is the device. I have 3 of them at Duke that we had right before the pandemic that we were about to start a study with. And then when the pandemic came, we switched to all COVID patient research. And so that was John Mullinger. He spent thousands of hours in COVID rooms making these measurements before we had a vaccine. He's really a hero. It was the first longitudinal data that we knew of in the world. So our first question was, are patients really quite hypermetabolic because they look so sick? This is some of the sickest patients I've ever seen. Well, this is the patient I was telling you about. This is Elijah's measurements on day 4. He's not hypermetabolic. He's hypometabolic. He's 78% of predicted from our equations. Now, I have an excellent ICU dietitian who had him at 1440. She actually guessed because we underfeed on purpose at the beginning of ICU stay, and so she was really good on the first day. So what about as they progress through their care? Now we're on day 12. Notice what his caloric need is. He's severely hypermetabolic now, 165% of predicted, 35 kcals per kilo. We had to change his caloric delivery by almost 1,000 calories in just a few days. The next day, he gets more hypermetabolic. He's 200% of predicted. This is what the burn patients I used to care for look like. He's 45 kcals per kilo. There's no equation that could ever get near predicting this, right? You'd never be able to feed a patient like this. He dropped on day 18. Now he's less hypermetabolic. We had to adjust his feeding down to prevent overfeeding. And so then we had to remeasure. We have to remeasure people over time, right? Just like we check blood gases over time. And by day 23, he was quite hypermetabolic again. He was very challenging to feed, and I'll get to that in a minute. And actually, the RQ, of course, showed us we were underfeeding him because his RQ was so low, and so he was breaking down his own muscle to feed himself. And so again, there's a lot of things metabolic carts teach us. This is Krista Haynes. She's one of our superstar trainees at Duke. She's a nutrition member of our critical care team and our nutrition team. And she graphed the data in 3-day intervals versus the equation and the straight line there. This is impossible for an equation to predict. This is the variability we saw in our first set of COVID patients. And so I have an amazing set of research dietitians at Duke. If anybody would like to come visit us, we would love to have more. And so they took the data from the first about 40 patients out to week 7, and they looked at comparisons to equations in COVID patients. And I brought McClaven on this because I'll show you the data was so striking, I didn't know what to do with it. So we saw this significant hypermetabolism that not only started for the first 2 or 3 weeks, but persisted all the way to week 7. There was no ebb and flow in these COVID patients. And Steve's like, I've never seen this before in anything but a burn patient. And so again, they get quite hypermetabolic. If you compare it to the equations, right, this is what the metabolic cart measured in red. This is what Aspen would suggest. This is Penn State. This is Harris-Benedict and MSJ. They are useless. I wouldn't use them at all. You can see they're nowhere near what the patients need. And none of the equations do well, especially after the first week. They either overfeed or underfeed. The equations did really poorly. The other interesting thing we saw that we've never seen before is the non-obese patients got more and more hypermetabolic. The obese patients didn't change at all. We've not seen this before. We actually got a grant, one of our dietitians and Krista got a grant from Aspen called the Leap On trial to look at this and compare obese patients to non-obese patients longitudinally. So we'll see. So again, the hypermetabolism of COVID is quite unique and is quite severe and it's quite persistent. And it seems to be different in obesity and non-obesity. And so I think this shows us how critical indirect calometry is. If it's not available, Penn State seems to be the best, but it gets really poor after about the 2nd or 3rd week, just like the other ones do. This is how we've now suggested to combine feeding and metabolic cart measurements. This is a graph I published in a paper I'm happy to send you. I worked on this with a number of Europeans, Arthur Van Zandt and Elizabeth Devalle, to put this together, and this is how we have begun to structure. Every time a patient has a clinical change, basically, you want to be making a metabolic cart measurement. So the patient is hard to feed. Our COVID patients were often hard to feed. He had big residuals. He was stuck on trophic. He was being underfed, breaking down his muscle. So what do we have to do for this patient, right? You can guess. Ian is often, this is true in all our ICU patients, Ian is often not at goal. And of course, feeding these patients can be very, very difficult. COVID involves the GI tract. I had some patients at Duke in the first month that were COVID positive from their stool, but not from their nose. And so it's really interesting. COVID affects the GI tract pretty severely as well. And so we wanted to look at, is this just something I'm seeing at Duke that these patients are so hard to feed, or is this universal? So we pulled from a big database in the US, the Premier database. We got a segment of data that had 75 hospitals and all their COVID patients, 265,000 COVID patients who were hospitalized. We found about 850 who were on the ventilator at any given time for more than a day. And we looked at how many patients were fed within 3 days and what happened to them, outcomes, and how many took longer than 3 days to feed. We figure 3 days is probably a fair time to get someone fed who's this sick. And so we said, we'll give them 3 days and we'll see what the differences are. We found that about 40% of COVID patients in the United States were fed nothing, and this includes PN because we can see that, nothing for more than 3 days. The average time to feeding in a COVID patient in the United States, from the data set we got, was about 10 days. 10 days they were starved. So that's terrifying. And so these patients clearly are harder to feed than even our ICU patients. I worry this is happening in more patients than we think in the ICU in hospitals, because this data draws from private and public and small and big and all different size hospitals, not just research hospitals. But we did find if you fed early in COVID, within 3 days, not 48 hours or 24 hours, better outcomes we saw across the board. Less time in the vent, less time in the ICU. This is controlling for acuity of illness and all the other variables. We have really great statisticians doing this data, and reduced length of stay. So again, if you can't feed people enterally, because these patients are very hard to feed, of course, the guidelines suggest switching to PN perhaps even earlier than you did before. And I would agree with that. And again, I just want to reiterate, Bob covered this nicely, but I think it's important, this is a message to take away. TPN does not increase infection risk in 2022. There's 4 large trials in big journals you've read, New England, Lancet, JAMA, thousands of ICU patients. It's just as safe to put TPN through a central line as it is saline through a central line. So don't ever not use it because you're somehow fearful it will cause infection, right? And our guidelines from Aspen, although I don't love everything about them. I think there's things we can continue to do better, but I love some things, and this one I really like. I think this is one of the best recommendations we've made, and there's no difference between EN and PN in terms of risk, so you can use them interchangeably. Start EN first, but if you can't do it, PN is totally safe. So one of the things that happened in this patient that I think is really important, and I have not heard many people talk about, and we just published it, is Elijah went into renal failure and ended up on CRRT, which happens to a lot of our ICU patients, continuous renal replacement therapy, right? And then he developed a really awful complication. He got pancytopenic and neutropenic, so to the point where we were afraid he was going to die of it. And we ruled out all the drug-related causes of low white count, low platelets, low blood count was almost. Ultimately, what might the CRT machine be doing to the patient that caused this life-threatening complication? It causes loss of copper and other micronutrients. His copper level was almost undetectable, and this leads to severe bone marrow suppression. So we gave back copper IV, cost about a quarter, and his white count came right back up. So what I didn't know, many people don't know, and I didn't learn this until I was in a burn unit about 2-3 years ago, was that vitamins and nutrient losses are severe from CRT. It's like a hole in the bucket. It's a dumb kidney. It just, the micronutrients and water-soluble vitamins and amino acids just drain out the bottom out of the patient. The CRT machine doesn't know what to do with them. That's why you need to feed more protein to patients that are on CRT. You lose about 30% of your protein load. And you lose all these water-soluble and trace elements. And you can get severe pancytopenia from the B vitamins and copper deficiency. I've seen 5 patients now at Duke over 2 years who got stroke workup, CTs, MRIs, because they wouldn't wake up. Their B6 was 0 from being on CRT. Give B6 back, they wake right up. Costs about $1. Thiamine and other vitamins can too. If copper is deficient for more than a few weeks to a few months, you can get permanent weakness, right? We know this from our obesity patients who don't take their vitamins. They get permanent neuromuscular weakness. And I always wonder how many of our patients with ICU-acquired weakness who are on CRT for long periods actually were just copper deficient and no one noticed. And then, of course, you can get lactic acidosis from thiamine. So we looked at all the patients at Duke that we checked these levels on. We have a standard protocol now to check them at day 5 in everybody. And this is Megan Foss, she's one of our ICU fellows. And she found that 90% of patients on CRT are deficient within 5 days of one or more micronutrients and water-soluble vitamins. Virtually all of them become deficient in these keys. And so we found copper was the most common. B6 is also up there, but selenium and carnitine. Carnitine gets also quite deficient, very easy to replace, but not something you think of very often. The others were deficient in non-CRT patients pretty commonly too. Zinc, it doesn't get deficient in CRT because the solution is contaminated with zinc, I learned. Meta Berger taught me that. So we saw some signals for increased risks of mortality. Any patient who develops a micronutrient deficiency, CRT or not, had a 2.4-fold increased risk of mortality. Now, again, I think this is going to require a trial to actually validate that, but I think it shows you those risks. So Meta Berger and I and others, we wrote a paper on this, and one of the issues we wrote, and this is a great paper if you want to learn more about this, but you need to check these things or replete them or just create a standard repletion formula, and that's what we hope to do. So the last things I'm going to say, right, as patients get better, this is the time when nutrition really matters. They're not going to eat enough on their own. and their average intake is going to be really poor. And so we need things like high protein oral nutrition supplements. This is what every day I go in the room and I tell patients, drink that supplement before you eat any of that food. It's far more important. It's like a medicine. And we use only H&B containing supplements. I'll show you why I do for the most of our patients, aside for the diabetics. And then we use a lot of anabolic agents, which I'll talk about momentarily. We use an H&B containing supplement because of this large randomized trial showing reduced death at 3 months post-hospital in patients, and many, many patients studied in many, many centers. And again, every 20 patients you give this supplement to, you save a life. And so this is why this is the supplement 90% of our patients get, a high protein H&B containing supplement. But the last thing I'm going to talk about is the right nutrition enough to win the war, right? We know that caloric delivery will slow lean body mass loss, but it doesn't stop it. It doesn't stop it. Although if you come back to my next talk, I'm going to tell you maybe it can. But surviving critical illness and COVID is superhuman. Mother Nature never intended us to survive these things. Whether we get hit by the surgeon, whether we get hit by the tiger, or hit by the COVID, we're not supposed to survive this. We remain hypermetabolic and catabolic sometimes for years after an ICU stay. A burned child will be hypermetabolic for 2 years after they go home and their burn wound is closed. And so again, what are we going to do to combat this catabolism that persists, where everything we feed the patient turns into fat? And there's lots of data to show that feeding people after ICU, most of it turns into fat if you don't give it a signal to be anabolic. And so can we learn from our athletes, right? Because you can't look like this by eating right. But they know how to put on muscle better than anyone. Take the right anabolic agents. And so I started checking testosterone levels, and it's already published by others, not me. They're all severely deficient within 2 or 3 days, almost undetectable, right? So there's no anabolic signal as our patients recover in the recovery phase when they're on the floor. So you can feed them all you want, but they can't use it, we're finding. And the burn folks have known this for years. I've never been to a burn center in any third world country or any developing nation that didn't give oxandrolone. And the GLUE grant and the NIH studies have shown it reduces death, it improves wound healing, improves all kinds of outcomes. But the question is, if you're going to use it in large populations, it's safe. Doesn't it increase cardiovascular risk? Well, no, it does not if you're deficient. There's a 43,000 patient study from Kaiser in the US, a big hospital network, that showed that deficient people given testosterone replacement had less strokes, less heart attacks, and less cardiovascular events by a third. So it actually reduces your risk of cardiovascular stroke events. And so these are the doses that I use. I use these pretty routinely. We don't have oxandrolone at Duke, so I use testosterone. Oxandrolone is better for patients because it's purely anabolic. And so again, you've got to feed these people. So real quick, this is a paper. If you want to learn more about the doses, I'm happy to share. So again, I think it takes all the things. And as Bob said, I tell my patients every day, the only thing a bed is good for is to sleep in. If you're not asleep, I want you out of the bed. I want you in the chair. I want you up. We have to feed our patients, and we have to give them the anabolic signal they need for our patients to optimally survive. And then, of course, exercise is critical too, and I'll talk about that more this afternoon. So as I finish, if we're going to create survivors of patients and not victims, one size does not fit all. We have to step into the next level of critical care nutrition to bring ourselves up to what we do in all the other organ systems we care for. We have to be better than we've been. We can feed patients on pressors, we can feed paralyzed patients, we can feed prone patients, and we need to personalize our targets with the new generation metabolic cart. And so again, this is critical. Measurement is critical. If you can't measure it, you can't improve it. I'm going to talk this afternoon more about a lot of these new technologies we're using, a lot of these new opportunities that have become much less expensive. And I think, as you've heard other people say, start slow, start paying early if you aren't able to get intro in, but always start with intro first. Protein delivery should be ramped up as well. Start less than 0.8 grams per kilo, as Arthur Van Zanten has shown us, until day 3, and then ramp up. And then I think there's a lot of opportunity we have in the recovery phase when patients can actually begin to get their lives back. And again, metabolic cart is critical of that. If you guys are interested, if there's dietitians in the room, there's physicians in the room, and you want to start a metabolic cart team or get one of these devices and you need to justify it to your hospitals, this work's already been done. We're happy to share the business case we used at Duke. There's also a business case from a private hospital in the US that there's an RD named Ashley Roth who's been running a metabolic cart team for 2 years now, just dietitians doing it. Dietitians can do all of this measurement. They don't need a respiratory therapist. You can email one of these 2 people. They can share a lot of information with you. And the last thing I'm going to say is we've started an online clinical nutrition fellowship that we launched last July with its first pilot. It's filled in 48 hours. So we're going to, in about 2 weeks, present the opportunity for you to learn from experts around the world online. You get to interact with them. You get to Zoom with them and ask them questions. and there'll be modules covering metabolic heart, critical care nutrition, perioperative nutrition, and we're partnering with the American Society of Nutrition and the board to help more people, more physicians, more dietitians get trained and work together from around the world. In our summer version, we had people from all over the world interacting. I learned more, I think, than they did in the session I taught. But follow my social media to tune in. In about 10 days, we're going to launch the sign up. Again, it filled, actually, the first six of the 7 modules filled in the first 24 hours. So if you're interested, please keep track and tune in. And with that, we must again take responsibility for what happens, not just day to day in the ICU, but what's going to happen to our patients for the rest of their lives. And if we do that, we can take patients who look like this, have them walking on ventilators, like Bob said, like this. This actually really happens. And then they can look like this, or at least like this. And with that, listen closely as Master Yoda tells us what we need to do. He's my favorite mentor as we go away today.
You must unlearn what you have learned.
All right, I'll give it a try.
No, try not. Do or do not. There is no try.
And with that, we have to do. I encourage all of you to follow me on social media if you don't, and follow other physicians. I always make my residents do. It's a great way to keep up with the literature. We post and talk about all the latest studies and all the newest data. It's a great way to keep track with all the stuff that's impossible to keep track of otherwise. And this is my email if you want me to share any of these slides or any of these papers with you. I'm happy to do that. Thank you.
Thank you. Thank you, Dr. Bismack. I think it was an excellent treatise on how to go about the ICU. We'll take questions at the end of the next talk.
Perfect. Yeah. Okay. Let me just pull this down for him.
May I now invite Dr. Joseph Karpano from the Indonesian Association of Parental Nutrition. Multiple interests, extraordinary lecturer in medical faculty, lecturer in the Kasih Bangsa from 2007, then instructor and course director for intensive care. Multiple credentials, sir. Please.
Okay, thank you for the information. I think this is my topics in the developing countries. We have to go back maybe in a more primitive one because we are already see there is some developing countries that have many excellent equipment and others. We try to go to the developed country, the primitive one. I have no disclosure. I just want to say we share the nutrition in ICU screening. Just want to review is all, and the determining the calorie in ICU and some point of to remember. The nutrition in ICU is what is the what, where, when, and how. It is the simple one that usually we have to calculate and to mention about the nutrition. What? Usually we use the guideline from ASPEN or SPEN. You know? Okay, thank you so much. It is macronutrients and micronutrients. There are macronutrients and this is the micronutrients. But we do not talk about that. Where? Where is that's usually that as our previous vice mayor Paul said it's parental or enteral, but here is either parental or enteral. But Aspen, according to Aspen, oral diet is first. It may be different. If not possible, Aspen suggests that early introduction in critically ill adult patients rather than early parental introduction. Also. Okay. Hello? Yeah. Oh, oh. Oh, okay. Hmm? Okay. It's okay. Can you hear me? Hello? Not yet. Hello? It is, yes, thank you so much. Yeah, much better. Uh, we go for this, according to expense, it's usually the enteral nutrition first and then PN. And if there is no contraindication in enteral nutrition, we use enteral nutrition. Otherwise, we choose the PN. And it's also the delayed PN should be considered. It is different from what Paul has already mentioned. For EN in the critically ill patient, gastric feeding should be first considered. Aspen also suggests the post-pyloric feedings in patients with enteral with to maintain enteral nutrients. It's also different to what Paul has said. Just use the gastro. So when it's early, the same. This is also the when Aspen suggests the initiation is early. If it goes and then the strong recommendation is early, also early and then present. But we must know how is the nutritional status is a patient is malnourished or not. There are some nutritional screening and assessment. It has a very different and not much different. Like the screening is a quick screen. When we enter this hotel, we are screened. It's a quick one, and after that, if there are bid, you have to be assessed. There are a lot of screening and assessment. This is some MST. This is MUST. NRR 2002, this is MNA, and SGA. The last two is the Nutric score from here. This is already proved by Hielan and friends. Also, the new ones is a GLIM, Global Leadership in Malnutrition. This is the GLIMS. We look further for the GLIMS one. GLIM here, we have to screen first the patient. Is there any risk of malnutrition? If there is, there are disease-related malnutrition, and the diagnosis is the exception is there are phenotype or and etiology causes. Each one of the etiology and phenotype it is a malnutrition. Here, there are some difference from the BMI. In Asia, we have a lower BMI. Yeah. But also in 70 years old, we need a higher BMI. And then this is the severity of the malnutrition. I don't want to talk this, but we need to differentiate which assessment and screening we need. There are two important. The first one is from Helen, and I saw. Listen, from Helen. Helen said it is better to use the Nutri-Score, but in developing country, it is too difficult. Why? Some in my country, some of the hospital do not use the Apache, but some use, and also the SOFA. Some use and some no. If we use the Nutri-Score, we have to get the Apache score and SOFA score. Also, there is an interleukin 6. In my hospital, I am frankly speaking that we never take how many the interleukin 6. And from the Nutri-Score, it's depend on your hospital. And also, this is a peer singer last month in the webinar, and from SPEN also, he used a screening, NRS 2002, and assessment by CLIN. I think it depends on you which screen and assessment you use. Next. But all of that, every patient, every critical patient, whatever, no matter what kind of screening and assessment, it will be identified the patient is as malnourished. When the recommendation from SPEN, yeah, this is same. Delaying enteral nutrition if shock. Otherwise, don't delay. Also, if there is a hypoxia, hypercapnia, acidosis, delay the enteral nutrition. Next, SPEN also suggests delaying the enteral nutrition in patients with active upper GI bleeding and start when the bleeding stops, or there is no more sign of bleeding. How much? This is what we want to share. I want to share how much the calorie here. It needs accurate methods to determine the energy requirement. Also, how much is the weight, how much is the age, how much the surface area, and how is the activity. This is what we have to know. And also, the last one is BMI, body mass index. Here are some options. Which weight to use? This is actual body weight, ideal body weight, or adjusted body weight. We talk about it. It is a WHO definition for the BMI. This is the normal range. It is the same. We follow the WHO, but some Asia country it is different. In China, Hong Kong, Indonesia, Japan, Singapore, Thailand. I'm sorry, I do not have the India. This is the criteria of overweight, and this is the obesity. Now, how to to calculate the body weight. In underweight, this is all style of the calculation. That is, we use the ideal body weight and the actual body weight. This is I take this from Pensa 2009. This is an original old one, but it is still used in my country. But in overweight, there are some difference. Before it is used the ideal body weight, but now in my country it is not always used the ideal body weight. It is depend. It depends. Some of the guidelines from ASPEN, and others. There are criteria. Body weight. Here, body weight is defined as pre-admission dry weight before resuscitation. The BMI up to 30 kilogram per meter square. Actual body weight is the weight measured during hospitalization, reported just before hospitalization. And ideal body weight is the weight related to height. Now, how much? It needs an accurate energy requirement to determine Harris Benedict. We are all on the Harris Benedict. This is good for group patient, difference from male and female. But I'm not confident with the indirect calorimetry. I do not use that because it is takes time. Indirect calorimetry is a gold standard. We already know it. But in developing country, I don't know. Do you have the indirect calorimetry or not? Some hospital in Indonesia has, but most of the hospital has no indirect calorimetry. So, what is the clue to reach the best one? There's a guideline from ASPEN, 20 to 25 kilocalorie per kilogram body weight per day for the initial phase of the critical ill patient, and then increase in anomalic phase. There are a lot of adjusted calorie equation. In American College Chest Decision equation, it is said that it is 25 time weight. If BMI 16 to 25, use the actual body weight. If less than 16, use the existing body weight for the first 10 days and then use the ideal body weight. The BMI more than 25, use the ideal body weight. Later, if the Jones, there are two equations. There is actually three, 1992, 1999, and 1997, and 2002. There is equation also, but it is also complicated for us. Later on, Penn State University equation also from young patient and older obese patient. We in my country we do not use this one. Also, the Mifflin Saint-George equation, use this one. We do not use also in my country. And we usually use this equation. There are two equations. This is one, the one is from ASPEN, and the other one is from ANHI. The adjusted body weights in ASPEN is a applicable. Calculated the ideal body weight, actual body weight minus ideal body, actual body weight minus ideal body weight times 0.35, 33 in ASPEN. And in from ANHI, so the American from Abbott, the ideal is 0.4 actual body weight. minus ideal body weight. This is the calculated adjusted calorie. As what I am doing in my hospital, we use both of them, but we look for the muscle mass. If the patient has a more muscle mass, we use this one. Otherwise, we use the S-pen. Now, what time we have? What is the point we have to remember in this one? In underweight, it is based on actual body weight, but there is risk of refeeding syndrome. We have to know that there are criteria from NICE in 2006. One of the following BMI less than 16, unintentional weight loss more than 15, and 3 or 6 months, little or no nutrition intake in 10 days, low level of potassium, phosphate, magnesium before feeding. This is what we have to be careful. Also, there is 2 or more of the following: BMI, unintentional weight loss. If there is 1 or 2 of these, we have to remember that the patient will have a possibility to have a refeeding syndrome. We have to be careful. Remember that. And this is for the overweight patient. In overweight, we usually use the ideal body weight, but some are adjusted body weight. We use the adjusted body weight. And about the protein, some guideline has informed that we have to give the patient with high protein provision. This is from critical care ASPEN guideline in obese patient 2009. They provide 60 to 70 of target energy requirement, or 11 to 15 kilocalorie actual body weight, or 20 to 25 kilocalorie ideal body weight daily, with the patient if BMI is more than 30, or provide the protein more than 2 grams per kilogram ideal body weight daily for the BMI 30 to 40, or 2.5 grams per day for the BMI more than 40. There is a higher proportion of protein calories, often 50 to 60% of total calorie, in order to minimize glucose loads while sparing lean mass body. I think this is what I want to share. How we calculate, we determine the calorie in the developing country. We are not using the indirect calorimetry. It is very nice if we have indirect calorimetry. It's the gold standard to know the calorie. But in the primitive one, in the developing country, lots of them do not have. But we have to treat the patient to calculate. So we look for the research in each country, in the developing country, such as Europe, in the United States, wherever. Look for that. Use the best that we know. So we have already talked about the nutrition in ICU. Screen is also have an important and screen the patient, determine the calorie. If we are not have time to calculate, just use the 20 to 25. It's according to SPEN. Otherwise, it is depend on the body weight, in the overweight or in underweight. Just calculate it. In underweight, it's different. We have to remember the refeeding syndrome, and in overweight, give the higher proteins. I think that's all for my presentation. Thank you so much.
Thank you, Dr. Hartano. Excellent, crisp and informative talk. Due to constraints of time, we will have the questions individually during the break time to save time and make sure the program continues on time. Thank you very much. Enjoy the rest of the program.
Yeah, it's actually
A very good afternoon to all of you all. Welcome to the next session, which is on sarcopenia. I now invite Dr. Ravindra Reddy, President ISPEN, and the conference chairperson to come up on the dais and take over this session on sarcopenia.
Hello. Yeah. Good afternoon, and apologies on behalf of the organizers that we are running a bit late. A few words about muscle mass. Way back, probably about 48 years ago, in 1974, if my maths is correct, Charles Butterworth, a surgeon from Harvard Institute or from Harvard University, he actually said that every hospital has a skeletal in their closet. And there have been umpteen number of articles to say that the skeletons are still rattling, right? And what he meant was about the malnutrition. But now we know that they are not one skeleton in the form of malnutrition, but there are two skeletals, and the other skeleton which I'm alluding to is the muscle mass or the loss of muscle mass. In fact, there's a very elegant observation study from Texas that showed that any disease, be it cancer or trauma or cardiovascular disease, presence of an adequate muscle mass will obviously improve the clinical outcomes in these individuals. With this brief thing, we have an amazing panel. We have Dr. Adarsh Chowdhury. I'd like to call him onto the stage. And I think you're the first one? Yeah. Adarsh Chowdhury is a gastrointestinal and hepatobiliary surgeon, one of the leading surgeons from India, and it is my absolute honor to be on first name basis with Adarsh. And he's been the president of the Indian Association of Surgeons, and also the surgical gastroenterology, umpteen number of articles, trained in the UK, and he's rescued some of my complications many a time, so I'm really indebted to him. And he's got amazing original research work in sarcopenia, and really proud of his work because that's in relation to the Indian patients as such. Dr. Adarsh.
I'm a surgeon, and one of our areas of interest is pancreatic cancer. This slide shows what happens once the pancreas is removed. And then what happens is you join the pancreas to the intestine. And this is one of the most complicated operations, and this anastomosis is a propensity to leak. So a few years back, our results were as good as any other center in the world. But as our numbers increased, we realized that our anastomotic leaks, our length of stay, our surgical infections increased. The philosophy we follow is that first we take the measurements and then we take the measures. So we all sat down that how is it possible that since our numbers are increasing, it means we are technically better, so that's why we increase numbers. Why are our complications increasing? Why are results not as good as they were in the past? The problem is that ignorance gives you a lot of options. When you don't know much, various theories come up, and we started thinking of various theories till we got hold of an article like this when we realized that we should have seen something else, that muscle mass is an important ingredient of success even for surgeons whose IQ might be room temperature, but we are very concerned about the outcomes of our surgeries. What actually happened, we realized once we reviewed literature, was that the screening methods in the past were a typical example of ladders against the wrong walls. Malnutrition was essentially assessed as weight loss, so all efforts were made to increase the weight gain and more calories were given, and muscle mass was a neglected factor in realizing that it contributes to outcomes in patients. Just to revise a few things for you, that we have two kinds of muscle in the body, the cardiac muscle and the skeletal muscle. The cardiac muscles, thankfully, are self-stimulating. They don't fatigue, you all know that. And they have intermediate energy requirements, whereas skeletal muscles exhibit fatigue and they have a high energy requirement. Most of us believe that muscles only contribute to our looks, movement and balance. Skeletal muscle is the largest source of glucose uptake and storage and supply. We need to remember that 75% of our body proteins are stored in skeletal muscles. And we have also realized as an emerging theme that the skeletal muscle is an immune organ also. In one of the classical studies reported many years back, which many of us have possibly forgotten, that if you eat food, within 3 hours of eating, 40% of that goes to the muscle. So muscle takes the majority of the food that we consume, and in a normal fed state, the glucose is absorbed from the intestine, goes to the bloodstream, it undergoes glycolysis, and the ATP is produced. So far, so good. But once you get into fasting, then if the glucose is not enough, it is broken down from the liver, kidneys, and then further if it is fasting, the endogenous glucose comes from non-carbohydrate sources like amino acids. It's just like when you are kicked out of your job, the first thing you do is you eat your bank balance. That's okay. When the bank balance finishes, you start selling things in your house. That's when the problems start. That when you start borrowing from your friends, and that's what happens when proteins are broken down for energy. Nitrogen is created, which further needs energy. So it's a complex situation. And many of us need to remember that if you have 80% of damage of pancreas, 75% of damage of liver, life goes on. But if you have more than 10% damage of skeletal muscle, problems start. So skeletal muscle is a very plastic organ. It helps, but it also responds very sensitively. Also, when we have skeletal muscle loss, there is insulin resistance. Insulin resistance is a bad thing for cellular homeostasis. It causes liberation of triglycerides from fat, so there is fat deposition. Insulin resistance also causes growth hormone suppression, so muscle regeneration also gets affected. And since you have less insulin in your body, there is compensatory hyperinsulinemia, which is very bad for muscle regeneration. It further causes deposition of fat. So skeletal muscle loss is a serious issue. There's an interesting concept coming on with the realize that every time you contract your muscle, myokines, which are various chemicals which are released, which contribute both to your innate and adaptive immune responses. When I joined my present hospital out of interest, we started a 100 push-up club in Vedanta. That before we start surgery, we have a small room where various anesthetists and me, we started doing 100 push-ups every day. Some do 60, some do 70. Interestingly, when COVID struck, there's at that time 68 people who were regularly doing more than 100 push-ups. 14 of us got COVID. None of us had a complication. I'm not saying exercise helped, but there is some suggestive evidence that exercise probably helps. What happens when you lose muscle mass? Patients have physical disability, they have falls, the length of hospital stay increases, wound healing is impaired. Some suggestive evidence that postoperative complications may be more. There might be disease progression, the toxicity of chemotherapy is more, and in some cancers, there is evidence that if you have sarcopenia, your long-term survival is affected. Many times we use words like fat-free mass, lean soft tissue, adipose tissue fat mass. This is so confusing. They essentially reflect the skeletal muscle mass in various body components, and depending on what system of body composition analysis you use, these terms are used. And I refer you to this article if you want to understand the tutorial of what these terms mean. This is a good article to understand what do these various terms like soft tissue mass, what does it include, so that you can understand that better. Also, there is some confusion as to what is sarcopenia, what is cachexia, what is frailty. Sarcopenia is not only reduced muscle mass, but also impaired skeletal mass function. In cachexia, the overriding thing is inflammation and cytokine-mediated muscle loss, whereas frailty is something like an age-associated biological syndrome which is characterized by a decreased biological reserve, and elderly people are known to have frailty. But lean muscle mass and muscle loss is a criteria for the diagnosis of be it malnutrition, sarcopenia, and cachexia. Who are people who are at risk of muscle loss? What is the clinical relevance of muscle loss? Aging is associated with muscle loss. Chronic diseases like kidney disease, cancer, we all know that. Critical illness patients in the ICU, and COVID-19 has taught us that muscle loss itself was a predictor of poor outcome. Patients who had muscle loss in hospital stay, their rate in the ICU, their mortality also was higher. As we grow older, we lose muscle. Why does that happen? It happens because we have lack of activity, we eat less, there decrease in hormones, and getting old is also something like an inflammatory state. I do not want to get into the details of that. And at the molecular level, what happens is there's imbalance between the synthesis of protein and degradation of protein. And there is also decreased regenerative capacity. Cellular senescence occurs, that we all die, and the cells get old and die. And the current area of research is mitochondrial dysfunction. Our mitochondria today are understood to be the storehouse of our energy. The mitochondria are responsible for muscle contraction, the complex calcium handling, and they are very much involved in cellular homeostasis. In diseases, mitochondria get affected, a term which is called as mitophagy, and that today is the cutting edge of research, and it is believed to be a perceived target to alter changes in aging and other diseases. Ravindra Reddy recommended me this book, which is written by a naturopathic physician. I read this book. It was like going to a biology class. And it made me realize that the current knowledge that we have, the root cause of many diseases is mitochondrial dysfunction. And I've also understood the ancient Indian medicine, which said some things which to me at some time made nonsense. When I read this book, I think it makes sense. When you do deep breathing, when you do pranayama, how does it improve mitochondrial function? For those of you who are interested in the why of life, I strongly recommend this book to you. My basic interest is in cancer, and majority of patients we see of cancer have muscle loss, which is dependent on the stage and type of tumor. And how do we define sarcopenia? Many times I'm asked a question, suppose you have a patient of pancreatic cancer whose albumin is 1.2, cannot walk. Will you do a Whipple's in this operation or not? I say, majority of time this question is theoretical, because by the time they reach that stage, the tumor majority of time is already unresectable. So muscle loss, which is significant, might be a surrogate marker of unresectability. Patients who have cancer get muscle loss because the tumor itself secretes pro-inflammatory cytokines which decrease muscle growth. And these people have anorexia, there is hypermetabolism. So it's intuitive to agree and understand that cachexia is an integral part of somebody having a malignancy. What does muscle loss do to cancer patients? In some diseases, we realize that it increases chances of anastomotic leak. In upper GI surgery, there is evidence. There is an increased incidence of soft tissue infections. Reasonable evidence to say there's an increase in hospital stay. Very convincing data of poor tolerance to chemotherapy, and in some cancers, there is suggestive evidence that even the long-term outcome is affected by the presence of pre-existing muscle loss. So now we believe that sarcopenia and muscle loss should be added as a prognostic factor in cancer, because not only the treatment or treatment responses, complications and long-term outcomes are dependent on muscle loss. What is happening in India? We have very little data coming from this country about sarcopenia and its incidence. I'm sure given our lifestyle, our food, incidence of sarcopenia in this country would be very high. We published this paper for the first time. We had no data as to what is a normal pattern of muscle in our country. So what we did was we took over 400 patients who were liver donors because they were fit. So we assessed their muscle mass by doing a CT scan and we published this paper. So this paper has been published and we could establish the normal muscle pattern in India. One of the questions which bothers me is that we know so much about it. Why is it that we don't follow it? Why is there so much a lack of interest, involvement in what we do? People listen in this hall, go out and forget. This is a question which has been bothering me for years. Why are we so insensitive to something which is so meaningful, so easy to change, still it is not implemented? My understanding is that it is because of this 3 cycles of concern which Stephen Covey said. That there's a circle of control which is dependent on me, what I can do. There's a circle of influence where I can influence people, and there's a circle of concern which are changing the whole society. Unfortunately, things don't change like that. To get what is outside, you have to change what is within. So we have to basically work in the circle of control, do my bit to improve outcomes, then only people will understand. Talking on a dialogue one-to-one basis, it might change, but there is a lot of gap in what we understand, what we do, and what we really implement. So what did we do? We started doing a couple of studies based on this. This is one of the papers of ours which is in press right now. We took patients who underwent Whipple's with us, 457 patients undergoing pancreatic duodenectomy for pancreatic cancer. Surgeons believe that they are gods. So we believed earlier that our sutures heal patients, but now we realize there were other factors. So we did this study that is the anastomotic leak related to the local pancreatic morphology or is it related to the body composition analysis? Interestingly, contrary to what we believed, body composition analysis with muscle mass, at least in our hands because we are a high volume center, did not increase the incidence of anastomotic leaks. But once a patient leaks, patients who had muscle loss, their outcome was bad and majority of them died. So body composition analysis makes sense because it may not decrease complications, but it can predict outcomes. So like that, we have many trials going on in our department. We are finding out that does prehabilitation in patients of esophageal cancer who have one of the highest degree of muscle loss, improve their muscle mass by doing repeat CT scans. We have great interest in ulcerative colitis. We do major surgery. Some patients do well, some patients don't do well. We are using immunosuppressants as medical management. Does preoperating muscle loss preoperatively predict outcomes? We are assessing how to assess degree of muscle loss in patients of esophageal cancer. Earlier we were measuring their psoas muscle, but now we realize what determines is their respiratory outcome. So we should do the assessment at the level of the chest. So we do the analysis at the level of the inferior pulmonary vein. So we are changing things about it. And I sincerely believe in life that if truth has to be believed, it has to be invented well. Otherwise, what we do all our life is assume answers. And the worst thing for a physician is not ignorance, but a perception of knowledge. Thank you very much. The stage is set for our guest speaker. I'm sure I didn't intrude on any of the topics that you will speak because nothing irritates a speaker than a previous speaker who covers his topic. Thank you very much.
Just in case.
While Dr. Paul Wishmeyer or Professor Wishmeyer is setting up his laptop, being the chairperson, I'm supposed to introduce. I've already introduced Dr. Adarsh. Now, Dr. Paul doesn't need any introduction, but those who were attending his previous lecture, I would actually call him as the Master Yoda of surgical nutrition and surgical rehabilitation. So, Master Yoda of the discipline of surgery is here again to share and enlighten us and perhaps even increase our muscle mass as far as knowledge is concerned. It's up to you.
He's going to show me. Thank you. It's great to be with everybody again and to talk about a subject that I am very passionate about, as you will learn, and one that I think does not get nearly the attention that it needs. And so that's why I think you've begun to hear the term muscle matters. I don't know who originated that phrase, but I have the exercise physiologist I showed you in the last talk who did all the COVID measurements. He's a master muscle and exercise physiologist. His name is Jeroen Mullinger. And his hashtag on his Twitter page is Muscle Matters. And so he likes to claim he started it. But what I would like to talk to you about is why, indeed, it is an urgent message for everyone, especially I will show you in India, that we need to pay more attention to our muscles. And as you heard me say before, and I think it's critical that every day that we care for patients, whether we're in a clinic, whether we're in the ICU, or whether we're on the hospital floor, we need to be thinking about what we can do for the patient that day, but we need to be thinking about what we can do for the patient that's going to get them to the rest of their life. What can we do that's going to assure they go back to a life worth living? It creates survivors of our patients that go back to their families, go back to a meaningful life, and not victims, which is often, sadly, the case, especially after ICU and cancer and many other illnesses. Because, again, what our patients really want is the ability to go back to their families. And, of course, the reality is that facing a major surgery, like cancer surgery, critical illness, COVID, COPD, is really the patient having to train for the marathon of their lives. Because this will be the most important race they'll ever run, whether it's recovering from cancer or recovering from COVID. We need to train them, and nutrition and exercise are essential for anyone who's ever run a marathon or ever run any race. And we need to do the same. And so, again, we need to focus our patients on the fact that this is like running the marathon for your life. And so I want to show you what can happen when we ask our patients to run the marathon of their lives and they're not ready, without the right training and the right nutrition before they start the race. And can they still be saved and still finish strong? And that's really the question. And so this, of course, is not the marathon of the road, but the marathon of the hospital or the marathon of the operating room table. And so to do that, I want to tell you about a patient that I took care of just a few years ago, and I got to know he and his family very well. And you're going to see some actual pictures of him. He gave me permission to do this, and he's someone that his family and I still are in close touch. His name was Elijah, and he was an 89-year-old gentleman with COPD coming for partial colectomy. And he had lost some weight from his COPD and from the fact that he had this need to have this colectomy. And so he'd lost weight before his operation. And he told me he was feeling weaker than he usually did, but he was still quite active. And he said, just yesterday, I met him on the day of surgery. He said, just yesterday I was on the roof of my church. He was up on a ladder fixing the roof of his church. This is a very active, nearly 90-year-old man. And the question is, with this weight loss and him telling how weak he feels, is he ready for surgery? Well, the reality is he isn't. This is not someone who should have an operation today, tomorrow, or next week. He's not ready. He needs to be optimized. And we'll talk more in this lecture and later today about how to do that. But that isn't what happens much in the world today. Surgeons like to operate. And so they operated, and he went to the OR. And actually with one of my very favorite colorectal surgeons that I work with, she's really excellent. And he did okay for the first few days after surgery. But then on post-op day 3, he developed acute abdominal pain and rectal bleeding and began to look very shocky and very sick. He ultimately got a CT scan that showed a ischemic valve was forming, and he was in hypovolemic shock, and he went to the operating room to get this dealt with. And he had a cardiac arrest. His heart stopped on the operating room table. He got compressions for about 2 minutes and a couple rounds of epinephrine and other drugs to restart his heart. And he was diagnosed with an anastomotic leak that had led to the shock that had led to the ischemic valve. And so he came back to the ICU where I took over his care with an open abdomen. He was very weak on the ventilator, And of course, we know he had a poor nutritional status coming in. And so a number of the people on my team, the nurses and some of the other physicians and the registrars, began to say, he's almost 90. Can he survive this? He's much too old and sick to recover. He had a cardiac arrest on the operating table. Maybe we should just let him die. Well, this patient did not want that. He had told me before surgery, he said, I have to get better from this because I have never met my new granddaughter, and I really want to meet her. So I want to survive this no matter what. And so we, as the physician team, the surgeon and I, we said, we're going to fight for this gentleman. We're going to try to give him his life back, even though the odds say it's not possible. And so, again, the family agreed, the patient agreed, and we kept fighting for him. Remember, this is a very active man before, and so our team was going to fight to save him. Can we save this 90-year-old frail, cachectic man who's had a cardiac arrest after surgery and give him back his life? And that's really the question. Can we create survivors of even the oldest of our patients as we operate on older and older patients? And we're already up against a challenge, right? We know that even 30 and 40-year-olds who are in the ICU on a ventilator, half of them won't go back to the work they did before in a year because of the physical limitations they have. A third of those patients, and these are young people, 30s and 40s and 50-year-olds, will never go back to the job they did before because of the weakness they're experiencing. And can we do anything about that? So no one is immune from this, from the young patients to old patients. Everyone to this point has been suffering. It's the new challenge of critical illness and surgery, I would say, is we're very good at saving lives, but are we good at giving people back their lives? And we know that if you're in the ICU on a ventilator more than 5 days, 60 to 80% of our patients will be significantly physically impaired for months to years and years afterwards. And major surgery can be similar as well as cancer. So this is an epidemic we're facing, this weakness issue, this muscle issue, and COVID-19 is only making it worse, right? We have more patients now on ventilators than ever before. So why are we losing this quality of life war? Well, of course, as you guessed from the title of the talk, we know that muscle loss is behind this. And we know ICU and major surgery patients can lose a kilogram of lean body mass a day. And I'll show you some examples of that in a minute. And again, the hypermetabolism, catabolism our patients face can go on for years. Again, we are not as evolved as humans to survive major surgeries or major illnesses or cancer or COVID. And so again, the body doesn't know when to turn off this catabolic signal. And so this may actually be worse, as I showed you in the last lecture, COVID-19. And the thing is, even when people eat well, and even when we feed them well with enough protein and enough calories, patients will gain weight, but it's almost all fat. If you've ever seen a burned child before some of the new interventions that we do, you can feed and feed and feed them, and they'll put on fat in their liver and fat everywhere unless you do some other things in addition to feeding and just exercise alone. So again, we're not evolved for this as humans, for sure. Mother Nature never intended us to survive the surgeon or the COVID or any of the cancers, many illnesses we face. So again, this is an epidemic, and we have to be better. And I'm going to show you we can be better. You have unique opportunities now to be better. We all do. And to get these patients better, patients like Elijah, we're going to need a combination of personalized nutrition, good physical therapy, of course, and perhaps some exercise techniques I'll talk about later today that we learned from elite athletes and Olympic athletes. So what are our goals? What are our nutrition goals to recover and prepare all our patients? Well, clearly we need to recover muscle mass. We need to improve muscle mass in our patients, and we need to restore their aerobic fitness. But again, to do that, as I said before, it's going to take personalized nutrition, the right nutrition at the right dose, and the right exercise at the right dose at the right time, and we need to measure. Because one size does not fit all. And again, Lord Calvin said it best, we have to measure it to improve it. So in our ICU, we do measure muscle mass, and I'll show you how we do it. And I'll show you Elijah's muscle mass, actually, that we measured in him. So what were his muscle components before surgery? We use the muscle sound ultrasound. It gives these brilliant pictures. And you can see here, you can see how little muscle he had. The muscle is in the pink there. The fat is above it. And so he had significant low muscle mass and a lot of fat mass for someone who actually didn't weigh very much. He only weighed 49 kilos. That's a BIA analysis on the right there that gives us a lot of information about our patients' muscle mass and body composition. And we do this in a lot of our patients. So the other question is, as you look at patients that come to see you, no matter what their illness is, do we know who the most at-risk patients are when you look at them? And how best to monitor our nutrition, and do we have better tools? So if someone is having a major cancer surgery, like Elijah and like the patient you heard about in the last talk, who's more at risk for complications? This healthy-looking, thin, older man, or this obese man Who's going to do better, the thin person or the obese person? And the reality is we have a lot of data for that. We know that actually having a normal BMI is bad for you if you're going to get sick. And the reality is, what's the best BMI to survive just about any illness? 31. So I see a lot of people that have a lot of eating to do, because I see a lot of BMIs that are not 31. Mine is 31, by the way. I'll show you why in a minute. But again, we know in COPD, we know in heart failure, hypertension, coronary artery disease, atrial fibrillation, cancer, trauma, ICU, any diagnosis you want to come up with, any disease you can have, the best BMI to survive is 31. 30 to 32, depending on the disease. Not 25, not 10, or not 20, 30. And so again, this is true in critical care as well. I want you to look at this ARDS data. Look at what BMI and survival does. Your survival improves all the way out to a BMI of 40. Why is this? It's not because they have more fat mass. It's because people up to BMIs of 35 and 40 still walk and are actively mobile. And so they have to have more muscle mass to move that body mass around. Above 40, the U-shaped curve starts to go up in mortality because they stop moving. They aren't able to get out of bed, and they lose, and they have very little muscle. So we think this, of course, reflects muscle mass. It's true in critical illness as well. Your higher BMIs have a much higher survival rate, and you can see below a BMI of 25, not good. Mortality skyrockets because your muscle is your metabolic reserve. It's your armor against disease, no matter what it is. And so, in fact, this was a brilliant paper in the Blue Journal. It's a very high impact factor critical care journal that showed for every 1 point lower your BMI is, you have a 7% decrease in recovery of meaningful functional quality of life, the ability to walk on your own and do your activities of daily living. So again, not only is it bad for outcomes, it's bad for function and quality of life if your BMI is lower. So again, if you're a woman with a BMI of 30, you're 60% more likely to recover a meaningful quality of life than if you have a BMI of 22. So it's pretty compelling. So what makes someone metabolically and nutritionally fit, and how do we assess that? So again, this has always been frustrating to me. I've run a lot of road races in my life, and inevitably, some older man or older woman who looks overweight and could never run runs by me. And I think, how do they do that? And so we can be fooled, right? Our eyeball test is really poor, and I'll show you some data for that. So we believe it's muscle mass is what makes you fit, is what makes you prepared for what life is going to throw at you, no matter what the illness or the challenge. And I think in India I did a lot of research before I came, because I didn't know a lot about, as we heard, about sarcopenia in India. Well, some of the new advanced techniques of body composition measurement have been done in over 1,000 Indian healthy individuals. These aren't patients. These are average, free-living people from India, and the ranges of 30 to 50. So again, close to my age, just a little younger. But what they learned was 7 out of 10 people in India suffer from poor muscle health. And I think this is probably true throughout Southeast Asia. I've seen data like this in other Southeast Asian countries. This is some of the highest low muscle mass and sarcopenia I've seen anywhere in the world. Anywhere in the world of a developed nation with a developed healthcare system. This study showed that 71% of Indian natives suffer from poor muscle health, characterized by low muscle mass and low protein content, as measured by more advanced techniques. And again, this is young people. This is not your older folks. This is 30 to 50-year-olds have low muscle mass here. And I also found that actually working professionals have lower muscle than non-professionals. Again, why is that? Professionals, those of us in professional jobs, often do this all day. We sit. We don't move. We watch too much TV. We play too many video games. Whatever we do, we're not moving. And those that work in non-professional jobs often are laborers, construction workers, farmers who are active. So again, these are what you'd think are your better fed, better educated folks, and they have lower muscle mass here. And I think it's true in other countries as well. And again, this is bad for us all the way around. And I was in Chennai last night and actually was giving this. And so I actually highlighted Chennai because I happened to be there. But in cities throughout India, this was true. It wasn't unique to any one city. Delhi actually did the best. But some of the other cities, they were all very high. I was really struck by how high this was. Why is this? Well, I went into the Indian Dietetic Association's information, and they've done surveys of just normal populations and normal folks in India. And what they found is 84% of people with vegetarian diets in India are protein deficient. They're not getting enough protein. But the reality is the non-veg eaters aren't getting enough protein either. So what the Dietetic Association here in this country learned is even the non-veg eaters are not eating enough protein by any nearly scope. And when they asked people about their knowledge of the importance of protein, 93% of The average Indian population has no knowledge of why protein is important or if they should eat it or if it's critical to their diet. So again, I think there's this huge education issue that needs to start in childhood. So this is an emergency in India, and I think throughout Southeast Asia. I've seen these kinds of low muscle mass numbers in other countries as well. And it doesn't get better as those 30 to 50-year-olds we just talked about get older, right? We lose muscle mass dramatically as we age. It goes down about 8 to 10% per decade, and then over 70, 50% per decade. It doesn't have to, but on average it does. And it's not just mass. You get weaker. You get weaker if you're not actively trying to sustain it, and we'll talk about why that is. And of course, then if you layer on a disease like cancer, COPD, CHF, it gets even worse, of course, because that compounds it by driving inflammation, which drives muscle loss, which then causes you to get more diseases and lose more muscle. And that's the vicious cycle that we're going to see. And then, of course, bed rest. The bed is evil. I tell my patients every morning I want them out of the bed. The only time they should be in the bed is when they're sleeping at night. There is never a time. But hospital beds cause more complications than anything else we do in the hospital. So if you lay a healthy 20-year-old in a bed for 28 days, we do this with astronauts. NASA did this in the US before they put people into space because of the gravity, loss of gravity. They won't be able to walk. They'll be too weak. So they lose a significant amount of muscle mass. If you take someone who's over 65, they'll lose 3 times that muscle mass in just 10 days. If that 65-year-old has got an illness in the hospital, they'll lose that in 3 days. This is what being in the bed does to you. It's bad for you, and we need to get our patients out of them. So again, this is what promotes that vicious cycle, right? Inflammation leads to loss of muscle leads to lack of immune system and lack of ability to defend ourselves from illness and recover from illness, which then leads to more lack of muscle and more illness. It's a vicious cycle we need to break. So how can we measure this? I think we need to be better about measuring muscle strength and muscle mass. This is something that should be routine in our clinics, should be routine in the ICU. We should be doing this in all of our patients. It's probably the most important risk factor for surgery almost that we have. And it's critical in cancer and other things as well. And again, measuring grip strength is the sort of gold standard for muscle strength in many cases. Muscle quantity could be measured by MRI or CT. It can also be measured by other simpler tests I'll talk about. And the physical performance is key as well. So the simple tests that all of us can do are things like skin fold measurements, hand grip strength, and sit to stand. So again, there's these great slides that Carla Prado has put out. Carla Prado's name has come up a lot. I'll have to tell her that she was getting a lot of praise and her ears are burning. Anthropometry, calf circumference, is a good way, and there's lots of ways to correct for it based on age, sex, and other things. Muscle strength is the hand grip test. We'll talk a little bit more about that. And again, the sit to stand. How many times can you do this in 30 seconds? You should try it at home and see how you do. It's important. And so again, calf circumference is a very basic thing you can do. I think it's something that if you don't have the advanced techniques in a country that maybe doesn't have the money for the advanced devices, this is a simple thing we all can be doing and tracking. There's ways to correct for it in obesity and in malnutrition. Hand grip strength and other sorts of tests are really critical. They really can tell us a lot about where a patient is, and if our patients are getting weaker, we can do something about it before they're in our ICUs or before they have illnesses that complicate their lives. Again, the key about doing hand grip strength is you can't do it in a laying down patient. They have to be sitting. They have to be square. They have to be sitting at 90 degrees. And so you can't do it in ICU patients who can't sit up. But you can do it in just about everybody else, but they have to be sitting. The sit to stand test, again, is one of the fundamental basic tests. We do this in all of our research studies. Our physical therapists do this every day in all their patients. This is how we track our patients' physical therapy progress. It's how we report our research variables. Again, it's how many times you can sit to stand in a measured amount of time. So again, this is a critical test. Of course, the gold standard in measuring muscle mass is the CT and MRI measured at L3. I can tell you in the US, there are now single slice CT techniques. It gives less radiation than a chest x-ray. It can be done in less than 30 seconds. Our insurance companies are paying for it. They've realized muscle is so important. The Harvard hospitals have just started to get this paid for. They want us reporting out on all our surgical patients. We do it at Duke for research, but we're going to start learning ways to bill for it as well. Now, this is where we get a lot of our data on how important muscle mass is to clinical outcomes. It's from CT measures. We know in the ICU, for instance, the muscle mass you enter the ICU with is highly predictive if you're going to live or die. You can see that green line goes into the ground if you enter the ICU with low muscle mass. You don't want that. We learned a lot about this muscle mass in elderly folks in the US from this trauma trial a good friend of mine, Rosemary Kozar, did. She's a trauma surgeon. So she looked at free-living, healthy, elderly people who got in car accidents, basically. They had traumas. They were able to drive their cars still, so they had to be relatively healthy, and they drove into something. And they came in, and their average age was 79, so this was quite an elderly population. 71% of them were sarcopenic this age, 79 years old. I just want you to remember, the average 30-year-old in India has 70% sarcopenia. So again, this is you could see the contrast in different places. But the reality is, many of these patients, almost all of them, were sarcopenic. But you couldn't look at them and tell who they were. So you couldn't look at whether they were obese, whether they were thin, or whether they had normal weight, and have any predictive value on whether they had measured sarcopenia by CT scan. But what you could tell is if they were going to live or die. You die twice as often, all of the factors being equal, if you started your trauma with a low muscle mass. You don't want to do that. This is true, as you heard, in pancreatic cancer. This is one of many studies showing that your survival with low muscle mass hitting a major operation is much lower if you don't have the muscle mass to protect yourself. In fact, there's so many studies now, there's large meta-analyses of this in surgery. This is a surgical oncology set of studies, 7,000 patients, whole range of sarcopenia. 40% increase in complications if sarcopenia was present across thousands of patients. So we know this is a gold standard marker for our patients and their risk. This is one of the most compelling studies. Alessandro Laviano shared this with me. If you have lung or GI cancer and you come into your therapy for that cancer with weight loss or low muscle mass, your average survival in this study was 8 months. If you haven't had weight loss or if your muscle mass is normal, you live 2 years longer. This is what muscle mass does for you. It saves your life, even in cancer, and you have less complications of chemotherapy as well. So can we do better to assess this? Are there things we can actually do at the bedside to assess this? Well, that's where the ultrasound comes in. I'm guessing how many of you have an ultrasound where you work? How many of you work in an ICU and have an ultrasound? I'm betting almost everybody in every country has this, right? And so this is an easy way. We've taught all kinds of folks to measure this in less than 5 minutes with an ultrasound probe about this big. And so this is something that's easy to do. You measure the rectus femoris. You can measure it in about 5 minutes. And we actually have a muscle-specific ultrasound now called the muscle sound that we use. It's a probe that's about this big. It plugs into your iPad and goes into your pocket. We hope every physician and dietitian has one in their pocket someday, because this is the fast and easy way to reproducibly measure muscle mass at the bedside. Looks like this. You can get all kinds of information. You get muscle mass, muscle glycogen. You can tell if your patients are drinking the oral nutrition supplements day to day and week to week, because you can measure their glycogen. This is validated by muscle biopsy. And again, it gives you data in about 30 seconds. It's an amazing device. It was developed for Tour de France racers, and the Real Madrid soccer team uses it, but now we use it in the hospital as well. This is what it looks like when you're using it. You can see how easy this is. The machine actually tells you if you're doing the image correctly. It can tell what the image is supposed to look like and tells you if you did it wrong. So it's pretty amazing. And of course, BIA is the last technique, of course, that we use a lot. It's very simple. This is not the scale your grandmother had that you stand on that gives you a muscle mass reading. These are really advanced BIAs. We have 2 of them at Duke. They give you a ton of information about body composition. There's a lot of good publications. I had Arthur Van Zanten write a brilliant paper about this in this editorial issue I was asked to edit for Jean-Louis Vincent. And there's a lot of promise for phase angle. It's correlated with muscle mass. It's correlated with death in COVID and death in cancer as well. And so, again, muscle loss leads to lots of diseases, and it leads to bad outcomes in lots of diseases. You don't want to face life or walk out the door of this conference center with a BMI less than 30 if you can avoid it and get hit by a bus. That's bad news. So again, this is really critical, and we know it's devastating. You've heard, everyone has said this. If you lose 40% of your muscle mass, you're done. It doesn't matter what other therapies you're getting. You aren't going to live. We'll get you out of the hospital, but you'll never leave rehab, is what the data would say. And so that's pretty compelling. And again, in India, this seems to be a true, and I think all of Southeast Asia and all of Asia, a true compelling problem. So we need to be better, and how can we do that? So how to optimize muscle mass and muscle function, right? It's going to take precision nutrition to do this, personalized nutrition that's doing better than we're doing today. And of course, nutrition has to be the complete package, and protein, as you might guess, has to be present. We have to deliver protein. We can't build a house without bricks. You can't build muscle without protein. So you have to have that. You've seen this slide a few other times. Again, we know that when you are stressed, whether you're hit by the surgeon, whether you're bit by a tiger, whether you're hit by COVID, our body has one response to injury. It's to break down muscle, to generate glucose, first to run away from the surgeon and run away from the tiger, but then ultimately to fuel our immune system. So our immune system, our white cells, depend on amino acids. So if you can't release the amino acids you need, or you don't have them being fed to you, your immune system will fail and you'll have complications and infections, and you won't survive infections often. And so that's why early protein is so critical in our patients and in our lives. And one of the challenges we face, of course, is as we age, it's harder to put on muscle mass, and it takes more protein to do so. And that's what anabolic resistance is. Anabolic resistance is it takes more grams of protein to build the same amount of muscle as we age than when we're young. And so our older patients have to take in more protein. This is a brilliant review. Now, not all older patients, not all older people lose muscle mass. This guy does pretty well, but he does more than just eat right to look like that, right? It's going to take more than just the regular protein and the regular nutrition that we use now. But we can learn a lot from athletes. We can learn many, many things. And one of the things that we know is taking boluses of protein is really critical. And the most important time to take it is when? At night. There's brilliant data in the elderly that taking in branched-chain amino acids at night or a protein bolus of whey protein increases muscle 20%. 20%. And people who aren't even exercising, it does this. So again, it's overnight that you release growth hormone, and it's overnight that you build muscle. So you can tell your patients this tomorrow. If they're going to drink an all-nutrition supplement, drink it at night. And again, you have to exercise to get the most out of that. But again, use of other amino acids is really key. And then if illness gets stacked on, it gets much worse. The anabolic resistance of critical illness and cancer and surgery is infinitely greater. And that's why you can feed all the protein you want, and that's why all the trials like the effort trial are negative. If you just give protein and calories without an anabolic signal, you don't gain much muscle. And that's where things like HMB that we're going to talk about in a minute can change that. They can change that. And again, so as our patients begin to get better, or as our patients are in the hospital, they're never going to eat enough to recover from their illnesses. And Elijah didn't either. We know the average intake of a patient after surgery, after ICU, is about 700 calories a day. That's nowhere near enough I'm going to show you. So the only way to get this is oral nutrition supplements. I go into my patients' rooms every day and I say, drink that supplement before you eat any of that food, because it has all the things you need in it, and they'll never eat food. They don't have the appetites for it. They can drink it quickly. And there's a lot of data for this, and I won't show much of it, but I think this is one compelling study because it looked at elderly patients with really key diagnoses, I think, that all of us see around the world. This is a study we did in a large database. This database has 60 million people in it. And we looked at patients who took oral nutrition supplements in their hospitalizations, and people with heart attacks had less readmissions, people with CHF, less readmissions, pneumonias, and the elderly, all markedly less readmissions because they were able to take in the protein and calories they needed. And they had significantly shorter lengths of stay in heart attack, CHF, pneumonia. There's data for this in virtually any diagnosis you want to find, but I think this is really compelling. But that's where the question becomes, is the right nutrition enough to win the war? Calorie delivery alone will slow muscle loss, but it's not going to stop it. And if your patient's sick enough, or if they come in with very low muscle mass, they're not going to gain it without you doing some other things to help them, right? So if we're going to create survivors of our patients and not victims, we're going to have to do more than just nutrition. And I think in India in particular, I read a brilliant paper that was just published in Scientific Reports that showed that 11,000 years ago, they used fossil records to do this. The people in India switched from being hunters and active hunters to being farmers. And immediately their muscle mass decreased and their height decreased 8 centimeters. The Indian population's height decreased 8 centimeters over a few hundred years because of this switch from a broad protein active hunter diet to a farming diet without the protein needs. So again, when I learned the Indian diet has evolved over 11,000 years, we're not going to get everyone eating protein in India or anywhere in Southeast Asia probably in the next few months. But is there something else we can do? Is there something, an easier way to improve the muscle mass in India and all of Asia? Is there a way to do this better and more simply and more naturally? Can we improve India and all of Asia's muscle mass more easily and naturally? Well, HMB can do that. I will tell you up front, I'll disclose I've been taking HMB since 1996, so it's something I take every day, but something we know a lot about. There's a lot of research that shows that this is the anabolic signal. It's a naturally occurring amino acid, I'll show you, that can trigger the use of the nutrients you're feeding your patients to make muscle. And again, this is an active this is a metabolite of leucine. It's in all human cells. All of us have this in our bodies. It occurs naturally in our cells. It's found in small quantities in many of our foods, avocados, watermelons, catfish. It's been studied in many doses for long periods of time. It's very safe, up to doses of 6 grams per day. The problem is, to get enough from your food, you'd have to eat 3,000 avocados, or about 500 watermelons, or about 750 catfish. No one's going to do that, right? So the good thing is now you can get it in a drink, which is really helpful. So again, what this does, HMB reduces muscle breakdown, and induces muscle synthesis. It's the anabolic signal that we need to use the nutrients our patients are getting. And it blocks a lot of different key pathways, like the ubiquitin pathway that breaks down muscle when we're sick and as we age. It inhibits that in a natural way like leucine does, only it's more potent. And it stimulates mTOR. mTOR is the major signaling molecule for muscle in our bodies. And this is a direct signaler of that, much like leucine, but more potent. So again, it improves muscle synthesis and reduces muscle breakdown in a natural way. So again, this is one of the key nutrients our body uses that we can now have our patients take in and our people take in. And it can break this cycle. The other thing that many of the studies show is it actually reduces inflammation as well. And it does this by a number of different processes. So it does a lot of the things that break this cycle that inevitably plagues our patients and those that we care for. So again, more than 100 studies that came out in the 90s. I've been taking it for almost 1996, so many, many years now. Decreases inflammation. For the original research was done in cancer and HIV when AIDS was devastating people. It was very effective at improving lean body mass in HIV and cancer patients. Athletes have been using it for years. It was developed for athletes to gain muscle without gaining fat. So it specifically targets the use of calories for muscle. Again, everyone's dream come true, and there's no side effects. It's very safe out to a year. So there's a ton of published clinical research and many systematic reviews of this. This is not a new thing. It's a naturally occurring supplement that many of us in the athlete world have been taking for many, many years. So again, what's some of the research? So again, if you look at healthy subjects, those with just elderly women taking HMB versus not taking HMB, they had significantly better muscle density after a short period of time. They had significantly better 6-minute walk tests. One of the key tests we do in all of our research studies to look at basic functions and quality of life is the 6-minute walk test. They had a 60% improvement in their 6-minute walk test from taking HMB. And there's other studies showing you have better hand grip strength, better muscle force. It does all the things we want a signal like this to do. There's been studies in wound healing as well. This was the first time I ever used HMB in a patient, was there's combinations of HMB with things to improve wound healing. So we use this often in the burn unit and other large wounds. And it's been studied. It shows much faster wound healing. I use this all the time in my wound patients. And again, it helps mobilize those patients too. They're stronger. And not only they're healing their wounds better, but they're stronger. And I think this to me is one of the best studies, the most compelling studies. Mick Deutz, who's the editor-in-chief of clinical nutrition, took elderly folks. Remember I showed you how much muscle an elderly person loses when you lay them in bed. This is a healthy elderly person. If you lay them in bed, they lose significant amounts of muscle. Mick uses very advanced tracer methods to do this. When he gives them HMB, they don't lose any muscle. So HMB can block the muscle loss from bed rest. I couldn't believe it, but he told me he's done this experiment numerous times. This is the only thing I've ever seen that can do this. And this is compelling data from one of the best muscle scientists in the world. So again, there's lots of meta-analysis data in the elderly showing that study after study, HMB can reduce the muscle loss and improve muscle gain in elderly patients and in elderly people in general. And there's data now from Danny Bear showing in ill, sick people in multiple different kinds of illness. Sorry, it's a little small to read, but that it can improve muscle mass and muscle strength as well. So it works to improve lean mass, hand grip strength, all the things for quality of life and muscle function you want it to do. What about clinical outcomes? Well, it's been studied there as well. And so, for instance, this is one of the studies in COPD, a common disease I know in much of Asia and much of the US as well. They gave patients that were on ventilators with COPD, HMB versus a placebo. 55% of the people getting HMB got off the ventilator versus only 25% in the control. So a significant number of people getting off ventilators. So I use this to help people get off ventilators. I've been using it probably for 20 years now to help people get off ventilators. And so it's very good at that. But then this is the compelling study that's led us to use, this is the only supplement we give to 90% of our patients at Duke. We use a high-protein oral nutrition supplement with HMB for all of our patients because of this study. It's one of the largest, if not the largest, oral nutrition supplement study ever done. 652 patients across 76 centers in the U.S. Some of the best scientists in all of nutrition were involved in this study. And then they followed them for mortality now, not muscle, but mortality out to 90 days after hospitalization for key diagnoses like acute MI and other critical diagnoses in the hospital. And what the data showed was if you take this supplement, a high-protein supplement with HMB, for 90 days after hospitalization, your mortality rate falls by half. It reduces death by half taking this supplement. This is the only oral nutrition supplement data like this I've ever seen in a large trial. Every 20 people you give this supplement to, you save a life. When this study came out, we shifted all our nutrition supplements at Duke to this one. This is the one we use in 90% of our patients. The only people who don't get this is some of our diabetics who there's a little too many calories in it for. And of course, it increased hand grip strength as well. So this is a critical time to be giving. Oh, I just lost my slides. This is a critical thing to be giving to your patients after hospitalization as well. At least 90 days is the time you should do. So there's a lot of data in both healthy and sick patients for the benefits of HMB, including a large randomized trial showing increased, not just muscle mass, but increased survival, which I think is really compelling. So what did we do for Elijah? So we have this very sick man who's just had a cardiac arrest, who desperately wants to live. So we started him on a high-protein supplement with HMB, and we worked with his family to keep going. We started him on a high-protein, the HMB, like I said. We started some testosterone because his level was very, very low. We started him on some other things as well, because for HMB to work at its very best, vitamin D needs to be normal. So again, you want to correct vitamin D if it's low. And then we did a few other things exercise-wise for this patient. We had him start to bring in his own weights to lift. Let me go back. He started doing sit-to-stands, basic get up and get off the bed and sit and stand like this. He had his own weights that his family brought in, and he worked really hard. 28 days later, after this patient, this 89-year-old patient had a cardiac arrest on the operating room table, he walked out of the hospital on his 90th birthday. And I didn't make that up. That's real. It was a miracle. And it's a miracle your patients can have too. This is actually Elijah, the day he went home from the hospital. This is him in his bed, and those things in his hand, those are his weights. This is what motivation and conviction from you as the physician or you as the caregiver working with your patients can do. So you may ask, so I'm an anesthesiologist and intensive care doctor by training. Why would I care so much about nutrition? As I finish, I'm going to answer that question for you, because you may wonder, why would anyone who's trained to be an intensive care doctor spend so much time on nutrition? And why do I hope you care about it? And I know because you're here, you do. But most of the people I talk to don't care about it nearly as much as you do. Well, how many of you have had surgery yourselves? Raise your hands. Raise your hands. So if you were in the U.S., the whole room would raise their hands. We've got data to say that every U.S. person will have 9.2 surgeries in their life. Now, many of these are cosmetic procedures. But nonetheless, everyone's going to have surgery. So someday this is going to be you or someone you care about. Although maybe you'll luck out and not have so many surgeries, because I've used up a bunch of yours. So this has been me. This is why I care about nutrition. This was me at age 15. I weighed 40 kilos in this picture. I had ulcerative colitis. I had inflammatory bowel disease. I was diagnosed as a 15-year-old. I was in the hospital for a year. TPN and oral nutrition supplements and enteral nutrition and dietitians saved my life. And this is where I discovered what nutrition could do. I was in the hospital for that year, and unfortunately my colon perforated, and I got septic shock and peritonitis. And so I had to be rushed to the operating room, where they took my colon out, and ultimately they had to remove it urgently. And then throughout the rest of my life, because of this, I've now had 27 abdominal surgeries. And I have 140 centimeters of bowel right now as we speak. And I have an ostomy, of course, because of that. And I'm short gut because of this. And so nutrition is critical to every day of my life. To give you an example of what real life looks like, in 2014, I was probably in the best shape of my life. Let me go back. This is me with my son visiting my grandfather. Probably the fittest I've ever been. And then I ate some quinoa. Don't ever eat quinoa if you've had bowel surgery. I got a bowel obstruction and ended up being rushed to my own emergency room. This is me in my own emergency room with a lactate of 10, being cared for by surgeons and residents that I trained, which was a little scary. And I ended up getting rushed to the operating room in shock with dying bowel. I ended up in my hospital on parental nutrition that I wrote myself. Because of this, I thought 2,500 calories ought to do it. I'm healthy, I'm fit. I shouldn't need more than 2,500 calories, should I? We'll see. I was in the surgical ICU for fear of bowel ischemia where I worked, because I had to have an open abdomen for a short period of time. And ultimately, I went from looking like this to 17 days later looking like this. I lost 20 kilos in 17 days. Remember I said you could lose a kilogram of lean body mass a day? I did. On TPN. I couldn't walk down the hospital hallway without being short of breath. I was running 10 kilometers a day before this. And so I've always thought that this is just part of being sick, and it doesn't matter who you are, you're going to lose muscle mass, you're going to get weak, you're going to lose weight. At Christmas, 5 months later, I couldn't pick up my youngest son because I was too weak. I was too weak to do it. So my ICU and surgical recovery and prehab is every day. It's every day part of my life. What did it take to recover in 2014? Took 4,000 calories a day and 2 grams per kilo of protein for 2 years to get back the weight and strength. I like to show pictures of me with my ostomy. I take care of a lot of ostomy patients, and they all think their lives are over because they have this bag on their side. And I tell them that there's nothing you could do before that you can't do with an ostomy. I was surfing in this picture in Hawaii just moments before this picture was taken. There's nothing I can't do now that I couldn't do before. And of course, exercise had to be critical to that as well. And so patient recovery is a personal passion for me because I knew I would be in the operating room in the ICU again. I always tell the residents that 2 a.m. phone call with a person with a terrible abdomen, yeah, that might be me someday, the one you don't want to see. So just come down, please. And unfortunately, this year, some of you know, in February, I started to have bowel obstructions again. And as it turned out, my ureter was adhesed to my intestine, and I was blocking my kidney. I was getting renal failure from it as well. And so I made the decision, because of these recurrent bowel obstructions, this is actually me in the hospital this year with one of them, that I would have an operation. I would volunteer to get operated on again, despite the fact I was told never to have surgery again, of course, and that I couldn't live this way. And so I went to the operating room on April 20th of this year, and I thought, gosh, this is going to be bad. I'm going to lose lots of weight. I'm going to lose lots of strength. It's going to take 2 years to recover. This is going to be bad. Well, maybe it doesn't have to be that way. I've always taught that it did, but maybe it doesn't. So again, surgical recovery begins before the day of surgery. It's true for cancer. It's true for any illness. These are all the things I took to get ready for surgery. And HMB was critical to this. I take it every day. If you went to my hotel room, you'd find a big bottle of it upstairs right now. And so I went to the operating room on April 20th, had a 13-hour surgery. They took out 20 centimeters more of bowel, so this is the shortest I've ever been. And they had to remove my gallbladder. It was adhesed to my bowel, and they couldn't get it out. Was admitted to my own ICU. This is actually me about a half an hour after I got out of surgery, this picture, thanks to my wife. And the reality is, of course, you have to get out of bed, and so I have to practice what I preach. This is me 12 hours after that operation, walking with my A-lines and my tubes and everything else in my own ICU where I work. That was on April 21st. Unfortunately, 2 days later, I woke up in the middle of the night with a fever, and my gown was soaked. And I looked down, and there was stool pouring out of my incision. I developed a big leak, and I had to be rushed back to the operating room twice over the next 2 days for severe peritonitis and septic shock. Bowel had perforated because of how much adhesions and how much lysing had gone on. I ended up intubated for a period of time in my own ICU, being cared for by my own residents and my own nurses. Sicker than I'd ever been at any time in my life. I developed a persistent GI fistula. They couldn't fix the holes. This was the complication I feared more than anything in life. Any of you who've cared for fistula patients, you know this can go on for years, right? Sometimes these never get better. And so I was terrified. And so I thought, oh gosh, now I'm really in trouble. I hope I ever get my muscle mass back. I hope I ever can exercise again. I hope I ever can come to India again and speak at Pensa or any other meeting ever again. Maybe that didn't have to be true, but I didn't know it then. So what can we do differently? What did I do differently? Well, one of the things I did, of course, is I used the metabolic cart. And I discovered some things I didn't know about myself. I found out that my basal metabolic rate, resting energy expenditure, is 3,000. So that 2,500 I was fed in 2014, not nearly enough. No wonder I wasted so much muscle. But this is if I was laying flat. Remember, resting energy expenditure is your energy expenditure when you're laying flat, never moving. So if you don't want to gain or lose any weight, feed that. But I was doing physical therapy every day. So we had to give 4,000 calories. The dietitians about died when I convinced them to write a 4,000 calorie TPN. But they did. This is me on 4,000 calories. And of course, I still have to take testosterone because I don't absorb cholesterol. I have no ileum. So I found out my testosterone was very low, so I take a small amount to replace it. I kept that going. I went home on TPN, MPO, for 3 months. 3 months at home. I'd never done that before. And then I transitioned to ONS with HMP. This is my dog helping to coach me. I realized you can actually do a lot on home TPN. In fact, if you look closely, this is, whoops, let me go back. This is me exercising with my fistula drain, with my open abdomen, my TPN catheter, and my TPN connector. This is me on the bike lifting weights. You'll hear my wife in the background saying, if you feel like you're getting exercise today or tomorrow, you're feeling a little peaked and you don't want to go, anybody can exercise. I discovered any patient can exercise. And anybody can do it no matter what. And I learned to do different kinds of weights with the physical therapist to protect my abdomen. But I noticed as I looked in the mirror every day in the hospital that my face wasn't getting thinner. And I got weight every day, and I wasn't weight. In fact, I had edema up to my waist. I actually gained weight in the hospital. But when I lost that edema, I thought, oh, I'm going to lose a lot of weight now. My weight was the same. I lost 5 kilos or less. I lost about 10 pounds. Total. Sickest I've ever been in my life. I was back at my pre-op weight in less than a month before I was even eating. I didn't think this was possible. Now, the other thing I'll tell you is my wife and I dance the Argentine tango competitively, and we do a lot of lifts. And so 8 weeks after my last surgery, I asked my surgeon, can I start doing lifts with my wife? We have a competition in 2 weeks. Can I pick her up over my head? And she's like, I think. What do you think? You think you can do it? And I said, well, I'm going to try. Operation. I didn't lose any strength. I didn't lose any weight. I didn't think this was possible, but it was. It's not mandatory that our patients suffer muscle mass loss. You can do this better. We can do this better. Again, I take a lot of supplements. And so again, it's going to take more than protein and calories aren't going to do this by themselves. I think the H&B is critical. I've always found it makes a huge difference. So my pre-op and pre-ICU preparation is part of every day. But how many of our patients are going to know how to do this to recover? Because we have opportunities to do better for them, and we have these opportunities now. I've lived it. Who's going to teach them? Well, you are. You're the people that care enough to be here to learn this, because remember, no nutrition is taught in medical school. No other doctors know how to do it, and they're not going to teach patients to do it. You are. You have a huge opportunity to change and save the lives of your patients. And realize that hospital recovery begins before the day of admission and continues long after discharge. And then we have to train our patients for the marathon of illness, of surgery, of cancer, because this is the marathon of their lives. They are running literally for their lives. And again, it has to start with us. All of us have to be better too. And so again, but if we do this, we can create survivors of our patients and not victims, because we can be better. And I think in Southeast Asia and in India, there's a huge opportunity to do better. It's much easier to put muscle on someone who's got a low muscle mass than someone who's already starting from a higher place. This is an emergency in Asia and India, I've learned. And so we have to be better. But how can we do that? Again, I don't think we're going to change the diets of all of Asia in the next few months. But again, I think given that we now have the opportunity to do it in a more easy way with supplements like H&B as part of a high-protein supplement, we know this works. We have the data to show this works. This is the anabolic signal our patients need, and it's a natural way to do it. So these are essential to recovery, to give that anabolic signal to make muscle. And of course, it's going to take some exercise too that I think we can teach our patients and all do ourselves. But in the end, we have to take responsibility for more than just what happens in the hospital. And we can take patients who look like this, have them looking like this, and then like Elijah, go home and have a meaningful life. He lived for 2 more years after this. At home, he met his granddaughter. His family told me he lived the life he wanted to lead, and he passed away peacefully the way his family wanted, not in a dramatic hospital event. And so in the end, again, this is the life we can give back to our patients. I'm going to mention this again for those who didn't hear. If you want to learn more about this, we have an online nutrition fellowship with 25 modules that's going to come out in the next 2 weeks. It's for all practitioners, dietitians, physicians, pharmacists, and we have people around the world joining us. You interact with other people. You interact with experts, Meta Berger, myself, Arthur Van Zandt. Numerous people are teaching in this course. All different topics, metabolic cart, perioperative nutrition, ICU nutrition. I encourage you to sign up and join. You get to interact with these people and get to know them and get to know your peers. And so again, in the end, this is what we're left with. This is what we need to do, and I encourage all of you to follow on social media. That's where I'll post about the fellowship. And I would be happy to share these slides or answer any questions or share any papers with anyone in the audience. Thank you.
Thank you. I don't think there's anybody else on this planet who has achieved so much despite having so many medical issues as Paul Wischmeyer here, and a standing ovation to him, please.
Means a lot. Thank you so much. I'm just happy I can be with all of you today.
Well, we'll be breaking for lunch, but please feel free to interact with Dr. Paul Wischmeyer for any of the questions and doubts. But I follow him on Twitter. I've been following it for so many years. And he's been so kind enough. In fact, when he ruptured his bowel, I sent him best wishes. He replied back.
Yeah, so many people supported me from around the world, and it was really inspiring. I think it's half the reason I got better. I don't think I'd be here without all of you who were so supportive. It means so much.
Thank you. Thank you all.
Oh, photo. Thank you. Thank you. Thank you. My pleasure. My pleasure. Do I have everything? Thank you for your help. That was great. Yeah. We can make sure I think I got everything. Thank you. I'll take my mic off.
Number
An announcement to all of you all that the next session will start at 2:30. I know your lunchtime is less, but please do cooperate. The next sessions in the parallel areas also will start at 2:30.
Oh, thank you. I appreciate all the help I never hear. More toxins. This is the best thing
बोल कौन? हाँ क्या हुआ? हाँ ठीक है बेस्ट करूँगा। ठीक है बेस्ट करूँगा।
अभी चलेगा कौन सा है खोल
अभी देखो अभी देखो।
कौन सा
हेलो हाँ भाई आ गया। हाँ ठीक है आ रहा हूँ।
नहीं पहले ये नहीं पहले ये लगा
कौन सा?
ठीक है खोलो खोलो सब एक साथ है
हाँ
या अलग अलग है
सब
ये
एक ही
सब
साथ।
एक साथ है ना
अरे ये दिया।
अच्छा ठीक है इंट्रोडक्शन सेशन का
ये तो शेयर कर सकते।
पहले इंट्रोडक्शन
इंट्रोडक्शन का
हाँ
इंट्रोडक्शन का आ जाता
अपने आ जाएगा कैसे
सीधा इधर आ जाता
कौन लोग कर रहा है
उधर से आ जाता। इंट्रोडक्शन का है ना तो इंट्रोडक्शन को उधर आता पहले पीपीटी इस पे
ये दोनों का इस है वो जो ये वो तो मैंने पढ़ then once they come
they will take over. Should I start? Hello and good afternoon to all. Myself is Dr. Ashwin Dadi. On behalf of entire organizing committee at the local level and also at the international level, I welcome you all in this very difficult post-lunch session. And I'm very happy that all of you had fulfilled your acute caloric deficit in a very lunch which was served in a sumptuous way. Thank you so much for attending this Symposium 5, which is being sponsored by, our Asian international organization. One of the very giant, we call it a Otsuka Pharmaceutical India and Otsuka Japan. So once again, I welcome you all for these wonderful academic meetings. With that, I just like to invite the chairpersons for the symposium. First chairperson is Dr. Vinay Unipintong. He is the president of the Society of Parenteral and Enteral Nutrition of Thailand. He is affiliated with the Surin Hospital, Thailand. And he was the first surgeon to introduce the enhanced recovery after surgery protocol in the country of Thailand. And his areas of interest are ERAS and nutrition in surgical and critically ill patients. Thank you so much, sir.
Namaskar. Good afternoon, everyone in this room. First, I would like to thanks to the organizing committee that invited me to be a chairperson in this session. And this session is sponsored by Osuka Pharmacy, as you know. And today we have the three lectures from the famous speaker, two from Japan and one from India. I would introduce the first two speakers, and then my co-chair, Dr. Balu, will introduce the first speaker.
So before that, Dr. Vidya, I like to invite Dr. Balu. He is a very close friend of mine, and he is the first surgeon from southern India to roll out the total nutritional management program in India, which has got a huge success in Japan. And India is fortunate enough to roll out this program amid the COVID pandemic. He is a consultant surgical gastroenterologist and clinical lead and is the director for the Department of Clinical Nutrition. Now we don't call it a Department of Dietetics because nutrition as a whole is a separate science. So he is the director for the Department of Clinical Nutrition, PSG Hospital, Coimbatore. And his areas of interest are the minimal invasive surgery, clinical nutrition, and he has been faculty for the Ethicon for the colorectal surgery and the robotic surgery. Welcome, Dr. Balu, and over to you. Thank you so much.
Thank you. I would like to invite our first speaker, Dr. Ryuichi Fukushima. Dr. Fukushima is the professor of surgery at Teiko Heisei University in Japan, and he also the past president of the Japan and Japanese Societies of Gastrosurgical Pathology, and he also the lots of membership in the professional organization, including ASPEN and ISPEN. And today we give a talk about assessing subclinical vitamin B deficiency in the peripheral parenteral nutrition. Please welcome Professor Fukushima.
Good afternoon, ladies and gentlemen. Thank you, Dr. Ping Pong Do, for your kind introduction. And I'm very happy to be here to present at this prestigious meeting. I'd like to thank Dr. Reddy, the president, and the organizing members of organizing committee. And also I'd like to thank to Otsuka Pharmaceutical Company. Well, actually, this is my first visit in India, and I'm very interested in the atmosphere of this country. Today, I'm going to talk about parenteral nutrition and vitamin B1. I have no, okay. As you may well know, that parenteral nutrition is indicated when oral intake or enteral nutrition is not feasible, or the amount of these intakes are not enough. Total parenteral nutrition can give you full amount of nutrients through the vein, but you need central venous access. In contrast, peripheral parenteral nutrition, PPN, can give some amounts of energy and protein via peripheral vein, which is simple and very convenient. You can easily use as combination with oral meal or enteral nutrition. Well, I'm an upper GI surgeon, so let's look at the nutritional status after gastrectomy. In contrast to colonic surgery, body weight loss is inevitable after gastric cancer surgery. The body weight continued to decrease up to 6 months after surgery, and the decrease greatest in the early post-operative period. And this decrease is pretty much correlated with energy intake as well as protein intake. Let's look at how much gastric cancer patients can eat after surgery. This is the result of the multicenter study that looked at the effects of early oral feeding after gastrectomy. Patients can eat very early after surgery, but even though they can eat early, the amount of food actually taken is not enough. In the cases of total gastrectomy, they can only eat like 185 kilocalorie on POD1 and 723 kilocalorie per day in POD7. And numerous clinical studies have reported that post-operative weight loss after gastrectomy is associated with a variety of adverse outcomes. Therefore, how to suppress weight loss in the early post-operative period is of great importance. Using PPN, peripheral parenteral nutrition, you can give a very good amounts of energy and protein in patients after gastrectomy, adding to the oral meal. The attempts to administer amino acids intravenously began in early 20th century. In 1913, protein hydrolysis were intravenously infused to goats. In 1939, Elman first used hydrolysate of casein to humans and maintained nitrogen balance. It was in the 1940s that amino acid began to be used clinically as parenteral nutrition. However, the product at that time was a hydrolysate of casein or fibrillin. Therefore, not only amino acids but ammonia and peptides were also included in the solution. Composition ratio of amino acids was not constant, and in addition, there was contamination with other impurities, which produces fever after infusions. Since 1946, crystalline amino acids were produced in the Japanese manufacture. Crystalline amino acids were used for the products. In 1946, Hoare introduced the VUJN composition of amino acids were in natural L forms. After that, many formulas are introduced. In 1957, Food and Agriculture Organization of the United Nations proposed FAO composition. Like VUJN, non-essential amino acids was 3 amino acids of glycine, arginine, and histidine. In 1965, a new composition was proposed, primarily referred to the composition of human milk and whole eggs. It contains essential and non-essential amino acids of about 50 and 50. In Japan, the Amino Acid Review Committee was organized in 1976, and new composition was suggested. The composition is considered to be suitable for patients with stress. BCA was increased to 30%, essential amino acids are increased, and amino acids that become toxic when overloaded, such as glycine, glutamate, and aspartic acid, are reduced, making them useful during stress. Many of the products in Japan now adapted this formula. Okay, now let's move to the topic of vitamin B1 and parenteral nutrition. And the main clinical question is, should we add vitamin B1 to peripheral parenteral nutrition? Vitamin B1, as you know, was first extracted from rice bran in 1910 by Japanese scientist Umemoto Suzuki as a factor to prevent bell belly. He named it orizanin. He published this discovery in a Japanese scientific journal that found a new nutrient, orizanin, that has anti-bell belly effect. The article was then translated into German, but the translation failed to state that it was newly discovered nutrient, and hence discovery failed to gain publicity in the world. The following year, Polish chemist Funk discovered the same nutritional component and named it vitamin. Now this has become famous. all over the world. Today, role of vitamin B1 is well documented, an important cofactor for carbohydrate metabolism, and there has been increasing recognition of its importance in neurological function. This shows the TCA cycle. Vitamin B1 is an important cofactor for glucose metabolism. As you can see here, B1 is cofactor for pyruvate dehydrogenase. So if you don't have vitamin B1, pyruvate cannot go into the TCA cycle and go this way, going this way to make lactate. And also, this is blocked here, so the TCA cycle cannot go through smoothly. So giving glucose without B1 may lead to overproduction of lactate here and induce lactic acidosis. The vitamin requirements are shown here, and required estimated average requirement is 0.8 to 1.2 milligram per day, which indicate the amount that would meet the nutrient requirements of 50% of the population. The LDA is 1.1 to 1.4. The recommended dietary allowance indicate the amount that would meet the requirement of most of the population. For parenteral nutrition, dose of 3 milligram is recommended by American Medical Association and is increased to 6 milligram by FDA in 2000. Vitamin B1 in human adults can store around 3 milligram of thiamine in muscle tissue and liver and kidneys. These stores can, however, become depleted in as little as 18 days after the cessation of thiamine intake. This leads to a variety of clinical features that are often vague and sometimes non-specific. Okay. And the famous clinical manifestation of vitamin B1 deficiency is shown here. The malaise, baby-like symptoms, baby lactic acidosis, and Wernicke-Korsakoff syndrome. The malaise is somewhat similar to autonomic imbalance, sometimes vague and non-specific, numbness, edema, general malaise, palpitation, anorexia, and so forth. And Berberi is the famous for the B1 deficiency and peripheral vasodilation, biventricular myocardial failure, volume overload, tachycardia, depression to left ventricular function with low ejection fraction, sudden onset of cardiac failure, and acute renal failure are some of the signs of Berberi. And the other one is a lactic acidosis that occurs within 2 to 3 weeks when vitamin B1 is not administered during TPN treatment, and unconsciousness, decreased blood pressure, cyanosis, and crystal respiration are known common symptoms. These symptoms did not improve with sodium bicarbonate and reacted to the administration of large amount of vitamin B1. Often occurs when a large amount of carbohydrate is administered under conditions such as stress or gluconeogenesis. Also occur during liver failure, renal failure, because such organs are key organs in the metabolism of lactate. Wernicke-Korsakoff syndrome is first reported by Wernicke in 1881. Double vision, dizziness, and anemia appears as primary symptoms as characteristic. And although disease is treated by administering large amount of vitamin B1, the disease may progress to Korsakoff syndrome, and this is irreversible. The risk becomes higher in patients with malnutrition, calcimatosis, alcoholic hepatitis, and toxemia during pregnancy. Now, first, I'd like to summarize the history of B1 deficiency during TPN therapy. This is the urgent alert of USA in 1988. This alert described that death case happened with vitamin-free TPN, and this alert strongly suggested that the reason of death were vitamin B1 deficiency. This is also the USA's document after happening of multivitamin shortage in 1996. This document also described the importance of vitamin B1, especially during carbohydrate load. In 1992, the notice the following notice was issued from the Japanese Ministry of Health in 1992 that expense of parenteral vitamins for patients who take oral meals will not be reimbursed by National Health Insurance. And parenteral vitamin administration were omitted from majority of patients who received PPN and also some of the patients who received even TPN. In such states, there's one case, a 30-year-old male underwent total gastrectomy due to malignant lymphoma of the stomach in July, and he was on TPN for 36 days without vitamins. And in August, diplopia, dizziness, gait disturbance, and amnesia were observed. The patient was referred to the university hospital and was diagnosed with Wernicke encephalopathy caused by vitamin B1 deficiency. Even after therapy, recent memory impairment, eye movement disorder, toxic gait, and numbness of the lower limbs persisted, and the patient was not able to work. The physician in charge was sued for not adding vitamin B1 to the TPN solution administered, and the patient claimed the right to be paid for health damage. The district court handed down an order to the physician to pay a damage of about $1 million US. Well, there are several of these cases, and the newspaper in 1997 reported 41 deaths after receiving TPN without vitamins, and expensive financial compensation were ordered by the courts. And the Ministry of Health produced the urgent letter, and it is emphasized that the TPN needed vitamin B1. So, the response to this, the manufacturer also launched TPN kit preparations containing vitamins. So now after 2000, you have the glucose, electrolyte, amino acid, and vitamins in all-in-one kits that would not omit vitamin administration during TPN. What about TPN, PPN? To find a clue to answer this question, we conducted clinical research looking at the time course of vitamin B1 concentrations in the blood before and after digestive tract surgery. 23 patients were included, gastric cancer, colorectal cancer, and others. Performed surgery was distal gastrectomy, local resection, colectomy, anterior resection, and others. This is the result. The lower limit of vitamin B1 was set at 28 milligram per liter, suggested by the Japan Vitamin Standardization Revised Committee. And the level is here. And vitamin B1 concentration, blood decreases after surgery, and it did not recover with a normal range even after the resumption of oral intake. And we also looked at the vitamin B1 status in post-operative patient more than 3 months after discharge at home with oral meals. 10 esophageal and 21 distal gastrectomy and 15 total gastric patients. And this is the result of this. And 33% of esophageal surgery and 43% of distal gastrectomy, 40% of total gastrectomy, they had the subclinical deficiency of vitamin B1. So, potential subclinical deficiency in vitamin B1 is seen in upper GI post-operative, perioperative patients. This is the data of blood vitamin B1 concentration in India. 150 patients were included, and if you look at the serum vitamin B1 levels, surprisingly, 72% had low vitamin B1 levels. And here I'd like to show you a case of lactic acidosis due to vitamin B1 deficiency after gastrectomy during peripheral parenteral nutrition. 64-year-old male with gastric cancer patient who underwent gastrectomy, discharged from hospital, and resubmitted 5 days later because of general fatigue and dehydration. His blood test is showing severe dehydration, and he was on PPN for 3 days, and dehydration improved, but subsequently developed neurological symptoms and metabolic acidosis. When blood B1 was measured, it showed a very low value of 20 nanogram per ml. Then B1 was administered immediately, and lactic acidosis was improved 3 hours later. B1 was continued and discharged at 4 weeks later. This is another case of Wernicke encephalopathy during chemotherapy of recurrent endometrial cancer under PPN. A 60-year-old female underwent hysterectomy, adenectomy, lymph node resection, and post-operative chemotherapy was done. Recurrence of the vaginal stump after 1 year and chemoradiotherapy was started, but due to generalized malaise, diarrhea, and abdominal pain, patient was admitted to the hospital, and she was on PPN And 6 days later, diplopia, day 13, decline in consciousness level, and day 15, diagnosed with Wernicke encephalopathy by MRI. Blood B1 level was 14 nanogram per ml, and B1 was started. 5 milligram of B1 was started, and she recovered after this treatment. So, in summary, potential subclinical deficiency in vitamin B1 were seen in post-operative patients or the preoperative patient of digestive tract malignancies. Vitamin B1 concentration in the blood decreases after PPN, and sometimes B1 deficiency lead to serious conditions. So, do we need vitamin B1 in PPN? Today's main clinical question. And the answer is yes, we need vitamin B1 in PPN. The conclusion is just mentioned. It is safe to add vitamin B1 to PPN solutions. Well, thank you very much for your attention.
So thank you very much for your informative lecture, Professor Fukujima. I move on to the second speaker, and after finish the third speaker, we will have a time to Q&A sessions. So I would like to introduce our second speaker, Dr. Michio Maruyama. Now he's the president of the hospital, Tanashi Hospital in Tokyo. He's gastrointestinal surgery experience and have involved in many associations of the nutrition society. So he have the area of interest in the enteral nutrition and post-operative nutrition treatments. Today we have a talk about the optimal nutrition management by early enteral nutrition after upper GI cancer surgery. Please, Professor.
Okay. Thank you for having me, Chairman, Professor Winpinit Pong, and Professor Mao. And it is a great honor for me to be here and give the presentation today. And my name is Michio Maruyama, working in Tokyo as a gastrointestinal surgeon. I'd like to express profound appreciation to Pensa 2022 organizing committee and sponsor of this session, Pharmaceutical India. And my presentation today is optimal nutrition management by early enteral nutrition upper GI cancer surgery. Let me start. My presentation today consists of the two parts. First, I would like to ask about the general concepts of the post-operative early EN, especially from the aspect of the guidelines and clinical trials. Afterwards, I would like to talk about my experiences of the post-operative early EN after upper GI cancer surgery. Concerning the postoperative nutrition, which route should choose, EN or PN? We think about it from the authorized guidelines and recommendations. ESPEN, ASPEN, SCCM, and JASPEN, all three guidelines recommended EN superior to PN. The most consistent outcome effect from the EN are reduction of infectious complications and ICU LOS. This meta-analysis shows EN is beneficial for infectious complications compared with the PN in critical illness. But recent ASPEN guidelines 2021 suggested EN equal to PN. Next, we think about the timing of the initiating the EM for the postoperative patients. These three guidelines recommended early EM rather than delayed EM. This meta-analysis figure showed the provision of early EM was associated with a significant reduction in the mortality. In addition to the mortality, the incidence of the infectious complications was reduced compared with the delayed EM. This systematic review meta-analysis of the EM versus PN after GI surgery showed EM compared with the PN was associated with fewer complications, fewer infectious complications, fewer anastomotic leak, fewer intra-abdominal abscess, decreased duration of the hospital stay. This study concluded that the use of EM rather than PN was recommended when possible and indicated. Postoperative early EM might be the optimal nutritional management after major abdominal surgery. This slide shows actual procedure postoperative early EM for the major abdominal surgery from the SPEN guidelines. Placement of the nasogastrojejunal tube or NCJ should be considered for all candidates for EN undergoing the major upper GI and pancreatic surgery. EN shall be initiated within 24 hours after surgery. It is recommended to start EN with a low flow rate and to increase the feeding rate carefully and individually due to the limited intestinal tolerance. The time to reach the target intake can be very different and may take 5 to 7 days. I will show you the target energy of the critical ill patient from each guidelines. In SPEN 2006 in acute phase, 20 to 25, in the post-acute phase, 25 to 30 kilocalories. In SPEN new guidelines indicated indirect calorimetry and predictive equations. Hypocalorie less than 70% is recommended. In ASPEN SCCM 2016, IC or predictive equation, whichever you use, isocaloric and 25 to 30 kilocalories. In ASPEN 2021, 12 to 25 kilocalories in the first 7 to 10 days. GSPEN recommendation is the same with the ASPEN and SCCM. This study shows the outcome of the ICU patient in relationship to the administered calories and protein intake. In this graph, the percentage of the administered calories divided by the REE. This is a 60 days mortality. This graph shows a U shape. Both underfeeding and overfeeding appears to be harmful. The percentage of administered calories up to 70% associated with a decreased mortality, and particularly as the curve increased more than 100%, increasing the mortality. In this graph, percent of the target protein target 1.3 gram per kilogram. This is 60 days mortality. Protein provision independently associated with the decreased mortality. More protein, decreased mortality. This study shows optimal dose of the energy and protein are not parallel. The relationship between the energy intake and outcome, for example, the mortality, hospital stay, or the complication rate shows a U-shaped relation. Optimal energy range is located at the bottom of U-shape. Lower intake and higher intake both are associated with increased mortality. Overfeeding might be lead to more episodes of the hyperglycemia and need for the high-dose insulin therapy and infectious complications. Undernutrition leads to the prolonged energy deficit and high mortality. How about the target protein intake for clinical ill and postoperative patients? Protein is the most important macronutrient, especially in the anabolic phase after the surgery. Many observational studies have shown that the provision of the more protein as compared with the lower intake is associated with the reduction in mortality and morbidity. In SPEN guidelines, 1.3 gram per kilogram per day can be delivered progressively. In Aspen guideline, in range of 1.2 to 2.0 gram per kilogram per day. In JSPEN, the same. This is one of the observatory studies concerning the provision of the protein for the clinical illness. As you can see, this survival curve of high protein group 1.5 gram per kilogram, medium protein group 1.0 gram, low protein group 0.8 gram. The result was a significant increase in the survival with the increased protein provision. But provision of the energy and other factors are not related to the mortality. This observational study was conducted for mechanically ventilated patients. Energy target measured by indirect calorimetry protein target 1.2 gram per kilogram. Primary outcome 28 is mortality. Neither target group, neither energy intake nor the protein intake did not meet the target. Energy target group, energy target intake reached the target, but the protein intake did not reach the target. Protein plus energy group, both of them met the target. Result shows for 24 mortality hazard ratio of the energy and target group 0.83, protein plus energy target group 0.47. This means optimal nutrition therapy defined as a protein and energy target widget associated with decreasing the 24 mortality by 40%, 50%, whereas only reaching the energy target is associated with reduction in the mortality, not associated with reduction in the mortality. Protein provision reaching to the target is important for the optimal nutrition therapy for the critical illness. Next, I'm going to talk about my experiences about the postoperative early EN for major cancer surgery. When you want to implement EN for the postoperative patient, the route of EN is necessary. This schema shows how to place the jejunostomy in the major cancer operations. This is esophageal cancer operation, esophagectomy, reconstruction with the gastric tube. You insert the EN catheter from the gastric tube and put the tip of the catheter in the jejunum beyond the pyloric ring. This is a total gastrectomy Roux-en-Y construction. You insert the EN catheter from the Y loop and put the tip in the efferent loop beyond the Y anastomosis. This is Ripple operation. As you can see, how to put the catheter, the tip is placed in the jejunum. I always use my original needle catheter kit for implementation of the jejunostomy. This is the 9-French catheter. I insert the needle into the Y loop and put the catheter along the teeth. This shows the catheter put in the jejunum was pulled out through the abdominal wall. And this is the outlook of the abdomen after surgery. You can see EN catheter which is fixed with the skin. This is my schedule of post-operative early EN, starting within the 24 hours after surgery, actually in the next morning after the operation. Continuous infusion using the EN pump, stepwise increase of the velocity. This table shows actual schedule, velocity, operation day, none, 1 POD 10, 2 POD 20, 3 POD 40, 4 POD 60. On the other hand, peripheral infusion was decreasing as the day goes. I ensured this schedule was feasible. Following this schedule successfully, incidence was 84%. Decreasing velocity was a temporary stopping EN because of the distension of the abdomen or some other abdominal symptoms, 12%. Converting to the PN is only 4%. This table shows energy and protein provision when you use the commercial standard enteral formula twin line, which is common type. 1 kilocalorie per milliliter NPCN ratio is 140. As you can see when you follow my early EN schedule, EN volume 0 up to 1440 milliliter. Energy also 0 up to 1440 kilocalorie per day. Protein 0 up to 58.3 gram per day. When you think about the patient with 60 kilogram body weight, energy 4 up to 24 kilocalorie per kilogram. If you take the target energy 25 kilocalorie per kilogram, probably this schedule would be okay concerning the energy provision. Protein 0.16 up to the 0.97 gram per kilogram. From the guideline target would be 1.3 gram per kilogram or 1.2 to 2.0 gram per kilogram. This protein provision is much less than the target. This graph shows the nitrogen balance of early enteral nutrition of the total gastrectomy patients. Up to 3 POD, nitrogen balance was below 0, which means the state of catabolism. And after 4 POD, the nitrogen balance was positive, which means the enters the anabolic phase. From this point of view, we can identify 1 to 3 POD would be the acute phase, and after 4 POD would be the anabolic phase, post-acute phase. I try to enhance the protein provision by changing the mixing the ratio of this unique enteral formula product. Twin line consists of liquid A and B. Prior to the administration, you mixed A and B and administered. Liquid A does not contain any protein at all. Liquid B contains a protein. If you change the mixing ratio A and B, you can change the NPCN ratio. As you can see this table, A 90 milliliter, B 200 milliliter, you can get the NPCN 50 enteral formula. A 180, B 200, NPC 100, A 200, B 150, NPCN 150. I tried these various NPCN formulas for the total gastrectomy patient. As you can see this table, from 1 to 3 POD, in early acute phase, NPCN 50 was adopted. 4 POD to 5 POD, NPCN 100, and after 6 POD, 150. This results of the nitrogen balance. When you use the original formula NPCN 140, as you can see, up to 3 POD nitrogen balance was negative, and after 4 days nitrogen balance enters the positive side. On the other hand, various NPCN formula, you can see the nitrogen balance enters the positive side on 3 POD 1 day earlier than original formula. In a sense, the 1 day earlier recovery in the aspect of the postoperative metabolism. In clinical aspect, it is difficult to achieve the protein target without the overfeeding using the standard enteral formula. A standard commercial enteral formula NPCN ratio is 120 to 150. When you want to meet the protein target for critical ill patient, it leads to the energy overfeeding. To avoid this issue, you can use the high protein enteral formula, for example, enteral formula with NPCN ratio 70 to 100. Using the enteral protein supplements or supplemental amino acid solutions. Recently, high energy and high protein enteral formula was available. 1.5 kilocalorie per milliliter, protein 9.5 gram 100 milliliter, and PCN ratio 74. I tried these products for early enteral nutrition. This table shows the early EN schedule. When you administer high energy and high protein enteral formula to the patient with 60 kilogram, as you can see, for POD, 36 kilocalorie per kilogram and 2.28 gram per kilogram. From the guideline point of view, there are too much energy and too much protein. Nitrogen balance of high energy and high protein energy formula on the two POD nearly zero. Nitrogen balance was positive 1 to 2 days earlier compared with the common type EN, and nitrogen balance far exceed to the common type nitrogen balance. This is the time course of the BUN of the high energy and high protein enteral formula administration. All of the cases show the BUN over the normal limit. Blood glucose also was higher compared with the common type early enteral formula. High energy and high protein enteral formula provide too much energy and protein, especially in post-acute phase. To improve these issues, I tried this study. I tried to high energy and high protein enteral formula for first 3 days, and after that, I changed the enteral formula to the standard common type. When the body weight is 60 kilogram, as you can see, the first 3 days and after for POD, for POD, energy not exceed the target 24 kilocalorie per kilogram, protein provision about 1 gram per kilogram. This is a bit lower than the target. I dare say probably a standard 1 kilocalorie per milliliter enteral formula with enhanced protein, for example, the NPCN ratio about 100 would be adequate for the postoperative early enteral nutrition. This is a nitrogen balance of this study. Blue line is the first 3 days high energy and high protein enteral formula. After that, the common type. And red line is all over high energy and high protein. Both lines shows the nitrogen balance shows the positivity on 2POD, early metabolic recovery. High energy and high protein group shows a BUN over normal limit, but within the normal limit in the enteral formula changing group. This new schedule of the postoperative early EN changing the high energy and high protein formula to the common type shows the early positivity on N balance and stable BUN. I will move back to the main theme. It is necessary to consider the long-term nutrition strategy after the surgery. Most postoperative patients start eating in the post-acute phase, but they don't eat a lot enough for the recovery. Actually, after the postoperative phase, more energy and more protein required for the recovery and the rehabilitation. After the major abdominal surgery itself, adjuvant chemotherapy, cancer recurrence, these many factors lead to the decline of the oral intake. They have a lot of risk of developing the malnutrition, so you should be prepared for the postoperative malnutrition and sarcopenia. For prevent the risk, additional enteral formula, for example, the home EN, oral nutritional supplement, ONS, or diet counseling would be the effective. I show you my experiences of the seamless nutrition support for the post-op GI surgery. I start early enteral nutrition via jejunostomy after surgery. On the post-acute phase, the patient starts a post-operative diet. This patient was 85 years old, underwent the total gastrectomy stage 4. She could not eat much. She started the practice of the home enteral nutrition during the hospital stay, how to prepare the enteral formula, how to set the infusion pump, how to wash the dishes, how to wash the devices. After discharge, the patient do home EN by themselves in addition to the oral intake. My experience is 1/5 of the total gastrectomy patients and half of the esophagectomy patients maintain the QL well with home enteral nutrition. These two RCT demonstrated the efficiency of the jejunostomy HEN after upper GI major surgery. 6 weeks of the HEN versus standard care after the esophagectomy or total gastrectomy. This study shows lost body weight 3.9 kilogram less in HEN group at 6 weeks. HEN by the jejunostomy was feasible, safe and acceptable to the patient and their carers. 2 months HEN versus standard care in the malnutrition patient with upper GI cancer, intestinal cancer surgery. This study shows lost body weight 5.3 kilogram less at 2 months, 3.2 kilogram less at 6 months in HEN group, and complete chemotherapy rate HEN group 48% vs standard group 34%. Placement jejunostomy should be considered in the upper GI cancer operation, especially for the malnourished patient for the purpose of the HEN after discharge. This is my conclusion, this presentation. Thank you for the attention.
Thank you, Professor. The questions will come at the end of the session. May we invite the next speaker, please? May I invite Dr. Harsh Sheth? He's a consultant laparoscopic GI and bariatric surgeon practicing in Mumbai, including Saifi hospitals. One of the few surgeons who has the privilege of being called a surgeon scientist. He has got a few patents in his name, and his main area of interest is bariatric, minimal invasive, and GI surgery. So he's going to speak to us about PPN supplementation in the non-ICU hospitalized patients in India, which is an interesting but important topic where we are concentrating only on the critically ill patients who are in the ICU, but this is a study from India which has concentrated on the non-ICU hospitalized patients. Over to you, Dr. Harsh.
Thank you. Thank you to the organizers and Otsuka for giving me this opportunity to present this. We're going to talk about the study that we performed in the Indian setting for non-ICU patients using PPN. But just a brief overview of what we are going to speak about. Malnutrition, of course, we all know is a problem in hospitalized patients. It causes increase in the length of hospital stay, increase in morbidity, mortality, increase in rate of readmissions, and obviously an increase in the rate of infections. Now, all of these lead to poor clinical outcomes. So how do we tackle it? The old adage holds true, that is, prevention is better than cure. So prevent malnutrition and you'll prevent all these problems. So the hospital malnutrition is a public health problem globally. Approximately 30 to 50% of hospitalized patients are actually malnourished. Malnutrition obviously leads to a lot of these problems. There's a metabolic stress, inflammatory response, the SIRS response is activated. There's a reduced dietary intake, and obviously a change in the functional capacity. So there's this interesting study that was performed in the United States where approximately 10,000 adults who were hospitalized in 601 wards were analyzed for malnutrition, and 32.7% of patients were actually found to be malnourished. That's 1 in 3 patients. Now, all of these patients obviously have an increase in the risk of hospital mortality, which highlights the ongoing issue of malnutrition in the hospital setting. The clinical outcomes, as we already said, obviously there's an increased risk of the length, there's an increase in the length of hospital stay, there's obviously a poorer survival rate in patients who are malnourished, and it's obviously going to lead to worse clinical outcomes. So the esteemed speaker before me spoke about enteral nutrition, but the question is enteral nutrition alone sufficient? Now, underfeeding is obviously a big problem, as Professor before me highlighted. Only 14 to 52% of patients who they actually achieve their adequate goal energy intake during the ICU stays. The average protein intake was, well, again, around 38 to 82% of the requirements. So, underfeeding again will lead to all adverse clinical outcomes. So, the importance of parenteral amino acid supplementation is to prevent all of these problems. And what proteins essentially do is by causing patients to retain the muscle mass, by causing a reduced systemic inflammatory response syndrome, it actually improves recovery and survival. The SPEN guidelines, like we all know, have stated that the hospital diet should cover around 30 kilocalories per kg of body weight and at least 1.2 grams per kg of proteins. So here's an overview of what we call the Chalo Ward project, which was done in association with Otsuka Pharmaceuticals. This is basically a multi-centric case series wherein we were basically trying to figure out what is the effect of partial parenteral nutrition on hospitalized patients in terms of the nutritional outcomes. So the Chalo Ward project, we had 49 investigators across the entire country, different specialties. There were 33 cities that were involved. 80 patients were enrolled, 42 males, 38 females. All of these patients were given Selamin 10 plus, which is a 10% amino acid solution with electrolytes, which is a 500 ml solution. All of them were given this once a day for 5 days. Now, before and after administration of Selamin, what we studied is the serum prealbumin and serum retinol binding protein levels, which are accepted markers of identifying nutritional status for most patients. And the expected outcomes were an improvement in the pre and post administration values after administration of Selamin 10 plus. So these are the baseline characteristics. As you can see, the maximum number of patients enrolled were from the intensivist. But actually, if you combine the general surgeon and the gastrosurgeon, you will see that surgeons actually had a higher percentage to play. The subgroup intensivist was obviously a major category, but combining the surgeons would obviously make them a bigger force. So the incidence of malnutrition was higher in males as compared to females. The age group, as the age group increases, obviously malnutrition is worse because many patients have nutritional deficiencies to begin with, which can cause trouble. So here are the changes in the prealbumin levels and the retinol binding protein levels before and after the intervention. So these were studied by the PET test. If you can see the baseline and post intervention, there was a significant improvement in the prealbumin levels as well as the retinol binding protein levels in all of these patients. This indicates that use of parenteral amino acid supplementation only for 5 days in hospitalized patients actually would improve their clinical outcomes. So the result from the subgroup analysis, this was from the intensive care analysis, again showed the same observations. So the results of this multicentric series show that administration of parenteral amino acids, that is Celamin 10 plus or similar, they actually improve nutritional markers, that serum prealbumin and retinol binding protein, in hospitalized patients with malnutrition. Additionally, benefits were obviously also seen in subgroup analysis of patients under the critical care by intensivists. Obviously, a lot of intensivists still do, especially in India, I don't know how it is otherwise, but they still do believe in the use of albumin infusion as opposed to parenteral amino acid infusion. And we'll speak a bit about that now. So here we're trying to bust myths. And the myth is that infusion of albumin actually improves nutritional status, and that is not true. I think all of us have read multiple trials, multiple systemic analysis, randomized control trials, which actually prove that intravenous albumin is used only to increase colloid osmotic pressure rather than cause and improve in the nutritional status. Albumin, of course, has its role in terms of increasing the colloid osmotic pressure, but apart from that use, it doesn't really make a difference in the nutritional status of the patient. I'd like to end by talking about some take-home points. Parenteral amino acid supplementations actually help to preserve active tissue mass and maintain a variety of other essential functions. Early infusion of parenteral amino acid supplementations actually will lower mortality in critically ill patients, as well as prevent malnutrition and improve clinical recovery in hospitalized patients. Serum albumin infusion does not provide any benefit, any nutritional benefit to malnourished patients. This Chalo Work program was obviously a multicentric case series. Of course, it has its limitations, but we do hope to perform a larger double-blind clinical trial with randomization for hospitalized malnourished patients across the country. Thank you.
So, thank you for Professor about the informative lecture. Now we have the time for the Q&A session. If our audience have the questions, can you identify yourselves and ask the question to our speaker? And I would like to invite our speaker to come in on the stage to answer the question from the audience. Please.
So please have a seat. Professor, this is regarding thiamine supplementation in PPN patients. Thiamine supplementation in PPN patients. Professor, if we are giving empirically a thiamine supplementation, if my PPN does not come with a pre-added thiamine, what is the recommended dose to give? Do we have any recommended dose of thiamine B1 to be given when you're giving along with the PPN solutions?
What is the recommended dose of thiamine in patients who don't have pre-added thiamine in PPN?
You're asking the dose of thiamine?
Yes.
Usually, the recommended dose is 3 milligram per day in the parenteral nutrition. So, if you have any symptoms of deficiency, 3 milligram may be okay for maintaining the status. But if you have the deficiency, the symptom of deficiency, you might need a lot more. Is that
okay? Normally we get around 100 milligram.
I cannot hear you very well. Please, the microphone is not very.
No, I was just asking you about the dose of B1 which has to be used as a routine if you are giving along with the PPN. I think you said 3 milligram as an RTA. Normally we get in commercial preparations about 100 milligrams. So is there a harm in giving 100 milligram daily, which is the usual practice when they are giving empirically, or you stick to the RDA?
Yes, I can help in this answer, in this question, please.
Milligrams for thiamine is advisable for routine supplementation.
Okay, thank you for the translation. There is no, there is rare, if you give high doses, the side effects is very, very rare. The extrons go into the urine. So I think the 100 milligram, it's perfectly okay. I don't think there is any side effects. If you have the 100 milligram doses for commercial rare drugs. So at least 3 milligram, but higher is okay.
Thank you.
Good afternoon. Can I have my questions? Sorry for that. I cannot pronounce the names very well. Forgive me for this. For the first lecturer, honorable lecturers, the deficiency conditions and which can occur for the thiamine within 24 hours. We have stores of 30 milligram in our body, but the deficiency does not take that long, 18 to 20 days to occur. If we have a repeated vomiting, which usually very commonly seen after surgery, especially bariatric surgery, we can have thiamine deficiency within 24 hours. In time of deficiency, we give 100 to 200 milligram daily for 3 to 5 days as a supplementation, a replacement therapy. As the professor said, during parenteral nutrition, we give 3 to 6 milligrams per day. So I want to comment. This is my comment for the first lecture. The second lecture, I wonder, Yani, you have done a very great job about the enteral nutrition to reach anabolism in 4 days. You have made a miracle. In my practice, I'm Dr. Matar. I'm from Egypt. I'm the head of the digestion, and I'm the head of the ICU and nutrition unit. I have never reached an anabolism in 4 days. So I'm going to try your practice and reach the anabolism in 4 days. This is a miracle. And we are going to follow rules. As regards the literature, yeah, this is difficult to reach. So I congratulate you for your method. For the last speaker, sorry, your Selemin, you give Selemin peripherally. The osmolarity is 1,000 or more. 10% amino acids means 1,000 millimole, and this is not to be given peripherally. So one of the Utska can answer this question.
So, Selemin is actually recommended to be given by the peripheral route, not by the central route. It's a 10% solution, but it's not hyperosmotic.
I want to know the osmolarity.
I'm sorry?
I want to know the osmolarity of Selemin.
You want to know the
osmolarity.
The osmolarity.
How many osmoles?
That's a great question. I don't remember off the top of my head.
What is
870? So you can be given. Thank you very much.
Dr. Harshit, in your series, was the protein calorie target was also met in those patients, because you looked at the nutritional biomarkers. So in those small group of patients, you measured the pre and post 5-day infusion of the markers. Was these patients meeting the required protein calorie requirements also? Did your analysis include that?
So almost all of these patients were either not on any enteral nutrition or on minimal enteral nutrition. So we haven't actually quantified how much was the protein and energy intake via enteral route. They were not given parenteral nutrition. They were only given Selemin for those 5 days.
So despite may or may not reaching the protein energy target, still you had a beneficial effect on the nutritional
Yes, that's
parameters.
correct. That's correct.
That's an interesting thing to observe.
I just like to add comment to the hyperosmolar solution in a peripheral vein. It can be given up to 1000 milliosmol, but you have to change the IV line daily. So that is the principle to infuse up to 1000 millimole. I have a question for Dr. Michu. You said that the ICU, when we give the calories, if we underfed or overfed, the ICU mortality is in a U form. In your studies, you had given 40 kilocalorie. You use 40 kilocalorie per kilogram body weight. So, was there any complications like hyperglycemia and the infectious complications in your study?
You asked me about the ICU mortality of the after the operation.
Yeah, in those patients who were given more calories.
But I think that this is my actual results, and so we don't use the ICU after the surgery. And so I think in these studies, I have most no complications and no death at all.
That's fantastic.
So, excellent presentation. Sir, I have a query. Like in your patients, those who are post-operative in convalescence, you have given them nocturnal feeds. So, my question is that if a patient is not taking his breakfast, can we give a compensatory feed for that point of time? Like every meal, you give him a time within 2 to 3 hours. If he doesn't eat, can we give a bolus of 200 ml of feed followed by 2 hours and give him some time to eat? If he doesn't eat, another 200 ml. Is it ideal to do that or give away straight away continuous nocturnal feeds? What is your comment on this, sir?
Continuous infusion for interval versus giving bolus infusions.
I didn't do any of the bolus infusion after the surgery. I always used infusion pump and continuously. But I think that it is quite difficult to explain. But for the surgeon, after the operation, the paralysis of the intestine is happened every time. So it is quite difficult to bolus after the operations. So guidelines says always the same things. Say.
So I'm asking that when the patient is allowed to take a meal orally, so I think 200 ml is a small volume. What do you say, sir? When he's allowed to take a meal, which is 300 to 400 calories, let's say the breakfast, so 200 ml of volume or 100 ml should be a small volume.
I see.
So the whole day we starve the patient or he doesn't eat, and overnight we start feeding it. So I feel that compensatory feeds should be ideal than nocturnal.
Yes. And this is a bit 10 years ago studies. Nowadays, we have followed the ELAS protocols, and so we started the eating more earlier. So this is a little bit old or the previous experiment. So nowadays, it is quite difficult to do the same thing.
I just want to add to the ongoing debate about the nocturnal feeding. It is because we give like 1 kilocalorie per ml. So consuming up to 3000 calories would be very difficult during the daytime. So it makes a logic. You give 1 liter to 1.5 liter overnight, and the rest of the day patient can eat ad libitum. So that is the science behind giving the nocturnal feeding, which is very easy to use the pump and feed the patient, and rest of the day patient is free to eat whatever they like. So this is the answer to your question.
And if I may add, madam, these patients are at home. So basically, you don't want an attender or a patient to be tied down to the bed because you have to infuse, because we are not going to give them bolus feeds. So if you're going to give even 200 ml, the patient is going to be in the bed for another 2 hours. So 3 bolus feeds, 6 hours is tied down. Here is attender is tied down. So basically, if you can meet the target within 24 hours, the easiest way to do is start in the night. If you have difficulty in doing the night, sometimes we tell the patients have 2 meals. Start your feeds at around 5 o'clock in the evening, and then go until 12 o'clock, and then you have at least another 6-8 hours to sleep well. So giving a continuous feeds after you go over a period of time, if not overnight, starting it after 2 meals works better for the social reasons and for the patient to go about his daily life. than giving bolus which is not tolerated, or giving intermittent infusions for 2 hours. It's really practically challenging to do that, especially when you're at home and not in the hospital when somebody else is doing the feeding. So if there are no other questions, we would like to wind up the session. We thank all our speakers for the excellent lectures, and thank you for the patient listening. Thank you.
ايوه.
Good afternoon, everyone. So after a good evening tea and refreshed, awakened from our sleep, so now we will see nutrition in gut health, nutrition in liver, pancreas, and GI diseases. So in this session, the chairperson, Dr. Dharmesh Kapoor, consultant hepatologist, Yashoda Hospital, Secunderabad. He has authored many nutritional guidelines on the management of chronic diseases, hepatitis B, chronic hepatitis C, nutrition in chronic liver disease, and management of acute liver failure. Published over 50 articles in peer-reviewed national and international journals, and has written more than 15 book chapters. And his areas of interest: liver intensive care and transplant surgery. And the co-chair, Dr. Sanjit Sesidaran, head critical care, one of the organizers of the Pensa conference. He is from Raheja Hospital, Fortis, Associate Mumbai, and his achievements include many peer-reviewed articles, 10 textbook chapters, and 2 textbook chapters, single authored, and Gold Award for a software in critical care nutrition. And he has organized a nutrition boot camp in 2016 to 22. And his areas of interest include critical care, hemodynamics, and critical care. So, Sanjeet sir will take over the session.
Thank you very much. And the next speaker is all the way from Auckland, Professor Gilhari. And he needs no introduction. He's been serving on the Aspen board for a long time, and was a founder and actually the first chair of the International Clinical Nutrition section. So, Professor Gilhari, please, stage is all yours.
How do I? Oh, we're all good. Well, good afternoon, everyone. And once again, I would like to thank Dr. Reddy and the organizing committee for the invitation to join you in this incredibly interesting conference. And I'm happy to be back in Hyderabad. This afternoon, I'm going to tell you a few of the research projects that we've been involved in New Zealand, mostly my colleagues, but it's an area that probably we all learned about, as I did in our studies, college studies, and then perhaps forgotten about. So the subject of my talk, Keim bile reinfusion therapy, advantages compared to parenteral nutrition. Here are my disclosures, some of which have been already described. And I want to just briefly remind ourselves about the indications for nutrition therapy in intestinal failure. What is Keim and Keim reinfusion therapy? Describe the indications and some clinical experiences in Australia, New Zealand, and Europe. Then this novel system that's been developed by biomedical engineers in New Zealand, talk a little bit about drug metabolism in intestinal failure, and then summarize. So this slide with these four mannequins is something I've used over many years to show the different spectrum of gut failure, from the complete in the far left, requiring parenteral nutrition, and normal gut function on the right, where, as we all have been hearing today, if the gut works, we must use it. So those are the basic principles for enteral and parenteral nutrition. Most of my career I've spent with many others trying to improve the safety of parenteral nutrition. These potential complications we will all have learned in the three categories of metabolic, mechanical related to venous access, and infections. And by and large, we've been successful in minimizing these potential complications, providing the therapy is managed by a good multidisciplinary team, then most are preventable. Nevertheless, they do exist, and if we can overcome them and move patients more quickly to enteral nutrition, this is the objective. So for Keim reinfusion, I've added a fifth mannequin with a degree of gut failure and a small stoma bag, shown a little more prominently in my friend Sally here on the right. So I pose a hypothesis that Keim reinfusion therapy could be a third option for many patients requiring nutrition support. Some definitions that most of you won't need me to go through. The enterostomy, the double enterostomy, a temporary procedure before reconnecting after a surgical resection, an enteroatmospheric fistula, EAF, where the small bowel is completely open, and these enterocutaneous fistulae, which are common causes of intestinal failure requiring parenteral nutrition and often prolonged hospitalization. The causes, these enterocutaneous fistula, create fluid losses, external losses, in the table on the right that I won't go into. And then a description of Keim. It's a mixture of saliva, gastric juice, biliopancreatic, duodenal, and intestinal secretions, whereby food, as I'm sure you know, is converted into absorbable nutrients by biosalts and enzymatic digestion. Normally, the average human will have 2 to 3 liters of gastric secretions, around 1 liter of bile, 1 liter of pancreatic fluid. And what's incredibly important is if these GI secretions do not reach the small intestine, then this can lead to malnutrition, dehydration, acid-base imbalance, and electrolyte disturbance. And this is the basis for Keim reinfusion therapy, which establishes an extracorporeal circulation of the chyme between the stoma bag, where the chyme is collected, and the downstream small intestine. This next slide is a classical slide from an intestinal failure textbook that makes me very excited, because you can see the table on the left of the saliva, gastric, pancreatic juices and bile, but most importantly is to remember what many of us have forgotten, I think, that this is a real treasure trove of nutritional substrates, wonderful enzymes and other factors that are involved in metabolism of oligosaccharides, carbohydrates, medium chain triglycerides, the medium chain fatty acids, the production of aromatic amino acids, arginine, branched chain amino acids, conversion of dipeptides to amino acids such as glutamine. And I confess that in my concentrating on parenteral nutrition over the years, I've tended to forget these wonderful nutritional secretions that many hospitals continue to throw away. So reinfusion of GAI secretions should be beneficial, but there have been widespread barriers to its use. And this was changed by my colleague, Professor Ian Bissett in Auckland, who spent about 10 years working in Nepal. And he had several disasters, such as the one I've shown on the left, surgical disasters and infection, but he had no access to any parenteral nutrition at his time in Nepal, and very little enteral nutrition. So he developed this triple stoma technique, fairly complicated, that enabled reinfusion of chyme, and it saved many patients. When he came back to Auckland, he got the rest of us all involved, and he defined these basic requirements for CRT. That's the patient with a small bowel stoma, fistula, requiring IV fluids, parenteral nutrition and energy, a distal small bowel out of circuit, access to a distal limb, and the distal bowel must be integrity without obstruction. So CRT, we believe, can be an alternative to PN, especially for type 2 intestinal failure patients, as described in the box on the left in the current ESPEN guidelines. So essentially, the indications would be management of high output DES with an output greater than 1 litre, management of high output enteroatmospheric fistulae, rehabilitation of the distal intestine before consideration of reversal, and then after testing fecal continence before consideration of surgical reversal. There are some guidelines, but essentially, like many of us, it's largely been ignored or forgotten. In the Aspen Phalampic guidelines a few years ago, it's almost forgotten about in the sentence down at the bottom that fistulolysis, which actually involves just enteral infusion of enteral nutrition and or chyme. The UK Baypen Biffa top tips are a little bit more forthcoming. You note that chyme theoretically may be more beneficial than an enteral feed. It can be technically difficult and time consuming. So why is this? And when after all, the main objective is to use the small intestine wherever possible to feed both the gut mucosa and the patient and to minimize use of parenteral nutrition. There are some contraindications. If the bile loss is less than 500 ml per day, if there's no malabsorption or electrolyte imbalance, it may be difficult in critical care and palliative care, but not impossible. But it's also important for the nursing colleagues and patients to be able to manage the procedure in their discharge plan. It can be uncomfortable, as we'll see, bile collection, decanting, and administration. Many intestinal failure centers tried it in the past, but that's one drawback, and it just requires much training and home support when the patient is sent home. So disgust in the smell and the procedure is very unpleasant and may limit its use in the past. There have been attempts in the UK in 1990, later in France and South Africa, United States to automate chyme reinfusion, but it always involved complicated machines and infusion technology. The various ways of doing this have been summarized by Amy Berry in this rather busy table, but essentially they can be done by bolus or by gravity, with some of the drawbacks highlighted in this slide. Pump infusion, when you combine reinfusing enteral nutrition with the chyme reinfusion, are also possible, but it generally requires two expensive pumps, connecting tubing and so forth. And as Amy notes, there can be troubles manipulating the tubes, transferring and filtering the chyme sometimes with a kitchen strainer, or as shown in one of those pictures, with a nylon stocking. And this is where the engineers in New Zealand came to our aid. And just before I go on, just want to remind you where New Zealand is in the world, sitting at the top of our globe. And this device is a small pump that attaches to the feeding tube that's inserted into the stoma with an external driver. The tube is placed by the surgeon or the stoma nurse, and then connected, a standard stoma bag is connected. And this, on the right, you can see just a very short video showing how the chyme, when about 200 ml has been collected in the bag, can be reinfused. So we regarded this as a really big step forward. It's a completely closed system. My colleagues carried out a feasibility study a couple of years ago with 10 patients, over 740 patient stays. And they were about 8 out of 10 were high output losses, and half of them were receiving parenteral nutrition. They checked the microbiology of the system and showed that there was no contamination during the procedure. And the results summarized here are that 4 out of 5 patients were able to wean off parenteral nutrition. 6 out of 10 patients successfully discharged home with rapid recovery and weight gain. And what's, I think, extremely important is there was a significant improvement in the liver enzymes. And these are shown here, showing the top left, the reduction in the use of parenteral nutrition, a couple of the liver enzymes that I'll come back to, and in the bottom right, the steady increase in weight for those patients receiving the chyme reinfusion. Now, we can't take full credit for this in New Zealand. The technology, yes, but Professor Levy in France back in the 1970s and 80s was pioneering this therapy, and not many papers were published in the English language, but this shows that 92 out of his over 300 high output fistulae patients received successfully chyme reinfusion. And the conclusion from this paper was that chyme reinfusion therapy maintains nutritional status, improves liver function with complete or drastic reduction in parenteral nutrition. I just run through now some other advantages of chyme reinfusion. And again, this goes back to the early work of Professor Levy and colleagues, who showed a significant reduction in fluid loss. As you can see in the graph on the left, as soon as chyme reinfusion started, there was a 33% drop in output and in fluid losses. We saw a similar trend in the feasibility study that my colleagues carried out in Auckland, and more recently in a study by Professor Picot and colleagues in France. You can see that the pre-chyme output of fluid was 2.4 litres, and after chyme reinfusion therapy, it dropped to 400 ml. Secondly, weaning from parenteral nutrition, which is a costly and can be difficult exercise. One of the first groups to show this was in Cape Town in South Africa, where all their atmospheric patients were weaned from PN with an average of about 7.5 days. Another retrospective prospective study from Professor Pico and colleagues of over 300 patients showed that 200 of those were receiving intravenous solutions, 77% PN, 23% enteral. And this slide here is one of many of their data, and I highlight this one where the brown bar shows the parenteral nutrition use before chyme reinfusion, and not much lower down the smaller orange bar, the parenteral nutrition use after chyme reinfusion. So 89% were weaned off intravenous supplementation after 2 days, and the other 11% required only reduced volumes of intravenous solutions. So that means we can look at early return to oral feeding, which is difficult, as many of you will know, in these intestinal failure patients. But two studies, the PICO one that I've just described with an 89% return to oral feeding, and there's also a very nice Indian study from 2020 showing a 63% early return to oral feeding. Improved nutritional status, which is also one thing we're looking at. This needs further research to look at some other more sophisticated nutritional markers, but essentially weight gain always occurs after and during and after chyme reinfusion therapy, increases in albumin and increased citrulline, which is a marker for intestinal function. Post-operative complications, we've heard something about this earlier today. This is a recent Chinese study looking retrospectively at over 150 patients, some of which received chyme reinfusion therapy and others didn't. And you can see that the post-operative complications were down to about 30% in the chyme group as opposed to 48% in the non-chyme group. And there's this improvement in liver function, which to my mind is one of the greatest advantages. And this again is data from Pico and colleagues published in Clinical Nutrition 2017, where over 200 of his patients that had liver function test double norm, as soon as they began chyme reinfusion, you can see the dramatic drop by less than half during the period of chyme reinfusion therapy. And this we found in our smaller feasibility study that I showed earlier. You can see how the GGT and the alkaline phosphatase dropped dramatically as soon as the chyme reinfusion therapy starts. And the last advantage that Professor Bissett, based on his experiences in Nepal, is really very passionate about, reminding us that 5 billion people globally don't have access to safe surgery, and many do not have access to parenteral nutrition. And so he believes that chyme reinfusion therapy is one way to address this problem. I'm not going to spend very much time talking about metabolism of drugs in intestinal failure. I was asked to concentrate on that in my talk a few days ago at the UK BAPIN session. But if you're interested, there's a very nice webinar on the BPNG website that you can refer to. And one of our experts and speakers on this webinar, Dr. Raj Banham, kindly allowed me to show just one or two of his slides. I'm sure those of you that have looked at drug pharmacokinetics are familiar with this classical graph that can tell us about absorption, distribution, metabolism, and excretion of a drug, depending on which part of the curve you look at. And then the orange shaded area would tell us about metabolism and bioavailability. Normally, most drugs given orally are non-lipophilic, and they have a normal distribution curve. But if we have a resection, produce a short bowel, for example, then the drug absorption is usually much reduced, and you see a curve that's much more flattened, and that will affect the absorption, the distribution, and the metabolism of the drugs. So I've applied this this science of pharmacokinetic data to some typical drugs, taking them from the ESPEN guidelines. Antibiotics, of course, are used quite commonly, metronidazole, for example, and that's absorbed mostly in the small intestine. So after resection, it has intestinal failure has no real effect on the pharmacokinetics. In contrast, gentamicin has poor oral availability, and so in a patient that's had a resection, it can affect the subtherapeutic levels, and the dose might need to be adjusted from that normally recommended. Similarly, for H2 receptor antagonists and PPI, such as cimetidine, also used, and ranitidine, this wasn't looked at by this paper, but cimetidine, they conclude, has reduced bioavailability in intestinal failure. So again, the dose may need to be increased in intestinal failure. The antidiarrheal medications, mostly loperamide, sometimes opiates, are used almost routinely in many of these patients, but it's important to realize that they may inhibit pancreatic and biliary secretions, and they then can impair macro and micronutrient absorption. And it's as well to remember that the evidence for their use is largely based on studies in normal intestinal function, not intestinal failure or short bowel. We found, and the French and other users of Kymry infusion have found, that CRT can significantly reduce the use of these medications. They're not expensive, but it's still significant. So to summarize this in terms of drugs taken from the ESPEN guidelines and from Dr. Badam's lecture, pharmacotherapy is difficult in intestinal failure, and it's important that these drugs should be prescribed on an individual basis to all intestinal failure patients. We may need to look at other parenteral, transdermal, buccal, and suppositories and alternatives. But however we decide to proceed, we must remember that drug absorption from the GI tract may be considerably impaired in chronic intestinal failure. So to optimize our drug use, we must be aware of the gastrointestinal anatomy of the patient, the absorptive capacity of the remnant bowel, and the pharmacokinetics. And of course, we need to check our stoma bag for any undissolved tablets. If they're not being absorbed properly, then they pass through, and we need to look at the implications of unused drugs. But overall, the recommendation is that medication monitoring by the pharmacist is essential. So as I draw to a close then, I'd like to summarize the experiences with Kymry infusion therapy to date. It's well tolerated, very few adverse reactions reported so far. 85% experience rapid GI recovery, and PN weaning, as we found in Australia, New Zealand, France, now the UK are using it quite a lot. PN weaning can be achieved in almost 90% of cases, and corresponding to that, more than 60% will show improvements in electrolytes and liver function tests. The majority have improved IFALD. Weight gain is quite notable, up to 6 kilograms when on just CRT alone. And this can enable early discharge from home so that the patient can manage this quite simple technique with support from the local stoma and nutrition teams. And then lastly, as we demonstrated, the use of the antidiarrheal medications, parenteral nutrition, and hydration solutions can be much reduced as CRT progresses. So my last couple of slides, we've attempted to make an economic analysis of the use of CRT, as shown in this table here. So here my colleagues and I, we looked at the standard of care, which is parenteral nutrition. We looked at line infections as potential complications and the use of the main medications. And you can see that the reductions with QIAM reinfusion therapy are about 10% in terms of the costs that are here in British pounds or New Zealand dollars. So from 38,000 without QIAM reinfusion to about 4,000 with QIAM reinfusion. Similar 10% or thereabouts reduction in the use of loperamide and codeine phosphate, with an overall saving approaching 40,000 British pounds per patient. So in summary then, first of all, you need to educate your colorectal surgeons. Normally they want to get in quickly, do the surgery, and maybe just tie off one end and bring the other end out. If they can be persuaded, it's not very difficult to bring, although I'm not a surgeon, to bring out both ends. That makes it more accessible. And overall, it's important to have the therapy managed by a nutrition therapy team. And that way, early into nutrition can be managed. It can provide optimum nutrition, hydration, electrolyte balance, and improve nutrient absorption. Successful CRT can minimize or avoid the use of PN via a central line. The drug savings can be diverted elsewhere, but the multidisciplinary team is important. So as I've concluded, CRT reduces stoma fistula losses, reduces PN requirements, lowers liver function tests, improves hospital stay and costs. Nutritional outcomes are improved, oral intake can be started more quickly. And that leads me to a picture of one of my, when I was a much earlier researcher, had the privilege of working with Professor Hans Krebs, he of the Krebs cycle, in his metabolic lab in Oxford. And he always used to tell us students, the principle which serves as a keynote is when we're forced to do something artificial, such as feeding, we must aim at remaining as close as possible to the natural physiological situation. Of course, Professor Krebs not only invented the Krebs cycle, if inventing is the right word, before that he devised the urea acid cycle, so he's actually responsible for 2 cycles, or a bicycle, as shown in this picture here. So I leave you with the thought that QIAM reinfusion therapy can improve outcomes, especially in type 2 intestinal failure, as a more physiological therapy. Thank you for your attention.
Thank you so much, Professor Gill. I think we'll probably have the questions at the end of all the talks. Can I now have invite Professor Adarsh Chaudhary? It's actually an honor for me to invite him onto the stage. He's been a teacher to me in my alma mater, which is GB Pant Hospital in New Delhi. And he's currently the chairman of Department of GI Surgery at the Medanta Hospital, Medanta the Medicity in Gurugram, New Delhi. He's going to be speaking on nutrition in patients with pre and post pancreatic surgery. Dr. Adarsh Chaudhary.
My talk will cover three issues in pancreatic disease where surgery is commonly needed: acute pancreatitis, chronic pancreatitis, and pancreatic cancer. Fortunately, majority of patients of acute pancreatitis have a mild disease. Only about 20% patients have severe acute pancreatitis. And of these 20% who have severe acute pancreatitis, 60 to 75% of them will die. The disease in them is very severe. Patients who have mild to moderate pancreatitis do not need any nutritional support, nor do they need surgery. Once the pain resolves, they can be started on oral feeding and can be discharged home. But patients like this who have severe acute pancreatitis, as you can see that there is gas in the pancreas. Patients who have severe infection, they are the ones in whom some sort of intervention is needed these days. These patients are managed endoscopically or by radiological drainage, and sometimes these patients might need surgery. And in these patients, the disease process is very catabolic. Many of them, the cause of pancreatitis is alcohol. So they have pre-existing malnutrition. So three questions need to be answered. Which patients need nutritional support? Which route will nutritional support be given? And if nutritional support is given, do we need to give some special formulas or normal feeding can be given? Today it's established that in patients who have severe acute pancreatitis, all of them need nutritional support. And contrary to popular belief in the past, that if you feed these patients, the pancreas gets stimulated and it can worsen pancreatitis. The concept of pancreatic rest was there. Now we know it's all theoretical. Oral feeding, if tolerated, does not worsen pancreatitis. Unless the patient has got gastroparesis, in majority of patients, the oral feeding is well tolerated. And apart from giving nutritional support, giving calories and proteins, one of the advantages of giving oral feeding is that it keeps the bacterial translocation from the colon less, because once the colon is without feeding, the permeability increases and the bacteria proliferate. So to prevent that, oral feeding helps, and there is evidence that oral feeding started early decreases the incidence of pancreatic necrosis and possibly also decreases mortality. There is no need to give any special diet to these patients. Usual diet is good enough unless the cause of pancreatitis is hyperparathyroidism or hypertriglyceridemia. In those cases, we have to modify the oral diet. Often the question asked is that a patient gets admitted, when should we start feeding? If the patient is hemodynamically stable or on a low dose of vasopressors, there is evidence that on-demand feeding is safe. Whenever the patient can take orally, we should start feeding as early as possible. If patient cannot take some degree of oral feeding till about second or third post-operative day, it makes some sense to pass a nasogastric or a nasojejunal tube. And once we start tube feeding, it is believed that continuous feeding is better tolerated than intermittent feeding. Patients who have intermittent feeding may get abdominal distension. They have a higher chance of developing osmotic diarrhea. So a continuous feeding by a tube inserted might make sense. In the past, we used to believe that whenever enteral nutrition is given, it should be given post-pyloric because we do not want to stimulate the pancreas. Now there are many studies which have shown that nasogastric feeding is as safe, as effective, as durable as nasojejunal feeding is. So feeding by a normally placed Weil's tube may be as good, but the only difficulty many times is that these patients have gastroparesis, high gastric aspirate. In those situations, nasogastric feeding may not be feasible, but it is not a dangerous proposition to give nasogastric feeding as and when possible. Should we give parenteral nutrition to these patients who have severe acute pancreatitis? Earlier trials showed that once we give parenteral nutrition, the incidence of Septic complications was very high, but if you see those papers carefully, the number of calories given to those patients was very high. But today, parenteral nutrition is rarely indicated, only when enteral nutrition cannot be given or not tolerated, or it's inadequate to maintain the targets. Only then supplemental parenteral nutrition can be added to enteral nutrition. There has been some discussion that is there any role of glutamine in these patients? Some studies have suggested that intravenous glutamine can decrease the ICU stay, possibly earlier weaning from ventilator. The data about oral glutamine is not good. Same way data about probiotics, omega-3 fatty acids, antioxidants to decrease permeability of the gut. Though theoretically they sound good, but they have not shown any conclusive benefit in real clinical studies. Coming up to chronic pancreatitis, patients who have chronic pancreatitis are usually malnourished. This essentially happens because majority of them, the cause of chronic pancreatitis is alcohol. Majority of them are smokers because the hallmark of chronic pancreatitis is deterioration of pancreatic function. So they have exocrine and endocrine insufficiency, and they also have delayed gastric emptying. It's a catabolic disease, so these patients are malnourished. And maintaining nutritional support in these patients is very difficult because unless we relieve the pain in these patients, they cannot eat. So surgical procedures are indicated to relieve pain, and only then their nutrition can be improved. One of the essential prerequisites of any nutritional support in chronic pancreatitis is to supplement them with pancreatic enzymes because they have exocrine dysfunction. Even if you feed them but don't give pancreatic enzymes, the absorption is severely affected. So the pancreatic enzyme replacement therapy is absolutely integral to patients of chronic pancreatitis, even if they undergo surgery, because all the more when they undergo surgery, there is loss of pancreatic substance. So enzymes must be prescribed to all patients of chronic pancreatitis. Occasionally, you need to give parenteral nutrition to patients of chronic pancreatitis. The indication may be presence of duodenal stenosis because sometimes there are juxtapancreatic problems, and sometimes there are complex fistulae like chronic pancreatitis can cause pancreatic ascites, it can cause pancreatic pleural fistulae. In those conditions, occasionally parenteral nutrition might be indicated. In patients who have pancreatic cancer and undergo pancreatic surgery, nutritional support assumes great importance because pancreatic cancer is a very nutritionally debilitating disease. These patients have anorexia, they have severe pain. In many of them, there's diabetes out of control, so they are malnourished. If you do studies, screening tests, nearly 70 to 90% of these patients are malnourished. So, a preoperative nutritional assessment, there's no single test which has been validated to be superior. And do these patients need preoperative nutritional support? Because, like I said, they are malnourished. Should we add a feeding jejunostomy during surgery to facilitate post-operative feeding? And what do we do post-operatively are topics to be discussed. Many patients who come to us, we don't have much time to give them nutritional support because if we want to make any meaningful improvement in their nutritional status, we need at least 6 to 8 weeks of nutritional support. And in a patient of cancer, it is ethically not justified to wait so long. The only time when we wait so long is patients who go for preoperative chemotherapy and radiotherapy. In these patients, we give nutritional support. Otherwise, nutritional support cannot be given because once the patient presents within the next 2, 3, 4 days, within a week, these patients have to be operated. There is some data appearing in literature today that prehabilitation benefits outcomes, but what duration of prehabilitation, what diet to give, what exercises to prescribe, how often, which patients, this is still not standardized, but there is some suggestive evidence that preoperative exercise and nutritional support can help these patients. When we do a pancreatic duodenectomy and these patients are malnourished, so they can have complications later on. Should we have a tube jejunostomy for feeding during surgery so that immediately after surgery we can start feeding these patients. Data suggests that routine jejunostomy is not indicated, may actually cause complications. Only patients who are presenting with vomiting or their albumin is so low during surgery, you think this anastomosis is going to leak, or if you do an emergency procedure or you re-explore, only then a feeding jejunostomy tube is placed to give an access for enteral feeding post-operatively. But in most high-volume centers today, routine feeding jejunostomy for enteral feeding post-operatively is not recommended. There is no role of routine nutritional support post-operatively because recent guidelines suggest that most patients we start feeding on first post-op day, and majority of patients who are uncomplicated will be on near normal diet by day 3 to 5. So it makes no sense to give post-operative nutritional support. Post-operative nutritional support is only indicated if you have a complication like an anastomotic leak or you have delayed gastric emptying, then these patients will need supplementary nutritional support. Unfortunately, majority of patients of pancreatic cancer by the time they come to us are unresectable. The disease is advanced. Only about 15 to 25% patients are resectable. So when you talk of pancreatic cancer, the bulk of disease is unresectable. Till about 5 to 7 years back, we used to say that it is not ethical to give these patients nutritional support. We are wasting our resources on giving these patients any additional nutrition. Now there is some evidence that at least enteral nutrition in the form of any enteral nutrition oral supplements improve the quality of life, improve the patient's performance status. And there's a study from Holland which suggests that when you add this oral feeding with pancreatic enzyme replacement therapy, possibly the survival in these patients is also improved. So this is my last slide. So most controversies about acute pancreatitis and nutrition have been settled. In chronic pancreatitis, patients are malnourished. Unless you relieve pain, nutritional improvement cannot be done. And in patients who have pancreatic cancer, nutritional support has no great value. It's a disease which has poor outcome, and nutritional support really does not make much difference to the long-term or short-term outcomes in pancreatic cancer. Thank you very much.
Thank you, sir, for a very lucid presentation. Could you please join us at the desk? The next speaker is going to be Dr. Roop Jyoti Talukdar. He is a dear colleague from our city. He works at the AIG Hospitals, Hyderabad, and he is going to be speaking on nutrition, gut microbiome, and pancreatitis. Dr. Roop Jyoti Talukdar.
Thank you, sir, for that kind introduction. And so I'd like to thank the Pensa team and Dr. Radha for this kind invitation. So I'm not a dietitian, so I'll not give you any recipes of what to prescribe that you know better than me. So what I'm going to do is to give you a clinical perspective of these diseases. And I think it's more of the complementarity between the clinician and the dietitian that would give the best possible results for patients. Is coming. Can you put on the slides? Yeah, is there. And the other thing is, I think Dr. Adarsh Chaudhary has done 80% of my job. So I'll just take you through a revision class kind of sitting. So let us see what is. It doesn't work anyway. No, this one. Like button. No, I need the pointer. Yeah, the pointer is this. This is like it's worse. Yeah. Okay. Yeah. So so acute. Let us see what happens. The natural history of acute pancreatitis. It begins in the acinar cell here, and after the acinar injury, what happens? The patient majority will come with systemic inflammatory response, but majority of them will resolve in the first few days, and that's why we call that they are having a mild disease and they go home in 7 days. But what happens in 15 to 20% of these patients? They will go on to develop pancreatic necrosis, and a proportion of those patients will proceed to development of infected necrosis from the second week and beyond. So the most important time in which this early management of this disease will make a difference in the long-term outcome is the first 1 or 2 weeks. And that is when, with all medical management, even nutrition plays an important role. And again, Dr. Adarsh Chaudhary has already told about necrosis. So this is what you would see in a patient. So this is what the patients with mild acute pancreatitis would have. Majority of them would have mild, 80%, and these are the patients with different type of collections. And this is the natural history of the collection. So this is like pancreatic parenchymal necrosis, and gradually a wall is formed here, and then there will be a definite wall formation around the necrotic collection. And based on the morphology of the disease and what is going on inside, is there an infected necrosis or is there gross involvement of the peripancreatic and periintestinal fat, that will determine the uh, outcome of the patient and the nutritional status. Now, what happens is, this is a knee-jerk reaction, and I must tell you, in acute and chronic pancreatitis, there are lots of knee-jerk responses from the healthcare giver team. The first three knee-jerk reaction is you should not allow any food to this patient. And the problem of not allowing any food to this patient is this patient, if we keep them for prolonged NBM, there will be alteration of the gut barrier permeability, there will be gut bacterial dysbiosis, and that would lead to bacterial translocation and toxemia, and this is what would finally cause infected necrosis. So if you're keeping a patient on prolonged fasting, they are more highly prone to develop infected necrosis, sepsis. And of course, when there is bacterial translocation, there will be endotoxemia that again causes secondary organ failure in these patients. And this again, the other problem is because of the prolonged NBM, and again there is a common habit of giving PPIs in these patients. Even guidelines say not to give PPIs, but that's a common habit all of us have. And once you give high doses of PPI in the ICU or HDU setting, the low acid in the stomach will uh, attract bacterial gastric colonization of the bacteria, and they can lead to regurgitation, pneumonia, sepsis. So that is why the old concept of keeping the bowel at rest or nil by Martin, which is still a knee-jerk reaction in many of us, should not be practiced. So the rationale for early feeding is to stop avoiding the bowel rest. The bowel should be moved. We have to maintain the gut barrier permeability and then provide adequate nutrition and the calorie. So there are studies like the benefits of early versus delayed feeding. If you see here, with delayed feeding, there was higher rates of necrotizing pancreatitis to the tune of twofolds, higher rate of infected peripancreatic necrosis, higher risk of intervention for necrosis, and of course a very high rate of development of multi-organ failure. And the beauty and the importance of this early feeding was shown by this Dutch group in a recent study called the Python trial. So here what they did was they divided the patients into two groups. In the early group, they treated the patient with nasoenteric feeding tube initiated within 24 hours and after randomization, or oral diet starting at 72 hours earlier or earlier if the patient demanded. That was the on-demand group. And what they saw in the results was there was no significant difference between the early and on-demand group. And the rate of major infection was similar, and there was no difference in the death. So, and in the on-demand group, 72 patients had tolerated an oral diet and did not require tube feeding. So, based on this, the current guidelines recommends the AGA and ACG. So, me being a gastroenterologist, I go by these guidelines, but still, I think the Aspen guidelines also speaks about a similar thing. There is strong recommendation for the enteral route preferred over parenteral. Again, Dr. Adarsh has already said, like the risk of parenteral nutrition, more infection, more adverse outcomes. The preferred choice of feeding is low fat solid diet as tolerated. This can be a little controversial. Some people say any kind of fat and any kind of diet can be given, especially for the patients with mild acute pancreatitis. And this is again a strong recommendation by the ACG guideline. And again, NJ has a similar efficacy and similar safety profile. And that again is strong recommendation from both the guidelines. To summarize the nutrition in acute pancreatitis, the patient has a mild disease. The patient can be initiated with a low fat solid diet as soon as the patient can tolerate. It's okay even if it started on day one. That won't harm the patient. If the patient has moderately severe or predicted severe disease, a low fat diet should be initiated within 24 to 48 hours. That's very important. And it's not essential that we have to wait for the bowel sounds to come, because by giving something into the intestine will initiate the bowel sound. And at this stage, in the early stage, is not about only giving the calories, because in the first 72 hours, 48 hours, because of the hypercatabolic response, because of the stress response, calories will be maintained. So we don't have to really give them high calories during that part. But the most important goal is to keep the gut moving. So even if you start giving the patient sips of water as early as possible, that's good enough, because the gut will keep on moving, and that will lead to reduction in the gut barrier permeability and bacterial translocation. If the patient is intolerant to oral feed by 72 to 96 hours, it's very important to start enteral feeding by NJ or NG as per the patient's tolerance. Now, what happened? Let's bring in the gut microbiome, because that was a part of my talk. So let's see what happens to the microbiota in this disease. So I had already alluded that there is bacterial translocation, and now there are several studies that have shown there is dysbiosis of the intestinal microbiome in acute pancreatitis, both clinical and experimental work. And the summary of all these results, all these studies show that there is altered gut barrier permeability, dysbiosis towards harmful and unhealthy ecology. And there has been several studies that showed a strong positive correlation with the dysbiosis with several pro-inflammatory cytokines, and also with the pro-adverse outcomes. Now, again, another issue in routine clinical practice, guidelines have been showing, telling us from last 20 years, 15 years, that prophylactic antibiotic do not have a role, it should not be used. But the sad reality in the real life practice is all over the world, a significantly high proportion of patients get prophylactic antibiotic, whereas the meta-analysis and the double-blinded placebo-controlled RCTs have shown that there is no benefit. One side, there is no benefit, but can it cause harm? So if we see this, this is a study that we in our institute had done. My postdoc and GI fellow had done this. What we did was, many of these patients, despite getting antibiotic, do not fare well. They develop infected necrosis. They end up in the surgery or with this endoscopic treatment. So if they're getting antibiotics, why this should happen? So that's why we started thinking, is something else going on within the pancreatic necrotic collection? And we looked at the fungus, the patients who underwent ductal or drainage of the necrotic collection. We subjected to the the fluid that was aspirated to culture to sequencing of the ITS region of the fungal genome. So that was a next generation sequencing, and what we could see was, in this collection there was a host of fungal species growing, fungal genera growing, and these are all unculturable. If we do culture, either we do not get anything or we get just candida. So if you see, the majority of the phylum was aspergillus. And then we also looked at the intestinal fungome by doing this ITS culture in the stool samples, the DNA isolated from stool samples. And here also there was a significantly high abundance of the species Aspergillus penicilloides. So what is happening here? So here we started looking at the gut barrier permeability, and in the patients who had acute pancreatitis, there was a significant reduction in permeability. So this is what is happening here. So there will be initial dysbiosis of the fungi within the intestine. Because of the gut barrier alteration, it will translocate to blood, and finally it will colonize in the WM fluid. So by giving antibiotics, we are not only not giving them any benefit, but probably also harming them. So and this will eventually translate to deterioration in their nutritional status. So this is very important to realize that those knee-jerk reaction, whenever we see a high TLC, total count, in the first week, that is systemic inflammation. That has nothing to do with infection. And once we start the antibiotics earlier, we don't know when to stop, and that is the problem. And that could probably lead to this kind of situation. So in acute pancreatitis, it's essential to start feeding as early as possible as per the patient's tolerance and demand to take food, prevent antibiotics because it doesn't only prophylactic antibiotic because it doesn't not only has no benefit but it may also cause harm. So now let's switch over to chronic pancreatitis. Again, let's begin with the natural history. So this is a disease with debilitating pain, recurrent intractable pain, malnutrition, and type 3C or pancreatogenic diabetes. So if we see here, this is how the disease progresses. We can arbitrarily divide into three stages: early, intermediate, late, but those are overlapping stages. Those are not watertight compartments. So the disease would begin as recurrent acute pancreatitis. It's called the sentinel acute pancreatitis event or the SAPE hypothesis. As the disease progresses, because of stellate cell activation, there will be significant fibrosis which is progressive and irreversible. And as the fibrosis progresses, the acute attack or the severity of the acute episodes come down and the type of pain starts changing. It may become more of a neuropathic pain rather than a nociception or inflammatory pain. And this is how the morphology of the disease would look like: a normal looking pancreas, normal pancreas. And if you see here, as the disease is full blown, you will see pancreatic ductal dilatation. There will be different types of stone within the duct and outside the duct. And this is an example, and this is the histology, which shows gross fibrosis of the parenchymal tissue. But then, interestingly, some of the islets are still there. So that is something we can discuss later on what this islets mean. And this is one of the blown up images of this of a patient who has a grossly dilated duct and obstructive ductal stone here. So let me tell you about this story of this young child. So she came to my outpatient clinic in 2012. And if you see here, I mean, she has come from her school because of his recurrent abdominal pain, which she keeps on having off and on, goes to the emergency room. And this time she happened to come to our hospital. 9 years old, non-diabetic, recurrent pain, growth failure. She was diagnosed of pancreatitis in 2010, but she was having symptoms for even 2 years before. BMI, yeah, I know BMI is not the best way to measure nutritional status in a child, but that was what was available at that time. And biochemically, her pre-albumin was pretty low, vitamin D was low, vitamin B12 was on the lower side. Morphologically, on a CT scan, which she brought with her, what we saw was there was gross pancreatic atrophy with calcification. Pancreatic duct was 6 millimeter. And what was she getting? She was getting pancreatic enzyme, 10,000 units just after meals, and she was on a fat-restricted diet. So again, the first thing that anyone would do in this kind of a patient, besides treating the pain, is to treat with pancreatic enzyme because this disease is characterized by pancreatic exocrine insufficiency because of the atrophy of pancreas, and that is one of the first thing that anyone would do: start pancreatic enzyme replacement therapy. So the goal is to correct the pancreatic exocrine insufficiency and improve the nutrition. But how effective is PERT? So there are several preparations in the market, and we often pick up anyone based on the patient's economic status. But if we look critically at the evidence, so this was a meta-analysis published by Iglesia Garcia from Spain. So where they studied 17 studies, over 1,000 patients altogether, over 511 patients with prospective randomized studies. Different kind of preparations were tried: PERT versus PERT, PERT versus placebo, crossover trials, different groups. But the problem here, if you see, hardly a few study actually had a proper sample size calculation. If we do a randomized control trial, the first thing is to have an adequate power. And adequate power means we need to have the right kind of sample. But most of the studies did not have sample size calculation. And all these studies actually gave patients 100 gram of dietary fat as the intervention, which is not a real life scenario. No one takes 100 gram of fat per day in real life. The duration of PERT was very short, 7 to 14 days. Most of the studies looked at the outcomes, the functional outcomes of these PERT preparation, the coefficient of fat absorption, coefficient of nitrogen absorption, stool weight, then fecal fat. Only 2 of the studies actually look at the clinical benefit, this is what needs to be studied. Are these enzymes actually causing clinical benefit? Only two of the studies which extended the follow-up up to 6 months and 1 year. And again, the problem is these two studies were industry sponsored. So even though I don't doubt the results, but again, it would be a good idea to have such a long-term follow-up study from an independent group, not involving this industry. So again, I told this. So I said this about the efficacy because after the meta-analysis, there were two other randomized controlled trials which studied PERT in patients with cancer and patients who underwent pancreatic duodenectomy. And both of the studies failed to show an improvement in the body weight and in the BMI. And then in one of the studies, compliance was an issue. The patients were not taking the medication adequately. And when we looked at our patients in this study, what we did was we divided the patients who came to the pancreas clinic with different levels of malnutrition into three groups. The group A patients were actually having at least 25,000 units, the right dose in the Indian scenario of the enzymes thrice a day with the meals, not before or after. In group B, the patients were taking, but somehow they were non-compliant because of various reasons. Either they could not afford or several other domestic factors. And in group C, either they were not taking any enzymes, either they were not started at all or they were stopped after seeing some benefit by the physician. And malnutrition was evaluated by several parameters, including subjective global assessment. So what we found here was interesting. If you see here, these are the proportion of patients who continue to have malnutrition on follow-up, which means that so if this is to the tune of around 30%. So patients who were taking these enzymes religiously, 25,000 along with food in the right way, right timing, right dose, even 30% of them were malnourished, which was same as the group of patients who did not have enzyme. And again, if we see here, the level of malnutrition, proportion of different grades of malnutrition were again similar in each of the three groups. So what does this mean? So what we did here was again the weight gain, weight loss, and the similar weight was similar in the three groups, irrespective of taking enzyme or not. So we tried to pick up different factors in these patients, different disease characteristics, different lifestyle habits, different etiological factors, and on multivariate logistic regression, what turns out is that these patients were either consuming alcohol or they were not taking adequate amount of food. Right? So till now, the most strong factor of malnutrition in these patients was exocrine insufficiency and maldigestion. That is maldigestion, not malabsorption. And now we have data to show that there is poor oral intake which contributes to this persistence of malnutrition in this patient. But the question is, why are the patient eating less? So this is something that we all have to introspect. One, of course, there is pain or there is anticipation of pain. That's why they opt not to eat in fear of pain, or they actually have pain or acute exacerbations. Anxiety and depression could be a factor. They may be having poor appetite for several reasons. I'll come to that. But then one of the striking factors when we ask this patient why you don't take, they say that they have asked not to take fatty food. Who says them not to take a fatty food? I'm not showing the data with the bar diagram and all, but by and large, either their family members or their caregivers or their dietitian. So this is a very common statement that the patient tells us, and that is why they are not taking adequate amount of food. One of the reasons. And why do they have poor appetite? Of course, these patients are in a hypercatabolic inflammatory state that reduces the appetite. Many of them will have delayed gastric emptying because of the disease itself or because of the diabetic gastroparesis, and many of them are substance abusers, alcohol, smoking, indus marijuana, and things like that. And then on top of that, it's a hypercatabolic state. Diabetes is the neuropathy, small intestinal bacterial overgrowth, oxidative stress, which is a constant feature of this disease induced by the stellate cell. So all these factors would actually, as a composite, lead to malnutrition in this patient. And therefore, it's not only about pancreatic enzyme replacement or not only to give them some nutritional supplement. We have to go beyond that. It's extremely important to consider these factors seriously and devise a treatment plan. And why low-fat diet is actually harmful for this patient? So this is the basic biochemistry. When we have undigested dietary fat, they will bind to the pancreatic lipase at the active site. They will form a complex. and the pancreatic enzymes will break down into pancreatic lipase digestive fat, and that goes into the intestine. So if we are giving the patient pancreatic enzymes, high dose of pancreatic enzyme, but we are not giving them dietary fat, this is basic biochemistry too. For any enzyme to work, there has to be an adequate amount of substrate. And for the pancreatic enzyme, the lipase component is most important, so dietary fat is the component. So if you don't give dietary fat, the enzyme is not going to work. It's a waste on their pocket, and the patient will continue to remain malnourished. So how to take care of this or overcome this? So this is the right golden rule of the thumb: right timing, right preparation, right dose. Again, right timing, it should go along with the food. Especially in the Indian situation, this is more so important. There are some studies which shows that immediately after or before food is as good as along with food. But in the Indian context, from what we observe, it's very important to ask the patient to take the food, the enzyme along with food, because if they try to eat after food, then they have many, especially for the ladies who are the homemakers, and they will do all the household work and then they will go and take the enzymes, and it's already 2-3 hours. It doesn't work. So it's extremely important to give the enzyme with food. The most important, another important component is to give an enteric coated microsphere or mini microsphere, so that is protected from gastric acid, and it passes through the pyloric channel, the 2 millimeter channel, through the food chain, and the right dose. Now the problem is we still do not know the right dose. If we look at different guidelines, they have different dosage schedule, different studies have different schedule, but in the Indian context, what we find is a starting dose of 25 to 40,000 units per mil appears to be fine. We don't have randomized control data, but clinical experience, real life experience tells us that this dose is kind of fine. I have just 2-3 more slides. And the other important thing is nutritional supplementation of micronutrients. So again, everyone talks about improvement of micronutrients. The pancreatic enzymes are required for micronutrient digestion. But there are several micronutrients which do not require pancreatic enzymes. So even if you give lots of pancreatic enzyme and the patients are not supplemented with this, they will still remain deficient. The other issue is I talked about oxidative stress, and all these micronutrients are used up in oxidative stress. And oxidative stress begins early on in the disease and keeps on happening. So even if we give a patient lots of pancreatic enzyme but do not replace this, and patient may still be deficient of these micronutrients even if they are not pancreatic exocrine insufficient. Because the mechanism of loss of this is not because of digestion, because of not eating and using up by the antioxidant defense mechanism. So that is why it's very important to give dietary counseling. A very nice study from the All India Institute around 10 years back, which shows that dietary counseling with or without MCT based diet is as good as giving nutritional supplements. So if the patients are counseled to take a normal, balanced, home cooked diet, if the patient is not very grossly malnourished, that should be more than sufficient to maintain nutrition in these patients. And then the other thing is the gut microbiome. This is a study that where we, for the first time, could show that there is a significant reduction in the abundance of Faecalibacter prosnitziae in chronic pancreatitis, especially diabetes, and there is increase in the abundance of LPS synthetic pathway and parallel increase in endotoxin. So which means that LPS from the intestine is translocating to the plasma, and that was directly associated with diabetes. So the summary here is the gut bacterial dysbiosis leads to endotoxemia, and endotoxemia or LPS is known to cause beta cell dysfunction. So if you remember that histological slide where the whole pancreatic parenchyma was gone but the islets were alive, still those patients will have diabetes because the islets are non-functional because of this LPS. It's not because of the destruction of the islets. And then we have further proven this with comparing with type 1 and type 2 diabetes. So if we put all together the exocrine insufficiency, diabetes, dysbiosis, and nutrition, so because of exocrine insufficiency, there will be malnutrition. But again in CP there is increase in the gut distal transit, ileal break is there, that causes dysbiosis. This will lead to bloating. On the other hand, autonomic neuropathy because of diabetes and intestinal motility abnormality again causes malabsorption, and that will again be contributed by the bacterial dysbiosis. So this actually is kind of a close knit network which contributes to each other and progresses the nutrition. So lastly, what to do beyond PERT and nutritional supplementation. This is not necessarily specific to pancreas. In any kind of condition where we have to give dietary intervention, Again, you know better than me what to do. But here, one thing I'd like to emphasize is the circadian rhythm. The body is regulated by circadian rhythm. The physiological functions are circadian rhythm modulated. And the gut microbiota also change based on the circadian rhythm and the functions. So in today's lifestyle, we have all lost our circadian rhythm. We do not have the right time to sleep, wake up, and that's what probably causes, contributes to gut bacterial dysbiosis and its metabolic functions, not only in pancreatitis, but also in any other illnesses as a whole. So finally, how to improve nutrition in chronic pancreatitis? The diet should be inclusive. That's extremely important. We should not ask the patient to restrict fatty food, or if the patient has no specific contraindication, they should be asked to take a normal balanced diet. That's extremely important. Then a balanced small volume frequent diet without fat restriction. um, Dietary regimen should be customized, and this is where the dietitian's role is of extreme importance to assess the nutrition, assess the other factors, the psychological factor, the other morphological factor, gastroparesis, and based on that, it has to be customized. It should not be a standard diet chart that should be given to the patient. Individualized and personalized dietary chart is extremely important. NJ feeding, of course, when the caloric requirement is not met, if the patient has acute exacerbation. Micronutrient antioxidant supplementation, along with the dietary supplementation, adequate glycemic control, and cessation of substance abuse. And of course, all throughout the treatment, the patient should be counseled, educated about their disease, and that makes a difference. We have lots of data on how personalized counseling helps the patient. I don't have time to discuss that today, but education and counseling of the patient is extremely important, and I'd be happy to take questions. Thank you.
Thank you, Dr. Akhtar. Please have a seat. We take questions at the end of the talk. The next speaker, Professor Ravi Meyer, needs no introduction. He's probably taught more than 600,000 doctors and clinical nutritionists all around the world. And we all have heard him in the morning, during the yesterday morning at the SPN LLL. Welcome, Professor Ravi Meyer. And he's going to talk about nutrition IBD for long-term care.
Okay, hello everybody. Also, I like to thank the organizers for inviting me again for this Pensa conferences. I really enjoyed these 2 days here in Hyderabad. So my topic was nutrition in inflammatory bowel disease, and I have no disclosures. When we look on inflammatory bowel disease, we have two distinct diseases, ulcerative colitis and Crohn's disease, and they have something in common. They can present in acute disease, and we can bring them in remission with our multiple treatment possibilities we have. Sometimes we can keep them in long remission, but sometimes these patients will also have a relapse. The pathogenesis is still not completely understood, but it seems that the microbiota, very important here, as already heard in other diseases, this plays a major role. If you look on a healthy subject, we have a nice balance of the microbiota, and so we have no alteration on the epithelial barrier, and so we have no inflammation. But it's clear, if you have a genetic background, we know a lot of genes are involved in these diseases, and you have negative environmental factors, this can lead to a dysbiosis of the microbiota. The microbiota becomes more aggressive, and so we have damages of the epithelial barrier, increased bacterial adherence, and also we have more translocation of the pathogen genes. They are interacting with the intestinal immune system through the pro-inflammatory cytokines, and this is at the end cause inflammation. When you look on the epidemiology, ulcerative colitis and Crohn's disease are more or less the same all over the world, and the ulcerative colitis is a little bit higher than Crohn's disease. Around 50 to 20% of this disease starts already in childhood. And what is interesting to see, in the past there have been a high incidence of IBD in Northern Europe, UK, USA, but in these areas there has been only a slight increase in the incidence. On the other hand, in the areas previously low incidence, like Southern Europe, Asia, and in most developing countries, they have seen a steady rise. If at the moment it's unclear if the increased incidence of the IBD is due to improved diagnostic procedure or to the changing on the environmental factors. What is also important, the incidence is higher in white than in black and higher in high socioeconomic groups. And also these diseases are more prevalent in urban compared to rural areas. When we look then specifically on IBD diets, there is no nutritional habits found until now really involved in the pathogenesis. The good news is that breastfeeding could have a preventive role, and also when we have an IBD patient, this will have an impairment of the nutritional status, and therefore nutritional treatment improves the outcome of these patients. And also we have to consider that nutrition is a different situation in the acute attacks or if the patients are in remission. You see, just as I mentioned in the past, in the area Hong Kong, Korea, Japan, and so on, Crohn's and ulcerative colitis, the incidence and prevalence was quite low, but there's a steady increase over the years. At the moment, it is not completely clear if the dietary factors plays here a role. More refined carbohydrates, more junk food in these areas, started to eat more saturated fat. But on the other hand, what is a good news, maybe a greater intake of omega-3 fatty acids may decrease in the future the risk. So in these patients, they are catabolic in the acute attack, so weight loss is very common, and these patients have a high prevalence of nutritional deficiencies. So weight loss is a little bit more in Crohn's disease than in ulcerative colitis, and so everybody's nutritional screening and assessment with a validated tool should be done. There's also some difference in the micronutrient deficiencies. When you look on Crohn's disease and ulcerative colitis, iron deficiency, anemia is more prevalent than in Crohn's disease, but the major feature in ulcerative colitis is bloody diarrhea, so you lose your irons. The fat-soluble vitamins are more impaired in Crohn's disease than ulcerative colitis, and in Crohn's disease we see more zinc deficiency than in ulcerative colitis. Gastroenterologists have for a long time neglected calcium and vitamin D, but this has to be considered today very carefully because we have seen osteopenia, osteoporosis is quite common in this patient, and in addition, corticosteroids are often used in the acute attack, and corticosteroids interact with bone health. Supplementation of calcium and vitamin D, specifically if the patients have corticosteroid therapy, they should be given. So what are the aims? We like to treat or to prevent the nutritional deficiencies. We like to reduce disease activity, clinical, laboratory, endoscopically, even histologically, and also we like to reduce the need for surgery. When we look on nutrition support, it is clear and it's generally accepted that undernourished patients and patients with high disease activity need to have nutrition support. But there is no IBD, specific IBD available that can be generally recommended to promote remission in these patients. And several studies have shown that nutritional status cannot be improved alone with only nutritional counseling. So in Crohn's disease, protein, energy, nutrition, and growth retardation in children is quite often seen. And if you have a deficit up to about 600 kilocalories, it was shown that the polymeric supplementation can be beneficial to improve the nutritional status, provided that the compliance is maintained. On the other hand, for ulcerative colitis, there are no specific data available on the benefits with oral supplements. Artificial support is more beneficial in Crohn's disease than in ulcerative colitis, and endonutrition is also the preferred route for nutritional repletion. So if a patient and the deficit of oral intake is more than 600 kilocalories, then tube feeding is indicated. The good news are that the compliance is here a problem. With the exclusive anti-nutrition, around 60% of the Crohn's patient can be expected to come into remission. But the time it takes to induce remission is rather long, and the compliance in adults is quite difficult. This is completely different in children. Children, we don't like to treat them with corticosteroids, so anti-nutrition is the first step to do it, and a lot of these children get remission with only enteral nutrition. So enteral nutrition per se is less active and less beneficial than corticosteroids. And if you need enteral feeding, nasal enteral tubes have to be used first. Enteral nutrition, on the other hand, I already shown to you, is not beneficial in patients with active ulcerative colitis. How much we should give these patients in the acute situation are catabolic, so they need some more energy, and the recommended dosage of protein is around 1.2 to 1.5 grams per kilogram. The dietitian has to estimate the requirements. We have to introduce gradually as necessary in malnourished metabolic stressed patients. But more is not always better. And the worst thing we can do to overfeed the patients and to put them in the bed. Bed rest and overfeeding will lead to more muscle loss, and at the end they have more inflammation. In the past, when I was a young gastrologist, about 30 years ago, we had the idea that parental nutrition to bring the gut at rest, no food, no nothing into the gut, this will heal the gut. But the data here, small studies, long time these patients need to get in remission, and so this treatment option is completely out and is not anymore recommended. Parental nutrition is only an indication in the preoperative situation if a patient is ulcerative colitis or Crohn's disease has to be operated with really bad nutritional status, bad nutritional factors, then they have a benefit when they are treated for a week or more if you can postpone the operation with parental nutrition. And this is also have shown that they improve the outcome. A lot of specific diets have been tried. Exclusion diet, no effect. Elemental versus polymeric formula, we know they are equal. I will just show you data afterwards. Different fat components, no major difference. High fat, low fat diet. A lot of hopes were in the past with probiotics or fecal microbiota transplantation. There are some effects for probiotics in ulcerative colitis, and also some effects when you look on fecal microbiota transplantation. There are some effects in children and adults if you use a diet enriched with transforming growth factor beta. Transforming growth factor beta is an anti-inflammatory cytokine, and in children and adults there are some small studies with beneficial effects. Glutamine, no effect. Short-term fatty acids, we can forget, and all phytonutrients used can be forgotten. There are two Cochrane database meta-analysis. The last was published in 2018, and it's clear the corticosteroids are, and when you look on the elemental polymeric formulas, the results are quite not different. So polymeric formulas are now recommended to use first. But there are no good studies comparing corticosteroids together with enteral nutrition. On probiotics, the use of probiotics cannot be recommended in patients with active Crohn's disease. All the data missed to have an improved outcome. In patients with ulcerative colitis, probiotics may be an alternative to standard treatment in mild to moderate forms. Also, there was a great hope using fecal microbiota transplantation in these patients. You see, this is just a published meta-analysis from C. So it seems that the probiotic, the fecal microtransplantation has a beneficial effect. But when you look on ulcerative colitis and Crohn's disease, you see the effect is only seen in ulcerative colitis. In Crohn's disease, there is not a significant difference. I still think that the fecal microbiota transplantation is an option in the future, but we need to have more data on the donors. We know that different donors have different activities, and also the application. We need to have this specific good donors to encapsulate that this patient can swallow the capsules. Now we have more the time done the transplantation by the gastroscope or by the colonoscope. There are some data in pouchitis, and here it's a combination of 8 different strains was compared with placebo, and these were given after the operation to prevent relapses or just after the operation to prevent the first pouchitis. There was another study showing a significant reduction. But if in daily practice you use this probiotic mixture, some patients will improve and some patients will have a benefit, some patients will not react. So to summarize this first part, in Crohn's disease, we can control the flare-up with anti-nutrition about 60% of the cases in adults, but time you need to treat these patients is very crucial. In children, I told you this is another situation. Anti-nutrition is less efficient than corticosteroids, and in ulcerative colitis they have no specific therapeutic effect shown. It's only supportive. We can replete or maintain the nutritional status, but on the disease activity there is no effect. Coming on to the second part, when the patients are in remission, most of the time when there is no inflammation, these patients have a normal appetite, they can eat normally, and so macronutrient deficiencies are rare. Adequate nutritional intake is most of the time there, but there is some group of Crohn's patients which in the acute phase they have a low body mass index, and this can persist after the patients come into remission. And sometimes we need to supplement this with oral nutrition supplements or even to give anti-nutrition. In the remission phase, we have still to consider malabsorption, previous surgery, short bowel syndrome, also some metabolic changes we have to take in consideration. Some patients with symptoms, bacterial overgrowth, can be a problem. We have to make the diagnosis with a breast test. Some drug interactions we can have, and micronutrients, specifically if you have iron resection, B12 has to be considered, and vitamin D and calcium are also necessary to be controlled. What is recommended, although the database are not very strong, the Mediterranean style diet with cereals, with dairy products, with a lot of antioxidants, with different vegetables, and also the supplementation of more fish, so more omega-3 fatty acids included in this diet. This is the only thing recommended today. Also, in the remission phase, exclusive diet, no clear data, but we have to consider the intolerances. If a patient has a lactose intolerance, also when they are cured, when they are in remission, the lactose intolerance is there. Some patients don't like spices, herbs, fried, gas-generating food, fiber-rich products, and we have to look on these things, and the dietitians have to make the recommendation how to avoid it. All nutrition supplements and anti-nutrition can be recommended in these patients with Crohn's disease when they cannot be treated sufficiently. Some years ago, there was a study published in the New England with only 78 patients, and they have shown with omega-3 fatty capsules that they could decrease the flare-ups over 1 year. But no one believed in this study, although it was published in New England, and it took about 12 years more to get the results, and the results came from Freedom, the EPIC-1 and EPIC-2 studies. Diet omega-3 fatty acid capsules compared to placebo, 1 year. Big studies, 360 patients in each study, and you see over 1 year there is absolutely no difference. So for a specific relapse control, omega-3 fatty acids cannot be recommended. Again, probiotics have been used in the remission phase. No convincing results in Crohn's disease. There are some data maintaining remission in ulcerative colitis, but here only very few specific probiotics can be recommended. The first one is E. coli Nisle, the other one is Lactobacillus rhamnosus GG. And in relapsing mild to moderate ulcerative colitis, there are also some data when you use this preparation, 8 different strains, that you have a weak beneficial response. I think the best study we have still in probiotics in ulcerative colitis is the study from Germany, published many years ago, and they looked on maintaining remission in ulcerative colitis with E. coli Nisle compared to standard treatment, and you see, when you look on the relapse rates, 12 months, it is the same. And in many countries in Europe, this E. coli Nisle preparation is approved by the medical authorities and is also reimbursed by our insurances. And quite a lot of patients, specifically in Switzerland or in Germany, they are using this E. coli Nisle preparation. The other study in the same way, looking on Lactobacillus rhamnosus, you see also a nice study, multi-center, randomized, double-blind control, 12 weeks, and you see with the probiotics, with these 8 different strains, you have a reduction on the ulcerative colitis disease activity index more than 50%, and 33% remission, 43% mucosal healing in 32%. But this is not significantly significant. This is significantly different. So also here, these multi-strains can be recommended in some specific patients. What has changed since the last 30 years? 30 years ago, Crohn's and ulcerative colitis patients, they were slim. But now with the obesity problem all over the world, we have a new situation. A lot of patients with ulcerative colitis and Crohn's disease are obese. And we have some data on the outcome in Crohn's patients. Crohn's patients have earlier perineal fistula, more increased disease activity, they have to go more to the hospital, and they have earlier surgical intervention. But it's also to say here, if an obese patient is in acute attack, we should not recommend them at this time they should reduce weight. If they're in remission, then we can speak about reduction of weight, then we can use the general treatment option of the several guidelines available. And this is my career slide. Many times I had thought I know the way to go to treat the patients, but all the time there are some things against. This is a nice picture from Paris. And with this, I thank you for your attention.
Thank you, Professor Remy. The next speaker is Dr. Dinesh Jyotimani. He is the Director of Hepatology at the Rela Institute of Medical Center, Chennai, and he is going to be talking to us on nutrition optimized in the pre-liver transplant recipient.
Okay.
Slide changes, no? Good evening, everyone, and thank you for giving this opportunity to talk in this Pensa meeting. It's really impressive to see such a big crowd and a lot of halls, a lot of meetings. So we heard a lot of talks on IBD, pancreas. So it's now the turn for the liver, actually. So nutrition optimization patients undergoing liver transplantation. Liver is a master organ. We know that it's like a processor. It does a lot of functions. And therefore, when you have patients with liver cirrhosis, all these functions can be altered and completely disorganized and in disarray. Malnutrition, which is, it could be undernutrition, or sometimes even in liver patients, like in IBD, they showed patients of obesity. So we do see overnutrition with fatty liver disease. But in general, malnutrition is seen in around 20% of patients with cirrhosis, but more when they have a progressive disease. Almost 50% of decompensated cirrhotic patients have underlying malnutrition. I would say in our practice, almost close to 90% have a severe malnutrition, what we see, because the patient with end-stage liver disease, they refuse to eat, and there are multiple reasons for that. And how does it affect? There are a lot of complication it can cause, and the other important point is what we call a sarcopenia. These are the definitions we need to know, where there is loss of skeletal muscle. As the disease progresses, as the liver disease progresses from child A to child C, there is increasing prevalence of sarcopenia in these patients. And patients with the liver cirrhosis, when you fast them, say for example for endoscopy, you need to fast them for, if you fast them for 12 hours, the same amount of catabolism occurs if you fast a normal person for 3 days. So there's a very accelerated starvation. There is increased high catabolic rate occurs in patients with liver cirrhosis. And this leads to a lot of complications. And in fact, study shows that malnutrition is associated with poor outcomes in patients with liver cirrhosis. If you see this animations here, the graphs here, the slides here, if you have a normal liver, the ammonia produced by the gut, it's metabolized by the liver. If you have liver cirrhosis but no malnutrition, the liver may not metabolize the ammonia, detoxify the ammonia, but it's detoxified in the muscles. But if you have liver cirrhosis and malnutrition or sarcopenia,
the secreted ammonia is not detoxified by the liver as well as by the muscles, and it's taken up by the brain. And these patients are often disoriented, confused, which we call as hepatic encephalopathy. In fact, when you have sarcopenia, your survival rates are very poor, even with transplantation. So malnutrition is associated with pre and post-transplant complications. So what causes malnutrition in patients with advanced cirrhosis? It's actually multifactorial. There can be number of reasons, starting from patient may have loss of appetite, they don't want to eat, they may have altered taste because of micronutrient deficiencies, they may receive lot of antibiotics, they may have nausea, vomiting, they may have constipation, they don't want to eat. So there are multiple reasons for that. And also the disease process per se can make them not eat. For example, if you have ascites, if you are admitted in the hospital with sepsis, they may not want to eat. And malabsorption, maldigestion, there are multiple reasons why these patients may not eat actually. And this is a cyclical process. So if you have liver cirrhosis and if you develop malnutrition, and that's going to aggravate the disease, aggravate the complications, and that's going to worsen the malnutrition. And this is a very bad, vicious cycle. Unless you stop it somewhere by intervention, it's not going to stop. It's a progressive condition. So what happens to the metabolic profile of patients or metabolic derangement in patients with end-stage liver disease? So I told you liver is like a factory, it's like a powerhouse. So when you talk about three major metabolic components, with carbohydrates, glycogen is stored in the liver. So that process is going to be impaired. So there is decreased hepatic and skeletal muscle glycogen synthesis. And glucose gets secreted from the alternative source, gluconeogenesis. And there is fat that get destroyed, lipolysis. And also there is increased breakdown of protein and also reduced formation. So there are multiple things that goes on in patients with liver cirrhosis. But what is more worrying is, as clinicians, we completely fail to address this issue and we don't talk about nutrition to the patients. During our ward rounds, we only address about ascites, give diuretics, TAP, give albumin, start telepressin, antibiotics. That's where our conversation stops. We never engage patients or we never discuss much about nutrition, and nor we involve the dietitian in the rounds or somewhere. So I think this is malnutrition being a potentially reversible, modifiable risk factors, at least to an extent. As clinicians, we should engage ourselves and spend some time in the ward round to discuss about the nutritional aspects to that particular patient. Unlike the many other chronic diseases, malnutrition in liver is very dynamic and it can be progressive. For example, when you have a condition like alcoholic liver disease, their nutritional deficiencies and requirements are different from when you have obesity related liver disease such as non-alcoholic steatohepatitis. So these are completely two different cohorts of patients. They may have different deficiencies and different requirements. But when the disease progresses and these patients develop more nutritional deficiencies, sarcopenia, and they have ascites, and in patients with NASH, you can have sarcopenic obesity. They may be obese by the BMI terms, but they still sarcopenic. Alcohol patients, again, they are profoundly malnourished. So these patients are not the same. All liver disease patients are absolutely not the same. So that is why it is important to tailor-make the nutritional therapy for these patients. There are a lot of guidelines from various organizations about nutrition screening and how you assess these patients for the requirements.
Majority of them are from the West, and they all talk about body mass index, which may not be that suitable to the Indian context because we are not that obese when in comparison to body mass index. We get all the diseases of a high BMI even in the normal BMI patient. So that is why we talk about these days about more of waist circumference, although. So we have more insulin resistance. So therefore, going by BMI may not be that suitable, but most guidelines are based on that. And also, if you have advanced liver disease, how you are going to screen them. So there are guidelines, so we should follow that. For example, you have patient with child A and in compared to child C, they are less malnourished. So therefore, if you see a patient with child C cirrhosis, it's better to go for assessment straight away in terms of the nutrition, how you're going to intervene. And there are various ways to do that. You have anthropometric assessment, you have non-anthropometric assessment, and you have functional assessment like a frailty test. So there are a lot of guidelines. EASL has come out with the guidelines, ESPN guidelines, and previously there is Indian guideline, INSL guidelines. So we need to follow them. But as a guideline, we need to address that with caution and make it appropriate for our patient. So one of the best studied tool is malnutrition universal screening tool. It's a must score, it's called. So it involves your BMI and weight loss. Again, there's a caveat here. Patients with liver cirrhosis, when they have developed ascites, your weight may actually increase. So you're falsely going to score them. So these scores are not liver specific. So therefore, when you use these scores, you should use it with caution, particularly as the liver disease progresses. So this is a royal-free score. This was developed exclusively for liver disease patients. But once again, if you look at it, starts with patients with alcoholic liver disease. So this was developed initially for alcohol hepatitis patients, but subsequently modified for other patients. This is designed for liver disease, and it's a very short screening tool. It takes approximately 3 minutes, and it has good inter and intra-observer reproducibility and externally validated as well. So this score can be quite useful in patients with liver cirrhosis. And also there's liver frailty index. So these are the scores specifically designed for this. So you have a hand grip test. I'm sure as nutritionists, dietitians, you are very familiar. Chair raise test or chair stand test, and a 6-minute walk test. So these are dynamic frailty index tests. So this can be carried out. Once again, you have to have a caution. Say, for example, patients with end-stage liver disease may have hepatic encephalopathy. So they may fail this test. So it is not the nutrition, it is the disease complication that they fail. So you need to interpret these results with caution. So what are the challenges of nutrition therapy or nutrition assessment in patients? What we just saw that. In addition to what all we saw, on the other side, from the patient perspective, we are restricting the salt because patients with ascites, sodium restriction is important. On the one side, if the sodium is low, we are restricting the fluid. But when we add nutrition supplements, we have to mix the same supplement with water. So your water content actually going to increase. So we have to get some balance somewhere actually. So that's where there's a major role for the dietitian. And often these patients have loss of appetite, ascites, frequent hospitalization, dizziness because of beta blockers we use, antibiotics can make them sick. So therefore, nutritional assessment in patients with end-stage liver disease to me is absolutely challenging. But nevertheless, we have to somewhere conquer this because this is a very important subject and it's part of the treatment rather than we cannot keep nutrition aside from liver patients. And therefore, we need to know how we are going to correct this. And once again, there are various guidelines that talk about the calorie and protein goals. Most guidelines, if you see the EASL, ESPN, INSL, they all are on similar lines. So in patients who are going for liver transplantation, the calories should be on the higher side. This is around 1.4 times the resting energy expenditure. So you have to treat them little more than what they actually require, but not too much. At the same time, these patients are protein malnourished, so therefore you need to give them high protein diet. And previously, in the past, most experts or physicians used to restrict protein. It's no longer necessary because particularly in high grade encephalopathy, people used to restrict protein, but that leads to more malnutrition and more complications. So therefore, that's no longer necessary. And of course, you need to get the right composition of the diet. Say, for example, 50 to 60% of the calories should come from carbohydrate, and around one third should be from the fat, and predominantly, polyunsaturated fatty acid. So you guys are the expert in that. So therefore, we should provide adequate calories and nutrition, sort of protein to patients with end-stage liver disease, because it is shown to improve a lot of complications and, of course, survival. So let us see what EASL guidelines say. Definitely, it is a multidisciplinary team approach. Treating physician, right from the nurse and nutritionist, everybody should be involved to look after that particular patient who needs more specific nutritional therapy. And calorie and protein restriction, protein goals we saw in the previous slide. Most patients finish their sort of night meal around 6, 7 o'clock, and that leads to a big gap of more than 12 hours of starvation, and that is not acceptable. And these patients often develop hypoglycemia. Therefore, overnight snack is recommended by EASL, and that's something we also follow that. So this is very, very important, because this will avoid hypoglycemic episodes. And also for protein, branch and amino acids can be supplemented in these patients, particularly if they have hepatic encephalopathy or advanced disease. And patients who cannot take orally, it's very important to discuss with them and counsel for nasogastric tube feeding. But somehow I feel patients in our country are less acceptable for that. I don't know, probably there's some stigma. We can discuss about that. And these guidelines by ESPN also concur on the similar lines in patients with, the fonts are very small, so also concur on similar lines. This is more recent guidelines from the European Society of Parental Enteral Nutrition. So therefore, the bottom line is you should feed them. You should feed them with adequate calories. You should feed them with adequate protein. Of course, the fat, which I will talk to you about short while. So therefore, do not restrict anything and avoid starvation in these patients. That's a very, very important message. So I see patients going into ICU, they may be kept on fasting because they are not okay in terms of orientation due to hepatic encephalopathy. All these things we should discuss and make decisions as how to safely feed them. There's always a bit of a debate about the role of branch chain amino acids in patients with liver cirrhosis. EASL guidelines clearly mention that yes, it should be encouraged and used in patients with hepatic encephalopathy, where also in patients with decompensated cirrhosis. There's a recent nice study from Jaipur where they showed that use of branch chain amino acid in liver cirrhosis improved hand grip and mid-arm circumference, as well as the gait speed, the walking speed. So, but you have to treat it for sufficient duration of time, 24 weeks like that. Bear in mind, it's quite an expensive drug. So, therefore, when you deal with cirrhotic patient, end-stage liver disease patient, you can come across a number of barriers. That is where the role of a multidisciplinary team comes in, because we need a good support system. And we need to address their comorbidities. Say, for example, some of them may be diabetic and have chronic kidney disease, so we need to adjust their diet accordingly and fluid intake. And the most important thing I sort of look into is the patient motivation adherence. So we have to reiterate again and again about nutrition. In every rounds, we talk about that to the patients, but we should do that more frequently, and also motivate the family to, because in India the family is pretty much involved with the patient care. So that we have to carry out as a treating physician. That's very, very important. And of course, when you have complications, we need to address that appropriately. And for example, if somebody has GI bleed, probably you should address that quickly and start feeding them rather than keeping them ill by mouth for a long time. And also, I told you the diet should be tailor made rather than just generic. So as the dietitian, what probably you can provide is a sample diet for the individual patient. This is a sample diet for from the West, but definitely you should make a tailor made diet. There is no point in treating a sort of patient from UAE with idli and dosa like that. It's not going to be palatable. They may not accept that. So you have to tailor make what they're going to eat, because there is a lot of cultural diversity in the nutrition, and that is why it's very difficult to do a nutrition based trials, because we all eat different kinds of food. When you see a patient with end-stage liver disease, you should formulate a personalized dietary plan. So that is actually very, very important. And last few slides. So in patients undergoing liver surgery, definitely you should feed them with high protein and high calorie diet. The reason being, there are studies shows that when you have malnourished patients going in for liver transplantation, they may have prolonged ICU stay in the post-transplant period. Their complications may be more, prolonged ventilatory days. So there are a lot of complications they can encounter. The risk of infection is higher in the post-transplant period. So therefore, treating a patient holistically is extremely important for their better outcomes. And so, as I say, preoperative nutritional therapy improves liver transplant outcomes in patients with advanced liver disease. And of course, not to forget the fat supplementation and the fiber supplementation, which also provides some calories, and also the micronutrients you should not forget. And the other important aspect is about bone supplements. So you should do a DEXA scan when possible, and then give them calcium, vitamin D supplement. These should not be forgotten. So there are a lot of things we should do to improve the nutrition. And as I said, it's a very, very holistic approach. It has to be individualized. This is my last slide. I would say, I'm just going. These are two different cases. I don't know whether you can see that. So, patient one and patient two. Patient one is a 60-odd-year-old, 8-year-old gentleman, and this is a lady. And if you see, both are malnourished. The second patient was more sarcopenic, and she was very, very sick with high MELD. The patient one was sort of MELD of 16, but both were malnourished. The difference was one agreed for nasogastric tube feeding, and in fact, she was bedbound, and she started walking, whereas this gentleman refused to eat and continued to refuse nasogastric tube feeding, and he developed septic shock and died. Whereas this lady, even with high MELD, with nutritional therapy, she underwent transplantation and survived and walked without any major issues. So therefore, Chairman, ladies and gentlemen, nutrition management in patients awaiting liver transplantation and in patients with liver cirrhosis is extremely important, and it should be sort of multidisciplinary team approach. And we should replace calorie, protein, and vitamins as required. And as I say, education is extremely important from the patient point of view, and also for clinicians like us and the entire treating team. And considerable time should be spent during the rounds focusing on the nutrition aspect. Thank you so much.
So the last talk in this session is by Dr. Gomti Narsiman. She is going to speak to us on nutrition optimization in post-liver transplant scenario. Dr. Gomuti is a senior consultant liver and renal transplant department at the Rela Institute Medical Center, Chennai.
Oh, thank you. Hi, good evening to one and all. So I'm the one holding you from the gala dinner, so I'm going to make it really quick. We have Doynes from hepatology, Dr. Dharmesh Kapoor. We have people involved in nutrition. So I thought my talk is essentially going to present problems, not solutions. I look forward to having solutions and action plan from this august audience actually. So this is from 1990. Janet, who has done a lot of work on liver transplant nutrition. Each of these words in this sentence actually is very simple, but has had a lot of impact over the last 32 years, I would say, and still holds very relevant. And it talks both about acute and long term. I think that's what we're going to discuss also today, is what do we do in the immediate post-op, but when we talk about implications, it has a big role in the long term in transplant patients. There are guidelines, SPEN guidelines from Liver Transplant Society, from the ERAS. Everybody has guidelines on what to do for transplant patients. And simple words. For example, we're talking about after transplant, is try and feed them early, and long-term nutritional monitoring is important. Similarly, when we talk about guidelines from the Liver Transplant Society, again, the aspects are quite similar. Current nutritional. Sorry, I'll have to expand it here. And the SPEN guidelines is also pretty much what it is for any major surgery, that a delay of more than 7 days you need to of oral intake, you need to initiate supplements. And if you're anticipating more than 10 days of less than 60%, you think about enteral. Well, this is a very common scenario in transplant patients, as you can see. And the problem statement, when patients come into transplant, Dr. Dinesh has told us so much about how sick they are before they come in. And so we have patients coming to transplant who are either sarcopenic, have sarcopenic obesity, or are obese. So none of these fall into the healthy category coming in for transplant. So we have a problem where the patient who is going to transplant with a sick state also has a lot of uncertainty post-transplant. That's where there's a little bit of interest generated in how do we take care of them in the post-transplant phase. Because this gentleman post-transplant could follow one of the two routes. One is like probably the patient in the next bed who goes home to the ward on maybe 4th or 5th day and then home by 2 weeks, or ends up getting reintubated, having problems because of sepsis or something else. So by day 1, day 2, we're not sure which route this patient is going to take. And so we cannot predict whether in about 6 days he's going to have his normal food intake, or by 10 days would he be taking 60%. So where does this all lead us to? It leads us to basically trying to take care of them very early on, considering they may have issues, and if they sail through without issues, withdraw the supplement. That's how I would approach the acute phase of managing a liver transplant patient. There's an interesting study from 3 hospitals in Delhi. The reason I'm putting this up, of course, their data, they looked at, the biochemical parameters and found albumin levels were low, liver enzymes were off, expected in all liver transplant patients. But what was interesting in this study was this aspect. That is, you can see the NPO on day 3, 6 and 9. 33% of patients were NPO on day 3. 50% were NPO on, 50% were only on oral, which means 50% were NPO. And in the 33% that were NPO, even by later on, you see that only a few of them went on to parenteral or enteral nutrition. A good number of patients by day 3 do not have any nutritional supplement going on. And this is not just in those 3 hospitals. This is the way liver transplant patients end up because what we see here is they start off with a negative intake for the first 3 days, some of them not even getting this. And I'm going to elaborate a particular scenario from our patient experience, which is quite common. I'm sure Dr. Dharmesh Kapoor will vibe with most of what is put up here. This is a gentleman, 58-year-old, NASH, as you can see, a lot of ascites, MELD of 24, high INR, very sick patient going into transplant. But before transplant, what is important is assessing him, and we see he has significant muscle loss, BMI of 18.1. As we go through the evaluation for transplant, every aspect is looked at, on the infection standpoint, the cardiac. Very importantly, the nutrition has to be focused on. This particular gentleman is malnourished, as we see, and so tube feeding was started on day 1 of the patient getting admitted to the hospital. It is not required to wait for the first few days for assessment, as early as you can start, because in this patient we're looking for a window to transplant him. That could be 2 weeks, 3 weeks, maybe later, we don't know. So as early as you can start on nutritional supplement, the better. And this patient undergoes a transplant 3 weeks from the day he comes into the hospital. Whatever benefit you've achieved with the nutrition at that point is definitely going to be helpful. We don't wait for nutritional improvement to transplant because there are several other aspects which are involved, like his sepsis issue, his decompensation from liver disease. But anyway, he goes through transplant. What happens in the post-op period? Like most patients, standard protocol, extubation the next day of surgery. And then by day 2, he starts having some bloody drain output. Again, not uncommon, not very common, but at the same time you do see it on and off. And standard practice is to watch them to see if they need to go back into the operating theatre. So every 4th hour he has his hemoglobin monitored. And then the plan is to do a CT scan if the hemoglobin drops further. The drain output is kind of starting to thin out, minimal, so you again wait overnight. Next day morning, drain volume is low, but the hemoglobin has dropped. Obviously, you're worried about bleeding. You get a CT scan done, there's a hematoma. He goes into surgery, resurgery, comes back, once again, following day gets extubated. So, in all of this, what is important is you can imagine he would have been nil per oral several hours or days together. And this is probably the scenario which is reflected in the study we saw in Delhi too. It is not uncommon to see patients staying nil per oral for quite a few days, not because we can't feed into the gut, because there could be probability of going back to surgery and intervention which is going to happen. The only saving grace in this particular patient was that we had started feeding him pre-transplant, continued to keep the tube and continued to feed him. But this is, again, because he was quite sick and had a tube before, we continue to do that. This is not a common scenario. Going back to what Janet's paper said in 1990, I had the privilege of working in a unit where she was a dietitian, and the protocol was to put a nasojejunal tube in all patients in the operating room. Because they have an NG there, it's not difficult to thread it through across and keep it in there. The advantage is in the 3% or 2% who may end up needing it, not in the rest of them who would anyway do well. So it's a matter of removing the tube on day 3, day 4 versus feeding them for the first 3 days, if at all they end up needing it for the next 1 week. So that advantage, I think we should think about it to see how we can feed and not think about it once they start deteriorating. So much about the early phase, and also because we know other issues. Infection issues are much more common when patients are sarcopenic, as we saw when they go into transplant, and feeding them, because in the early phase there's a lot of deficit in them already, and every day, every few hours more is going to increase the deficit. So early nutrition has a lot of benefits, and I don't think we'll have to stress it more as to how we can feed them early. But I think the problem statement, the bigger problem statement I would say, is in the long term. The early period, most of us are now used to taking care of sick patients. What happens in the long term? I think that's the big problem, mainly because it's metabolic syndrome. Metabolic syndrome in any specialty we see. Like we saw in IBDs, it is much more in liver transplant. All the more because the etiology when they go in for transplant is also changing right now. And the guidelines for defining metabolic syndrome in the post-transplant period is pretty much what is followed elsewhere. More than 3 of the criteria are required to label them as metabolic syndrome. Now, what is interesting is these patients, the incidence that's quoted in different studies varies from anywhere, this is post-transplant metabolic syndrome, from 45 to close to about 65% end up with metabolic syndrome post-transplant. And the factors that contribute, if you see in the thing, is predominantly the pre-transplant risk factors. Not that we can change much of those, they come in with these. What can you do to them? You know, when 60% of them end up with metabolic syndrome. The only factor that's listed is change in BMI. Can we do anything about it? This is interesting because in the context of what is quoted as 45% and 65%, there is already an underestimation of the metabolic syndrome in them. Underestimation happens in the pre-transplant phase also, because whatever is quoted does not take into account the low SVR and hence the blood pressure parameter will not be there. Low lipid levels in liver failure as a result of which they will not come into the category of metabolic syndrome, but they still probably are having a component of it. And in the post-transplant phase, in a lot of studies, they have substituted diabetes mellitus for impaired glucose tolerance and used BMI instead of waist circumference, which means it's still an underestimation of the metabolic syndrome that exists. With all of this, our own data also reflects that in the last few years, the etiology of patients coming into transplant has changed so much. NASH now contributes close to 42%. In the early phase from 2009 to 14, it was about 30% of our patient population. Currently is 42%. So they start off with NASH, metabolic syndrome. Post-transplant incidence gets much more higher. This paper from Michael Charlton in 2010 highlights several interesting aspects. In 2010, when this paper was written, NASH was the 4th common indication for transplant, and the prediction at that point was in 15 years it's going to become the top, and that's where we are right now. And interestingly, he also talks about the metabolic, the modifiable and the non-modifiable factors which need to be looked into. So non-modifiable factors, etiology, we can't do much about it except that hepatitis C, which was earlier an important cause for metabolic syndrome post-transplant, is not so much an indication now. And the immune suppression is a mandatory thing that you're going to give, but how well can you modify it? How quickly can you reduce steroids so that the patient's metabolic syndrome does not worsen? Use of everolimus, which is used to protect the kidneys, can also cause dyslipidemia. So where's the balance between the two? Of course, the modifiable factors is where we can play a big role, which is nutrition and activity. The recurrence of NAFLD in post-transplant is close to 78%, and de novo in somebody who's not had a fatty liver disease is close to about 40%. So we're staring at a very big problem in our hands, but what does it really translate to? It translates to cardiovascular events. I mean, this is quite logical. Diabetes, dyslipidemia, blood pressure will all translate to cardiovascular events. And the incidence of this is quite high in transplant patients when they have a metabolic syndrome. There's a good difference in patients without post-transplant metabolic syndrome and with post-transplant metabolic syndrome developing a cardiovascular event. Does it translate to cardiovascular mortality? We've not been able to really prove that in many studies, maybe because at that point modification is made or we don't have studies long enough to substantiate that enough. Going to the patient's perspective, interesting study from 2022 recently. How do we really change this? I mean, we've been talking about this for nearly 30 years now, that post-transplant metabolic syndrome and obesity is killing patients. Nothing has changed. The problem has only increased. So they went back to the patient to see what's going on. Why are they behaving like this? So the early phase is when the patient has gone through a lot of difficulty from sickness to feeling well. So the path back to living is what they are enjoying at the moment, and then comes the pleasurable new phase of life. And by then we talk to them about metabolic syndrome and the mortality and the risk involved. I think at that point in this qualitative study the patient said, I'm happy to just be alive. I don't want anything more. But if the studies look at this particular study looked at, does it really keep them alive? Because that at the end of the day is what might strike the patient. This is a very nice study where patients have been followed for 370 patients, followed for 12 years. And the aspect that they look at is the BMI at the end of 1 year was what they followed up. Patients were categorized into 3 groups based on their normal BMI, which was less than 25, 25 to 30 as overweight, more than 30 characterized as obese patients. Interestingly, the obese patients, as expected, when I say interestingly, as expected, their overall all-cause mortality was higher. So it was not necessarily the cardiovascular which we were focusing on earlier. It was found that malignancies, sepsis, and cardiovascular cerebrovascular disease killed them more. The obese patients were had a 2 times higher risk of death compared to patients who were in the normal weight from all-cause mortality. So where do we have to go back to? We have to go back to starting very early on, because end of 1 year BMI predicts what your long-term outcome is. And I looked through quite a few of the recommendations from different hospitals on post-transplant diet advice. Not everybody focuses on long term. I think it's important to start early on. When we talk to them about diets during discharge, we need to highlight the importance of managing their weight gain, which happens a lot because of medications and their lifestyle. So there are a couple which spoke about it quite elaborately, and I think that's something we all need to incorporate. Going back to Janet's paper in 1990, there is a good table on short-term and long-term needs. Like I said, I don't know how much the impact of metabolic syndrome was at that point in 1990. All they wanted was to see patients, stay alive for 10 years post-transplant. But now I think this is the need of the hour. I'm going to finish my talk with a couple of slides about patients. This is somebody who came and saw us just about a week ago. 49-year-old gentleman, diabetic, 15 years, NASH, chronic kidney disease, diabetic nephropathy. His BMI at transplant was 21.6, sarcopenic ascites. So BMI again was much lower probably. Received a liver and kidney transplant. He's very happy right now. He says life is perfect. But then we look at his labs. He has a fasting sugar of 132, triglycerides of 219, fibroscan showing recurrence of fatty liver disease. His current BMI is 33.4. From all what we saw now, this man is going to have major trouble. Not that he was not counseled, but I think this is where we stand right now. And this is with the permission of Mr. ST, the one whom we spoke about earlier. He was also a NASH patient, if you remember. He is 1 year post-transplant with specific attention given to the modifiable and certain other factors. The diabetes, hypertension trying to be well controlled. Statins were started quite early on. He's on low dose of tacrolimus, needing some MMF to protect his kidneys because he had some kidney injury early on. Steroids were stopped early on. His BMI trying to maintain where it is probably safe for him. So with these, I think I'm going to end my talk saying we need to really think out of the box, think of new things, because patients' attitudes haven't changed. We've spoken about the same thing for several years. These are some new innovatives which are coming up, looking at exercise-based regimens from home for transplant patients, long-term monitoring of them. Should we probably think of something like that for diet monitoring for transplant patients? But ultimately, it all depends on activity, diet, and behavioral therapy. I think we need to focus on a lot more to make a change in our patients and make the long term really successful. Thank you.
Thank you so much, Dr. Gomati. I think you should come and sit. Sir, the floor is open for any questions. Dinesh? Any questions from the audience?
Can I ask? Yeah. So since there is no questions from the audience, I'll probably address a question to Gomti. So I did notice that you basically been stressing the fact that there's going to be cardiometabolic problems post liver transplant. Is what we are trying to prevent. Is there any marker that will tell me, like in pre-transplants, we do a fusion ratio BC AA divided by aromatic amino acids to understand how bad this patient is. Is post-transplant to predict cardiometabolic disease? Is there some way we can predict it?
All I mean, it all comes back to the same thing of BMI and talking about what we know already. I think there's a huge scope for work in those areas to predict who are the ones who will end up, because even the morbidity ones did not go on to mortality on the cardiovascular. So I think there's a lot of work. I could not see any. I don't know if the others in the panel can tell if there is any marker that we have.
So is there something to do with leucine in here? Anything with leucine to do in liver transplants?
Sorry, say the last thing again.
Is there anything to do with leucine here?
So not exactly. So you're asking about any association of ASCVD in the post-transplant scenario. So basically, it's all to do with the standard parameters that you see in the general population. So you could pretty much give them the same risk as you would in someone who's not been transplanted. So the factors like, say, the HSCRP, it's got very little value somebody in the pre-transplant scenario, but becomes important. But there is no scoring system. Basically, it all drives down to what risk factors you have in the metabolic syndrome, which would be the driving force. And partly it is driven by what she described, a perfectly happy patient, partly by immunosuppression. Of course, there is a huge overlay of the genetics, which is still under study. But the good thing over here is that even though you put on a lot of weight, and like Dr. Gomti mentioned, that you're looking at the recurrent NAFLD as about as high as 70% in de novo, as high as 30% in some studies, but the NASH percentages are much lower. So it's just about 20% in the former and about 15% in the latter. 20 might go up to 25. So the fibrosis is not all that high. But then these patients put on a lot of weight in the first 1 year, and that is the crucial time when your intervention should happen.
I have a question for you. How you diagnose infected necrosis in India? There's this controversy to puncture or not to puncture. What is your approach here?
Yeah, great question. So we don't do any FNAs of the necrotic tissue because the false negativity is very high. So we go clinically. If the patient has necrotic pancreas and he continues to have high TLC, recurrent fever through week 2, week 3, on a CT, if we see air bubbles, so those are the surrogates. We can say definitive, but based on that, we can start empirical antibiotics, but not on the first week. First week, the fever will be because of systemic inflammation.
Professor Gill, I have a question for you. I was very interested with the machine that you showed, the inside machine. It just takes out the labor, takes out all the unpleasantness that we have with the chyle reinfusion. Are there any problems with this particular machine? Any problems, any practical problems that come in with this machine?
Not really. It's a closed system, and once the stoma nurse is trained, or the patient, and she can then train the patient, and it becomes very easy to manage. So they just wait until there's maybe 200 minimum 200 ml in the stoma bag, and then they can reinfuse, and
But no problems per se. So when you reinfuse it, it goes at a rate that is fast, slow. How is it? Oh, there's one over here. So can we just show it to the audience? So this is the machine, is it? And this is the machine.
The nurse connects this little pump to the feeding tube, which is a standard procedure for stoma nurses, a standard stoma bag, and then this driver attaches from the outside, and that drives the pump to reinfuse. So we have more than 100 patient experience, so it's too early to say it's completely trouble-free, but we haven't had any reports of any major problems using it. And the nurses are very happy because they don't have the smell or the transferring and the filtering or anything. I guess the only
it's not a problem, but the patients are better if they have a fairly low fiber diet. One of the first patients in New Zealand was so happy that he was able to eat again. He ate a whole pineapple, and the fiber from the pineapple clogged all the tube and everything, so it didn't work well. But otherwise, a reasonably standard diet seems to work very effectively. Yes.
Can I suggest some technology add on to that? Should get it Bluetooth enabled and attached to a smartwatch so that they can press on and off through that.
Fantastic. So if anybody wants to have a look at this, yeah.
I just have a question, sir. I have
To
a
whom?
question.
To whom is the question?
To Dr. Talukdar. Hello, doctor. This is Harita. I'm from the dietetics team here at Apollo Hospitals, Hyderabad. I just have a query about you mentioning that you do prescribe a normal diet for a patient on pancreatitis. As you understand, traditionally we have been talking about low-fat diets to all these patients. So, are you suggesting that if somebody is on creon or off creon, based on that we suggest, or all patients blanket you talk to them about a normal diet? I'll also tell you my concern why I'm asking this question, because for a patient, if we talk about a normal diet, he would think that he can go back to a very unhealthy normal diet, or a normal diet in his perception being a normal diet, which would include a lot of deep fried foods, fatty foods, eating outside, fast foods, going and eating maybe a lot of simple carbs in his diet. So do we still describe
That's a very practical question. Lots of practical implication. When a patient is on pancreatic enzyme, then definitely a normal diet, which should include balance that. I'm not talking normal means they can go to any extent to eat the pizzas and burgers. So that's why the counseling and education is very important. I mean, just talking not to eat or to eat, this is not enough. That we should go that extra 2 minutes we should spend with the patient to educate them what is a normal diet and what is a balanced diet, and that's what they should stick on to. And if the patient is not on enzyme, even then, if we can tolerate a normal diet, sometimes some patient may not be able to tolerate fat, they get dyspeptic and they get, so in those you can do some tweaking. But if the patient can tolerate, then he, because see, the pancreas actually has a huge reserve. Like even though we talk about pancreatic exocrine insufficiency, the pancreas can work very well, digest the food very well, as long as it is 60 to 70% gone. So at many a time I feel the threshold of using enzyme is somewhat low in certain situations. So that's why I think a normal balanced diet, like saying the word repeatedly, balanced, can be given to any patient's blanket. If the patient takes pancreatic enzyme, definitely yes. Not taking enzyme, if you cannot tolerate certain specific component, that can be tweaked. But most important, educate the patient. They should understand what a normal is, and I mean they cannot make their definition of normal. So that is extremely important.
Yeah, thank you.
Yeah, thank you so much, Dr. Roopjyoti. Back to back, there is a second question for you. Nice presentation. I was very much impressed.
Thank you.
But my query is that you said that there is a certain strain of probiotics which is useful in a patients with chronic pancreatitis.
No, I mean, did I say no? I just told we had discovered, or we had shown that there is a significant reduction in that Faecalibacterium prosnitziae. So I'm not saying it's beneficial.
Right.
Number one. Secondly, Faecalibacterium prosnitziae is unculturable, so no probiotic preparation has that. Whatever probiotic we get in the market, it's just like few lactobacillus and few other strains. My concern with probiotics is we are just giving them a few strains. We do not know how long they colonize inside, how long they stay, how they interact with the other organisms. Because microbiome always work in group, not as individual, or they crosstalk very frequently. So by giving one certain organism what we are doing to the other commensals, we still do not know. Even it is prescribed in other diseases. In pancreatitis, we do not. And mind you, in acute pancreatitis, actually there was a study from the Dutch group. It's called the ProPatria trial. There was a very high mortality in the group which got the probiotic, and there is an issue with the strains. They have been done with some experimental work with that strain, and they had shown that there is a problem with the strain. So the jury is still out. We do not know if we use the right kind of probiotic at the right timing. That's extremely important. In future may be beneficial, but as of now, there is no role of probiotic either in acute or in chronic pancreatitis.
So that was, you stole my heart, that my question, that many patients with chronic pancreatitis, they develop recurrent acute attacks, or maybe there is a small bacterial, small intestinal bacterial over. Thank you so much.
Thank you.
Namaste, this is Dr. Daphne from Apollo Hospitals, Chennai. My question is to Dinesh. With regard to pre-transplant patients, what is your take on protein intake? We do talk about high protein diets, but in Indian setting, can you comment on how much are they taking? Do you have any data?
I mean, generally in our population, the protein intake is extremely poor because most of our diets are predominantly based on carbohydrates. But certainly, we need to encourage them to take high protein diet, as we mentioned, depending on their body weight, around 1 to 1.2 grams per kilogram body weight per day. But most of the time, they don't. They are not able to achieve that. But that's where we should try and sort of reiterate to them, continue to educate them. That's very important. And with regards to the source of protein, it's always pretty much debatable. Plant proteins are pretty much easily absorbable, and there are studies to show that they have better outcomes in terms of improving the symptoms and complications. So therefore, I mean, it has to be tailor-made for that individual patient. So your protein intake might be different from my protein intake from others. So it all depends how much what their cultural background is. So you have to go accordingly.
So in Indian setting, if we see, the baseline intake, because I have done research on liver transplant, we find that during baseline assessment, we find their intake is less than 50%. And as per my research, we found that if we are able to achieve more than 80% of their targeted protein, their life expectancy, that is post-transplant 1 year survival, improves by more than 7 folds. So, and same way with regard to the assessment also, if we are able to, improve their muscle mass, because I had assessed their hand grip strength, and we found that if their hand grip strength is less than 18.15 kg, their mortality post transplant 1 year survival was about 4 times higher if it is less than 18.5. So in the pre-transplant phase, as we assess and if we are able to intervene early, we were able to have a better outcome.
I mean, yeah, that's certainly it's sort of shown in multiple other studies. But have you looked at other confounding factors that interfere with the survival rates in your study? Like,
yes, of course, I had looked at child score, MEL score, all the series were looked at, and it was considered during the analysis.
I think most of the time, the clinicians and dietitian, we don't educate the patients much in terms of what they actually need to take. And I think that's a learning point. We need to tell them what to take, and we need to have a multidisciplinary approach to all this.
Exactly, a multidisciplinary approach, and from the initial phase itself, as they are evaluated, if we could have a stringent follow up, the outcomes get much better.
Thank you.
One last question. These days we are coming across a lot of I won't say patients with NAFLD, maybe grade 1 or grade 2. When they come to the dietitian, their BMI is absolutely normal. We look at their eating pattern, take their earlier history, diet history, and then we make an appropriate diet plan for them and tell them to exercise. Can you tell us a little more about what should be the exercise regime for such patients? Or what else can we add as dietitians?
I think exercise, physical activity is mandatory. So it should be, need not be intense. At least it should be a moderate physical activity. I would tell them at least, brisk walk on a daily basis, at least 4 to 5 kilometers, and at least 6 days a week. And also, there are a lot of studies coming on your core physical exercise, not just walking, not just running. So there are other parameters, other types of exercise you can do to improve your fitness levels, and it has to be sustained. See, if you do an exercise for a week and expect results, that's madness. Actually, you're not going to see results in a week's time. It's going to be sustained effect. Say, for example, the obesity and NAFL did not happen overnight. It happened over 15 years. So you should at least give 6 months to for your exercise and dietary regimens to work. And I strongly advocate many patients, almost all patients, to do exercise because most of the GI diseases are related to your sedentary lifestyle, like fatty liver, your inflammatory bowel disease. There are much bigger exercise is a much bigger role, not just in fatty liver, even in other diseases. Say, for example, it has been shown to change your bacterial flora in the gut. So there are multiple beneficial effects of physical exercise, and it should be definitely encouraged. And as I say, it need not be just one type of exercise. There are multiple exercise. So one patient came and showed me that he does exercise. I asked him, can he demonstrate? He said, like that. So that is not exercise. So it has to be, where you sweat out, where you'd see sort of changes in your heart rate. That's very important actually. So that sort of physical activity is important. Dharmesh can add on.
So I think you have asked this question to a guy who's a marathon runner. And what we must remember is, I think the programs on yoga are doing a huge disservice. And just a cue from what Dr. Dinesh just said, many people will come and tell me that, what is your form of exercise? They'll say, I do yoga. So I don't know what it means.
Absolutely.
So the exercise has got a specific physiologic definition. That definition must be fulfilled. If they want to do the yogic exercises over and above that, that is the way to go. The general definitions for the population at large is that now it has been pegged up to about 180 to 210 minutes per week. What we must also tell them that it's not just aerobic. The liver disease patient at least need to build their muscle mass. So stop using the elevators, take the stairs, go to the place of work on a bicycle if you can, though that culture does not exist in our country. Or at least if you're working in a large campus, you could, take a bicycle from your home to your office. So those are the things that you do. But what I find missing from the regimen that we give to our patients is the thing about the isometric exercise. So core strengthening, you could just use the Bisleri bottles as weights. So you don't need to, go to a gym and pump iron. You don't need to do that. So those are the things that are very important. And just something which was asked in the earlier question, most of the decompensated cirrhotics, they can be advised food intake ad libitum. We do not need to quantify what they are eating. So whatever they want to eat, they should be asked to eat. Some people have a reservation about animal proteins. That is not true. Only red meat should be avoided. If someone, say, belongs to Kerala and you ask him to take paneer, he would probably never have heard of it. So you ask them to take whatever they are comfortable with. The other thing that you commonly see in the nutrition prescriptions is about the fluid intake. So again, that is a myth. So oftentimes you find even the liver doctor is telling that you restrict fluids. That is fallacious. That is unphysiologic. Just think about it. So you should not be asking your patients to restrict fluids unless their sodium values have dropped to less than 120. But very often I see in the prescriptions that patients would be asked to restrict fluid when they have got advanced liver disease.
Thank you, sir.
Absolutely.
Dr. Zubaida Tumbi from Mumbai. I am an independent dietary counselor. I feel that when we see increasing prevalence of metabolic diseases and visceral obesity, there is this increase in fatty liver, the non-alcoholic fatty liver disease, and that too in children as young as 8 and 9. But the doctors, the friendly neighbor doctors will often tell the patient that you need not worry about this grade 1, grade 2 fatty liver. And I have in my practice seen that with 3 months, 6 months of regular counseling and follow-ups, they are able to reverse it. So I think doctors need to be sensitized that when patients have these show-ups in their ultrasound, they should tell the patient to mind their diets or be supervised by a clinical dietitian and get reversed, because these are often found to be, having, say, pre-diabetes or hypertension or higher triglycerides. Your comment on this?
First of all, ultrasound it has subjective variation. So grade 1 to normal, I would say if ultrasound something shows grade 1 fatty liver disease, probably you should just do some basic tests, LFTs or a fibroscan like that to see what actually what's going on. And also at that point there are no therapeutic drugs, there's nothing you're going to use. Still lifestyle changes will
Perfectly,
have to,
perfectly.
yeah,
That is
still
what we do.
lifestyle changes. So if the patient has obesity or abdominal obesity, it's better to exercise rather than going for ultrasound, finding out they have fatty liver and then exercise. Do you understand my point, where I'm coming from? So
No, the point here is not that we will advocate that. When we make the person understand the importance of good nutrition with lifestyle changes, with physical activity, exercise inclusions, the sleep wake cycles and all those things, sometimes the doctors will say, okay, just ignore it. There's no need to worry about it right now. And then you have also compounding, in evidence of your liver enzymes, your triglycerides. I mean, these are all there.
Yeah, I take the liberty here. I will take the liberty here as the organizing team. So I've gone from the fed to the fasting state very quickly. So I think we're the other way around now. And I thank the entire audience being here. I thank Dr. Dharmesh Kapoor for being the co-chair here, the chairman here, and Dr. Gomti, Dr. Dinesh, Dr. Talukdar, Professor Gilhardi, and none other than Dr. Ravi Maya. Professor Ravi Maya. Thank you very much for this entertaining evening. And I welcome you all to the gala dinner. Thank you. Can we just come in for a photograph, please?